You got to figure out the management versus you got to read every article in print. Nobody has time to read every article. But if you know what's going on in the disease, you'll see there's only one answer that's managing something going on in the disease. That's how you know the answer. It makes it so much easier.
And I'll see you at 4. And
Okay. Yeah.
we have a session.
No problem.
We can end it.
All right. Angelique. Oh, look at you.
Oh, so happy to see you.
Yes. All right, let's continue. All about sex all day. Let's go. Everything you want to know, we're going to talk about it. All right, let me get back to where we left off. Dr. Nagel. Dr. Nagel was a famous OB-GYN who came up with this thing, Nagel's rule. And he made a huge assumption. He said, well, a woman's menstrual cycle lasts about 28 days. And that was before they did all the studies around the nation and around the world. When they finished all the studies, they found out the menstrual cycle from beginning to end spans 21 to 42 days, but the average was 28 days. So his assumption became the actual truth. So that's how he became famous, okay? Because he could have picked any number of days, but he picked the exact number that they came up with around the world. All right, so 28 days is the average. So that's the number they expect you to use to evaluate any female. But the span is 21 to 42 days. So if somebody has menstrual cycle last 6 weeks, we still say that's normal, okay? And then menses are the days of blood flow. Vaginal blood flow lasts 3 to 5 days. Remember, you always want to know what normal is so that when they tell you something, then you compare it. Is this too little, too much, or right there in the middle? Okay. Now, by making a 28-day assumption, allows us to calculate what they call estimated date of confinement, EDC, meaning when is the baby due? First question any mother asks you if she has a wanted pregnancy, when's my baby due? Because women like to plan way ahead of time. Do I have enough time to paint the room, get the bassinet in there, get the lights fixed, get the walls done, or whatever else she's got planned? She has to have it done before that baby's due. Okay. So what you do, if a woman has a normal menstrual cycle, Bailey, I start with the first day of her menses. So this is January. So let's say she says is January 10th was the last first day of menses. Well, folks, the first day of menses, that means the first day of vaginal blood flow, is the first day of the cycle moving forward, but it's also the last day of the cycle that you just came out of. One day serves two purposes, which is why they like to ask that question. Before you would think, oh, it ends one day and the next day is the first day. No, the day you start vaginal bleeding, the next group of eggs are starting to develop now. One last time, the first day of vaginal blood flow is the first day of the cycle in front and the last day of the cycle behind. Everybody clear about that? All right, nobody should miss that question. So if a woman tells me her cycle, let's say her last cycle started January 10th. To figure out estimated date of confinement, you go forward 9 months or backwards 3 months, you end up in the same place. So if I add 9 months to January, I'm in October, 10th month. And then you add one more week. Why do you add one more week? Because 9 months is approximately 36 weeks and term pregnancy is 37 to 42 weeks, not 36. Okay. You might say, well, what difference does it make for 1 week? It makes a big difference. There was a study done, they call them late preterm deliveries. It means babies who were 7, 6, 5, 4, 3, 2, 1 day early. They followed them for 5 years. And after 5 years, that means kindergarten, over 40% of them still had neurological problems. You know what that means? That means something very important happens in the last week of term pregnancy to the brain. Man, we thought the brain was fully formed by 8 weeks, but something happens that last week. We have no idea what it is. That's why there's a lot of research trying to figure out what the heck is this. But when that study came out, they sent a note to every OB-GYN in America: do not deliver a baby early unless you have a medical reason. Because if you just deliver them now out of convenience, they can go back and sue you. If that child is having trouble in kindergarten, the mama said it's your fault for delivering him 3 days early. And remember, with children, they have up until age 18 to sue you for what happened 18 years ago. Okay? So that's the rule now. Do not deliver a baby early unless you have a medical reason. Then it's justified. Because I remember when I was a resident, the OB-GYN said, you know, I'm going on vacation on Friday. Let's get this baby out of here. You can't do that anymore. Okay? All right. If the woman's menstrual cycle deviates from 28 days, you add or subtract the variation at the end. Do not do it at the beginning, because then you got to take into consideration which months are 30, which months are 31, which months 28. And then is it a leap year or not a leap year? Don't do that. So let's say she has a 33-day cycle. That means she varies by 5 extra days. Everybody follow me? So the same woman I just did, I take from January 10th to October 10th. I add 7 days, October 17th. That would be for the normal female. If she has a 33-day cycle, I add 5 more days after that. So now it's October 22nd that she's due. Any questions on that? They either give you a normal one or slightly abnormal one, but you have to know how to figure out estimated date of confinement. If you've been on an OB rotation, anybody been on OB rotation yet? Anybody? Just one, 2 people? You know that circle that you're always spinning? That's how it's Nagel's rule is dependent on. Okay. All right. But just so you know how to do it in your own mind. Okay. Some rules about pregnancy. Number 1, term pregnancy is 37 to 42 weeks. If you're before 37, we say preterm. If you're above 42, we say post-term. Average birth weight for a baby, 2,500 to 3,500 grams, which is 5 to 7 pounds. That's over 70% of babies fall in that range. Preterm, birth before 37. Post-term, birth after 42. And that's different from SGA and LGA. SGA means small for gestational age. LGA means large for gestational age. So let's do one at a time. How do I know you're post-term? First thing that I know, the best clue that you're post-term is dry Wharton's jelly. What is Wharton's jelly? This is the jelly in the umbilical stump. Within the umbilical stump, you have 2 arteries and 1 vein. Umbilical vein, 2 umbilical arteries. If I have any variation of that, like 1 artery instead, or 2 veins instead, 60% of those babies have a congenital heart disease that you have to worry about. And the way I make sense of that is because the heart and all the vessels develop at the exact same time. So that means if there's a mistake one place, there's probably a mistake in the central area as well. Just so you know, all those babies have to have an echo. Okay? That's just a rule. But dry Wharton's jelly knows what day it is. It says, hey, it's 42 weeks. And it starts to dry up. It starts to look like jelly. It was clear water the day before. So Wharton's jelly, the fact that it's jelly means it's beyond 42 weeks. That thing stays just clear liquid till 42 weeks, then it starts to harden, which means after a while, it's going to clamp down on all 3 vessels. The baby will suffocate and die inside. Just so you know why an OB-GYN gets nervous when it's around 42 weeks, the baby and mom doesn't even have cramps yet. You're worried. So what prostaglandin gel can I use to induce labor at that point in time, Solange? Before we tell the husband what to do. That's plan B. Husbands love plan B. All right, but we got to do plan A first. The plan A, which prostaglandin? What's the E2 analog? What's the name of it? You are correct. No, dinaprostone. Birthing is a dynamic process. So dinaprostone is the prostaglandin gel we use to induce labor. Or you can ask the husband to have as much sex over the next 24 hours, ejaculate as many times as you can inside a vagina, and his prostaglandin F will induce the same labor. All right. All right. So those are 2 options. But Wharton's jelly says you're definitely post-term. So if they ask you what's the best clinical finding for post-term, this is it. Not dry skin, curl up nails, hair growth, all those are great, but they're not the best answer. All right, that's post-term. Next one, SGA. If you have small for gestational age, there's 2 types, symmetrical and then asymmetrical. Asymmetrical is also called head sparing, which means head circumference is normal, but everything else is shrunken. The number 1 cause of SGA overall, Chris, it means the baby's not getting enough nutrition. Where does the baby get his nutrition from? Mom's umbilical arteries. Well, umbilical arteries was coming from mom. Everybody understand that so far? If the baby's not getting enough food, it means the vessels are constricted. What do you call it when mom's vessels are constricted? She has what? No, what disease do you have when your vessels are all constricted? All of them. It's called hypertension. That's how to remember that. That's how you talk it out again and come up with the same differential. Hypertension is therefore the number 1 cause of SGA. But that hypertension, Chris, causes asymmetrical SGA, head sparing. Why is that? Whenever you don't have enough nutrition, what's the most important organ? The brain. The body will shunt all the nutrition to the brain, sacrifice everybody else. That's why head circumference is still normal, but the rest of the body shrunken. But at least now you know why. Don't just memorize it because I said it. I want you to understand why, in case they ask you to explain it. All right. Lack of nutrition, the body protects the brain, sacrifices everybody else. Okay. So hypertension is the most common overall, but that's the pattern you get. What about symmetrical SGA? Everything is shrunken. Most common cause, chromosomal abnormalities. A part of your body can't outrun the genes. It's the same genes for every part of your body. So as I remember, and it could be any chromosomal problem. We've never seen the answer be two different ones. It's always a different one. Yeah, short armor 3, long armor 7. I don't care what they say. Just tell you, so I need an answer with chromosomal problem. You'll see the answer. It's always going to be a different one all the time. Stop caring which one it is. Just click that answer. Chromosome problems number 1. Torch number 2. Remember I said, always focus on most common. I've shown it to you. Test after test after test. Doesn't matter what test you're taking. Focus on most common. Your score will approach 90 percentile. Start doing something else. Now you're sacrificing points. Okay. All right. So that's SGA. Any questions on SGA? So symmetrical, chromosome problems, torch infection number 2. Asymmetrical, hypertension from mom. What about LGA? If you got LGA, large gestation age, it means the baby's eating too much. Why would the baby be eating too much? All right, that means mom is sending over too much nutrition. So we call this infants of diabetic mothers. IDMs, what we call them in peds. LGA, most common cause, infant of diabetic mom. Mom is diabetic, the baby's being fed too much sugar. Now I'm about to take you through about 20 complications of infants of diabetic mothers. Follow my story. That's how I remember all of them. I just kind of think of what's going on as bad baby's coming out. Okay. Infant of diabetic mom. So what's happening? Mom has hyperglycemia. It goes up like this. Everybody follow? That means mom has to chase with high insulin like this. Everybody follow? That insulin will push that glucose across to the baby. Now the baby sees high glucose. That means the baby chases with high insulin and it pushes all that glucose into his body, which is why macrosomia, number 1 complication. Does that make sense to everybody? Big baby, right? And if the baby is big, what you're going to get? A lot of preterm deliveries. Because the baby gets so big, he descends the uterus way too early. Hey, there it is. Get out of here. Preterm labor is the norm. The last time I looked this up, that was a few years ago, so I don't know if it's changed, but 32 weeks was the average gestation for infants of diabetic mothers. They rarely ever go to term. Okay? Preterm deliveries. Now, if you got preterm deliveries of a big baby, what are you going to get? Hang on. Preterm delivery. Clavicular fracture. So you're going to get clavicular fractures. No, before I do clavicular fracture, you're going to end up doing more C-sections. Why? Because some of them are on their way out. Also, no, we got to realize this baby's not going to make it. And then he gets stuck, and then you got to get him out real fast. So there's a high incidence of C-sections and infants of diabetic mothers. And then from there, the ones who can actually come through, they have a lot of clavicular fractures. The most common position for coming out is left occiput anterior. That means the left side of the back of your head will present first, because the baby's coming out like this. All right, with arms folded, so he just slides right out. Left side of his head will present to you first. That's how I remember that the left shoulder presents first, so left clavicle is the most commonly broken. Why is that happening? It's called CPD, or shoulder dystocia. Let me just use that term. Shoulder dystocia, which means the baby is too wide to come through the vaginal canal, which is the narrowest area. How do we know the baby is too wide to come through there, Gloria? It's something called a turtle sign. Turtle sign says his head is on the way out like that, you know, and then all of a sudden he gets caught on the pelvic bone and comes right back in. You're like, come on, mom, push harder than that. And the head's on the way out, right back in. Like, dang, mom, how you doing that? Anyway, it looks like some tricks he's doing. The baby's stuck. That means his shoulders are caught on her pelvic bones. And that's why the shoulder catches, snatches it right back in there again. It's called a turtle sign. Whenever that happens, we do what we call it McRoberts maneuver. That's what we do 99% of the time. Don't worry about the other 2 maneuvers. I've never seen them tested. They want you to know the one that almost every doctor does. McRoberts maneuver. says if I'm working with the OB-GYN, I was working with a female. So she takes one side, I take one side. So she normally took the left side because she's right-handed. So if you're left-handed, you take the right side. So because what you're going to do is pull on the thigh to widen the vagina, and at the same time, push down in the middle right here. That way you're guiding the baby's head straight through. Maybe slide right out and somebody's there to get it. McRoberts maneuver. Okay, because remember, it's the baby who's trapped. So as you stretch the vagina, his shoulders now can come right on through. Now, it sounds like it's painful and cruel that we would do that to a female. Wait till later. I'll show you why it's even possible to do that. Okay, but that's what we do. All right, so shoulder dystocia. Any questions so far? All right, so from, pen's in my pocket. I was like, what did I do with my pen? All right, next thing, from clavicular fractures. Oh, let me talk about that. Left side is the one that fractured 90% of the time just because it's the first one to present. And it's usually in the middle 1/3 of the clavicle. Just has to do with physics. If you bend the bone, the middle would break first. So it has nothing to do with the baby, just physics. Any questions so far? How do you know to suspect it? It's asymmetrical moral reflex. As soon as the baby comes out, he feels how cold it is in that room. Woo! Both arms should abduct symmetrically and recurl symmetrically. But you notice only one arm went out. He doesn't want to move this one. It hurts too much. So anytime you get asymmetrical moral reflex, you got clavicular fracture until rule otherwise. Any questions on that? So anytime you feel that, what you do is examine the clavicle, starting from the shoulder and follow it all the way to the sternum. And you feel a crunch, wherever the crack is. That's called crepitus. So they'll describe crepitus by midway or crepitus near the sternum, crepitus near the shoulder, whatever. But you got crepitus, you got a fracture. What do? Orthopedic consult. You want the orthopedic surgeon to follow along with you. All right, orthopedic consult. What he does is, the first thing you do is do an x-ray. The reason why you do an x-ray is to make sure that the bone is cracked. If the two are still aligned with each other, but separated like that, they should come back together with no problem. Remember, the baby is rapidly dividing for the first 2 years. You see them just come back there like nothing ever happened. But the key is they got to be aligned. What if they're off alignment? See that? And you don't straighten them out. You're gonna have to do surgery now. That's why they want orthopedic surgery to follow with you. All right. So X-ray shows alignment. We no longer do the figure 8 strap. Remember, we used to do that and hold their shoulder like that, so it would align it better. They did a head-to-head randomized trial. Figure 8 strap, no figure 8 strap. It was exactly a 92% reunion rate on both sides, which means figure 8 straps do nothing. So we don't do anything else anymore. It's just watch. It will repair itself. Everybody follow? But the complications. If the bones are misaligned, they tend to point downward. If they point downward, right underneath the clavicle is your subclavian artery. If that piece of bone rips the subclavian artery, you now have a subclavian artery aneurysm. That's not good. That's the blood supply to the entire arm. If you have an aneurysm, it can clot off. So what we do is when you feel crepitus, they'll say, what's the next step you manage it? Listen over the crepitus. If I hear any kind of bruit, it means there's an aneurysm already developing. Next step would be arteriogram to identify it and take them straight to vascular surgery. Why? Because if you miss that, an aneurysm is dilatation, right, Chris? See? Dilatation, what happens to flow when you dilate a vessel? Increase, what happens to velocity? Decrease, you have stasis within every aneurysm. That means it's going to clot off if you leave it alone. So if you miss it, that whole arm may clot off. Next you know, you find yourself having to amputate the whole arm. How do you apologize to a mom for that one? Because that kid's life has totally changed now. He's missing an arm. So that's why they say, listen, don't miss this one. Okay? Any questions on clavicular fractures? Any questions at all? Cool. All right. After clavicular fractures, brachial plexopathies. That's herbs and clunkies. Herbs, nerve root, C5, C6. So if they just want to make an anatomy question, that's all they'll ask you. What nerve root is involved? C5, C6. So the top of the brachial plexus. What do you see on exam? Because I'll ask you, how does it present? Or on a lot of times they just tell you the physical exam. You got to make the diagnosis for yourself. You'll see arm fully extended, forearm fully extended and internally rotated. Remember the waiter's tip. Arm, forearm fully extended and internally rotated equals Erb's paralysis. Nerve root, C5, C6, the top of the brachial plexus. What do you do for that? Again, orthopedic consult. Okay. Orthopedic surgeons control occupational therapy because this baby's going to need occupational therapy and physical therapy until this thing resolves. How long does it take to resolve? Remember, nerves regenerate at the pace of 1 millimeter per day. That's the number they want you to know. Well, 1 millimeter per day, that's a long distance to go from your shoulder all the way out to your fingertips. It's anywhere between 12 to 24 months before it resolves, but it completely resolves. The reason for you understanding that is because mom is going to say, how long do you think it's going to last? You can't say, oh, just a couple of months, oh, just a couple of weeks. It means you don't understand. Because a month, 2 months will go by, and now she's pissed off at you. You said a couple of months. No, it may take up to a couple of years, mom, but it will fully resolve. But we will be doing physical therapy and occupational therapy with your baby because you got to keep exercising all the joints, every joint, every day, so that everything still moves when it finally resolves. Otherwise, they'll get a contracture. Everything's frozen now. Now you got to go through multiple surgeries to break, cut muscles, break bones. And mom's not going to be happy about that one either. Okay, but physical and occupational therapy takes care of it, fully resolved, 12 to 24 months. Any questions on that? Next problem, complication. Go ahead. Okay. Go ahead. Since I stopped now, you might go ahead. Okay. Yeah, everything will fix itself, right? It's contractures we're worried about. If they're stuck in one position and you don't exercise, they'll be stuck there. Okay. The other complication we're worried about with the Erbs, C5, remember 3, 4, 5, there's your diaphragmatic nerve. It's called hemidiaphragmatic paralysis. That means half your diaphragm is now paralyzed. How do you know half my diaphragm is paralyzed? It's called paradoxical movement of the stomach. When you breathe in, your belly should go out because the diaphragm should push everything down. Everybody understand that? When you breathe out, it should go back out like that. But you're going to see half your abdomen doing that. When you breathe in, only one side went out, the other one went up. That's because this one is getting sucked into the vacuum. So he's just moving passively. And that's called a paradoxical motion in the abdomen. So paradoxical breathing is going opposite of what you expected. That person has a hemidiaphragmatic paralysis. Because of severe distress, they have to be on a ventilator. It may take, again, 12 to 24 months for it to heal up, but it does completely heal up. All right. But again, you got to make sure you educate mom. Usually neurologists are coming to talk to her about that. So let her know it will completely resolve and your child will come off the ventilator and be fine. But if your phrenic nerve is paralyzed, there's going to be a lot of distress. So phrenic nerve neuropathy. Any questions on that? All right, so now you know how to recognize it. What about clumpies? Clumpies, first thing, nerve root, C8T1, the bottom of the brachial plexus. C8T1, the bottom of this brachial plexus. Ulnar nerve comes off of there. And that's why, remember, you get ulnar, no, was it, what's the word that they use? Claw hand. Ulnar nerve is paralyzed, but you can still use these fingers. It looks like you're making claws with your hand. So claw hand, clumpies. So claw hand, clumky. So sounds real familiar. All right. Again, orthopedic surgery consult. Again, physical and occupational therapy. It completely resolves. That one luckily has no big complications that we have to worry about. All right, Adonis, you have a question?
Yes, doctor. Regarding the Erb's paralysis, you said the paradoxical breathing was due to that?
Yeah, correct.
Oh,
so
okay.
That means when you inhale, the side that's paralyzed will move up rather than down. And then opposite
okay.
when you
Thank
exhale. Yeah. All right, now, when the baby is born, let's go to metabolic problems, Abigail. The baby is used to seeing high sugar from mom, right? So the baby is used to putting out high insulin to match it. Everybody with me so far? But when the baby is born, mom's glucose disappears. But the baby still has high insulin. Takes time for it to go down and go away, right? So first day, hypoglycemia is a big problem. Hypoglycemia is a big problem the first day. So any symptoms on the first day with a large baby, always pick hypoglycemia because it could be a lot of things. There's nothing for me to point out. All right. That's the first day. What do? Start feeding as quickly as you can. Milk has sugars. They can take care of themselves. We don't have to inject the baby with glucose. We try to avoid that. I mean, if we have to, we do it, but it's just start feeding as early as you can. Remember, as soon as the baby's dried off and mom is ready, you can start breastfeeding right away. There's no time span you have to wait. Okay, so easy to take care of itself. But then some babies, because their islet cells have been so stimulated by hyperglycemia, they have grown new islet cells. You guys remember that term? Remember that term? Cynthia? Nesidioblastosis. Overgrowth of islet cells. You got too many islet cells all over your pancreas. So how do we know this? Your insulin is high. What about your C-peptide, Bailey? It'll be high. That's how you know. They're hypoglycemic, and then you check your insulin while they're hypoglycemic, you see sky high insulin levels, sky high C-peptide levels. And that's how you know you got nesidioblastosis. Nesidioblastosis requires subtotal pancreatectomy. You're gonna have to take them to surgery and cut out some of those islet cells. In the meantime, I can give you a drug that can block insulin. What drug do you know that can block insulin, Anders? And what drug do you know can block any hormone or neurotransmitter except GABA? Yeah, so octreotide. No, you had it right. Stop hesitating, though. So octreotide, I told you somatostatin can block everything. So here's another time we use octreotide. That's it until you're taking the surgery, because you don't want all that insulin coming out until you take the surgery and cut a bunch of those cells out. Okay. All right. On the second day, so hypoglycemia, I told you they're asking a lot of mechanisms now, is due to transient hyperinsulinemia. Remember, the baby's had high insulin for months, and now you got to wait for it to drift downward back to normal. All right. The second day, they get hypocalcemia. Why do they get hypocalcemia? Because the parathyroid arteries, Ashley, the parathyroid arteries are so fragile that their high viscosity of hyperglycemia rips them up. So you get transient hypoparathyroidism as your reason for this. So the two big metabolic problems on day 1 and day 2, respectively, hyperinsulinemia, hypoparathyroidism. It's transient, goes away on its own. How do you treat that one? Encourage more feedings. That's it. Milk has calcium, so you don't have to worry about it. Yeah, so milk takes care of the hypoglycemia and hypocalcemia, but they'll actually explain how did the baby get it. Solange? It's a relative hypoparathyroidism because the viscosity of hyperglycemia rips those arteries. So the body just needs time to repair them. Mabel, question?
So please, what did you say about the cause of the hypocalcemia?
Hypocalcemia is transient hypoparathyroidism. Is the high viscosity of hyperglycemia ripping up the parathyroid arteries. So the body just needs time to repair it. Question, Karis? Nesidioblastosis, her question just means too many islet cells because it's hyperplasia of islet cells. Yeah, that's all it is, the reaction that happened in utero to so much glucose to help the baby out. Yeah, and so we got to go in and cut some of those cells out of it. Any questions so far? All right, now, hyperviscosity. If you have high viscosity, Justin, what happens to flow when your viscosity is high? Flow decreases. Which tissues are going to be affected first? The proximal tissues or the distal tissues? The distal. Does that make sense to everybody? So if we go to the brain, since it developed first, you're going to have what we call sacral agenesis. Notice the distal part of your spinal cord. So sacral agenesis is a big problem for these babies. It's based again on high viscosity. So distal blood flow is sacrificed. So the sacrum, if you remember, the sacral plexus does lower extremities and then anus and bladder So that means the child's legs won't work very well and he's incontinent for urine and stool. That means they wear diapers for the rest of their lives because there's no way to fix it. Sacral agenesis. Any question on that? S1 starts at your Achilles. S2, a band of skin from the Achilles to your buttocks, and then 3 circles around your anus is 3, 4, and 5. Hopefully everybody still remembers that. Okay? So sacral agenesis is a big problem. Where is the watershed area of the GI tract? Adnan. Huh? Watershed area of the GI tract. I heard ileum, that can't be it. Not ileocecal either. Gloria. Splenic flexure is number one. Rectosigmoid is the other one. So that means, listen carefully, they have what we call small left colon syndrome. That's atrophy from the splenic flexure down to the anus because it doesn't have enough blood supply. All right. So small left colon syndrome. It means they're going to have trouble with constipation all their lives, but we don't remove it because it still works. Okay. But it means they got to eat plenty of vegetables every day with their meal, vitamins, take water, drink a lot of fluid, laxative if necessary. They just learn to adapt and that's it. Okay. But they'll ask you why that colon is so small is because of the watershed areas. Any questions on that? Okay. So notice, therefore, when you look at all the problems, you just follow the story, and then all of a sudden you can remember the whole thing. So infants of diabetic mothers, a lot of problems. The second problem for LGA, the second problem that causes large for gestational age is twin-to-twin transfusions. First of all, they'll ask you how this is even possible. Twin-to-twin transfusions. For you and I to be fighting over the same blood supply. Sabu. Are we attached to the same placenta or 2 different placentas? We got to be attached to the same placenta. So they're just making an anatomy question. That means we got to be monochorionic. There's no other way for that to happen. And if we're monochorionic, Sabu, are we identical twins or fraternal twins? Got to be identical. See, they're just making an anatomy question just to see if you knew that part. Okay. But let me tell you a little more than that. All right, so let's say myself and Sabu were twins. Anything is possible. So, so it's easy to make the diagnosis. Why? There's one big twin, one tiny twin. As it works out. So we're attached to the same placenta. So one day I just feel like grabbing all the blood away from her. So I just sucked the blood my way. She said, no, give me some of that. I said, no, I'm bigger. Give me that blood. So now what do you see on ultrasound? One big baby, one small baby. Easy diagnosis to make. That's a twin-to-twin transfusion. Anybody follow? Sabu, question for you. What's the most common cause of death for that small baby? Cause of death is not ischemia. Thank you very much. All right. What's the most common cause of death for the large baby, Maria? Say what? Say it again. Thank you very much. Why hesitate at all? Okay. Remember the question we saw with Frady's attack. What I tell you before we read the thing, I said, what's it going to be? In case you don't know, just say heart failure. But by the time we finish, well, respiratory failure is number one. Then but look what they test writer put, heart failure, just to see if you're going to change your answer. All right, but anyway, both of them die of heart failure. Severe anemia causes heart failure, polycythemia causes heart failure. They both die of the same thing. So what happens? 50% of the time, one baby dies. 30% of the time, both of them die in utero. That's a high number. So that's why monochorionic twins, you got to have a perinatologist follow the whole time because a lot of problems can go wrong. A lot of, you can twist around one person, you can hang the other one by twisting the cord around their neck. Oh man, it's bad. All right, so anyway, twin-to-twin transfusions. What do we do? All right, so I'm going to do when one baby dies, and then I'll do when both babies die, which is equivalent to a mother with one baby, and that one dies too. As long as there's a living baby inside of a uterus, folks, key word, living. As long as there's a living baby inside the uterus, there's a wall that builds up. There's a virtual wall, not a real wall. There's a virtual wall. Why? That separates me, the baby, from mommy over there. I gotta save myself from mommy. She's a little crazy these days, man. Eh? Why do I have to save myself a mommy? She says she loves me, but she says she loves me. Eh? She said I got her eyes. She says I'm such a cute baby. What's me? Why do you think she's trying to kill me? Her immune system is trying to kill me. That's why we have a wall. Why must I protect myself from mom's immune system? If I look just like her, I got features just like her. Why is she trying to kill me? Nah. Mom drinking too much, smoking a little weed. What? What's going on? Why is mom trying to kill me? Not protecting herself. I'm not attacking her. She's attacking me. There's something you gotta connect to. Chris, 50% is dad. Dad is a foreign antigen as far as mom is concerned. See, something so simple, but you've never thought about it. Huh? It's dad's genes. Mom has never seen dad's genes inside of her. She's gonna tag it as a foreign mass. Everybody understand? That's part of the reason for spontaneous abortions. Sometimes it does happen. Just destroys it. That's it, gone. Okay? So that's why a virtual wall must go up. And as long as the baby's alive, that wall stays up. If the baby dies, so I'm going to say, let me go in order. One baby dies. If one baby dies, there's still one baby who's alive now over here. Everybody follow? That wall stays up. As long as it's a living baby, wall stays up. So what do you do when one baby dies? You tell mom one of her babies died, but we're not going to do anything about it. Why? Because her immune system can't even see that somebody died over here. Everybody follow? There'll be no inflammation, no nothing. All we do is let the other baby go to term, and then after you deliver the living baby, now deliver the dead baby. The reason why we do that is if you try to do anything with the dead baby, you end up killing the other one too. If you try to get a needle, anything, you pop the sac, that's it. The other one's aborted now. Now she's lost both babies. And that's why we stopped trying. Okay, let her have at least one living baby. Okay, but it poses no harm. No infection rate, nothing. Because her immune system cannot see what's going on over there. Any questions on that? Every rare moment, that dead baby actually gets resorbed by her system. It's only happened like, 1 in a billion babies. We don't know how it happens because her immune system is not supposed to see anything. And yet the baby got resorbed. Some experts think maybe the other baby ate him. I don't know. I doubt it. But which means the immune system can be selectively going there. And I don't know, folks. I can't even explain that one. If the immune system is not supposed to go over there, it doesn't go over there. But who ate that baby? Well, it's the immune system. But we don't know how the immune system get over there and attack that baby without attacking the other baby. You ate your twin? Oh, you were twins? You were one twin? Oh, girl, we gotta have a conversation. What you doing eating twins? Really? No kidding. Yeah, well, that's what I'm saying. It's a rare event, like 1 in a billion, 1 in 2 billion, I don't know. But it's rare that happens. Normally, the baby is still there at term. You deliver the dead baby afterwards. All right, question. Honor, you're first. What if what? So if they convert this an ethics question, what would be the ethics question? Yeah, how would you disclose this information to mom? It's just about knowing how to be considerate and compassionate as you deliver bad news, because it's still her baby died. Yeah. Oh, you have to tell her. No, yeah, you can't hide it from her. You got to tell her there's a dead baby inside. Okay. Yeah, and Melissa, you're next. Somebody in her family was pregnant with twins, and the woman was told that both of them are going to die if she doesn't pick one. Yeah, that can happen. That's how I said you have to have perinatologists following them. They do weekly ultrasounds, watching what's going on. So it may get to a point where he's thinking, okay, this one is moving too much, which means he's going to strangulate the other one. And then the other one may die. And so he may think, well, we need to sacrifice one. All right. Yeah. So you end up with both twins living. I don't know how they were going to sacrifice one versus the other. That's kind of hard to do. But the only way to do that is from outside. You're going to have to do it with a needle. That way you go wherever that baby is, and there's a certain way they can poke them, and that baby will die without disturbing the other baby. Yeah. All right. So Where are we? Oh yeah. So that's if one baby dies. You tell the mom, but you tell her we're going to leave the baby in there because we want you to have the other one. That way she understands why we're not going to do anything about a dead baby. All right. Second scenario, both babies died. Or in the case of a singleton, meaning one baby, that baby dies. Then that wall is going to start coming down. But you got about 24 hours before it comes down. So that's why when that happens, what do? We help mom deal with the loss because she's lost her babies. That means make sure her husband is around to comfort her, a preacher, her rabbi, whoever that she needs to comfort her, because she has to accept that the baby's dead before we do anything. And like I said, if you're compassionate with somebody, they're going to accept it within minutes. But we give them a few hours, just relax. We got 24 hours. You don't have to rush. Okay. So by the next day, though, you want to get her okay, that we need to get this baby out of there. What do we do with that one? That's when we use misoprostol, okay, and start pushing the baby out of there. Okay. Or you can use even dinoprostone if you want, because the baby's dead anyway. It doesn't matter which prostaglandin you use, but you go ahead and deliver the dead baby. Okay. All right. Then the last question I'll ask you about this is, how do you detect when you have fetal demise? The best way to know that a fetus just died is estriol levels drop off within a couple hours. Estriol. Estriol can only be made by the placenta of a living baby. That's why as soon as the baby dies, that's it. The placenta stops making estriol. That's how we know that baby's now dead. Obviously, we still verify with an ultrasound, but the baby's dead once estriol levels start falling. All right, any questions on LGA? All right, cool, moving on. Nagel's rule also allows us to divide the menstrual cycle, Cynthia, into 3 distinct periods of time. The first period, days 1 through 10, that's called prolific phase, main hormone controlling estrogen. Second period, 10 to 14 days, called ovulatory phase, main hormone LH. Third period, 14 to 28 days, luteal or secretory phase, main hormone progesterone. You understand, Cynthia? You understand, Angie? I don't think you guys understand. Check this out. That means if you tell me what day it is, I'll tell you what's going on. I'll tell you what hormone. You tell me what's going on, I'll tell you what day, and I'll tell you the hormone. You tell me the hormone, I'll tell you what day, and I'll tell you what's going on. Folks, come on, they got so many questions all over the exam, and students miss so many of them because they're not organized like this. If you're organized, they're all easy questions. Now, here's where I see students making a mistake. Listen carefully. They start describing, they'll do a cervical mucus, uterine curettage, and they say they saw proliferation of a bunch of hypochromatic little beady-eyed circular cells with some blue stuff on the side and then some other red stuff in the middle. Man, they go on and on. That's the problem. You guys read way too much. I stopped after I saw proliferation. I said, I don't want to know anything else. The question says, what hormone is wrong with it? I'm done already. That's what I'm saying, folks. Know your key words. The test writer has to use them. He has to use them. It's only if you understand it very well, you understand he's giving you the answer. And you don't have to read the whole vignette at all. Stop at proliferation. Stop at ovulation. Stop at secretions. See that? Do I care what you're secreting? No, I saw secretions. That's good enough for me. That's progesterone. I don't care what the rest of the vignette says. Okay? It makes it so much easier. Now, what organ in your brain controls time? Melissa? Who? Why do you say pineal and then I don't know? You don't have to be sure. Just say it though, but don't say I don't know right afterwards. Because then if you're right, you get 0 points in the mind of the attending. Just getting you ready for rotations coming up. You got to just say what you think, but don't take the credit away from yourself by saying, I don't know right after that. Because then if you're right, the attending says, you're just guessing. You don't get any points. Okay? It's already hard enough to impress an attending, so don't take away the times when you actually did. Abdullah Khan.
Yeah, I just wanted to tell you we're twins too.
Oh, you're twins too? Did you eat your brother?
Nah, he's still in
No.
class, Mohammed.
Nope, I'm right here.
Oh, your brother's right there with you?
Yep.
No kidding. Oh, Abdullah Muhammad Khan.
You
I didn't
meet
know.
me
I
yet?
thought 2 different guys. Oh my God, look at that. We got twins in the class. That's awesome. What's that? Yeah, turn your cameras on. Turn your cameras on. All right. There we go. That's Abdullah. Where's Muhammad? Muhammad, put on your camera. Yeah, there. You can tell them apart though. You guys identical twins? You're muted, Muhammad. Are you?
So we're fraternal.
Oh, fraternal. I was gonna say, yeah, I can definitely tell a difference in their faces. Yeah. Okay. Yeah. So anyway, pineal gland. Stop bothering Mabel. We'll meet Mabel at the end of the week. Yeah, we got to get to know Mabel. She's been a sweetheart the whole
What
time.
happened?
Don't worry, Mabel.
Mabel is a ghost, man. Don't worry.
Don't worry, Mabel. You'll be our star on Friday. Okay.
It's a ghost baby.
Yeah. No video yet. Wait till Friday. So anyway, pineal gland tells you what day it is. Remember, in the morning, it uses serotonin. In the evening, it uses melatonin. Serotonin is made out of what amino acid, Abigail? Tryptophan. And melatonin is made out of what amino acid? Maria? No, it's still tryptophan. Remember, they're both from the same molecule. Melatonin, serotonin, you can tell by the name. All right, but anyway, it turns out, folks, that the one that's most fixed for every woman is a luteal phase. That means, what is it that every woman in this class has in common? A luteal phase of 2 weeks. If they ask you which phase varies the most in any 2 women, is a prolific phase. So if a woman has a 30-day cycle, a 35-day cycle, they'll ask you, well, which one varied? Just add it prolific, don't add it to anything else. You understand, Abigail? All right, so let's say I want to figure out when Abigail ovulates. All I got to do is ask her, hey, Abigail, just tell me how long your menstrual cycle is. I won't tell anybody else. Whisper. What is it again? Anyway, so let's say she tells me it's 30 days long, right? All you do is subtract 2 weeks, and that's what day she ovulates. Real easy. So if she's 30-day cycle, subtract 2 weeks, what day does she ovulate? 14 and 14 is 30. 16 and 14 is 30. So anyway, so she ovulates on day 16 of her cycle. Everybody follow? Now, who the heck wants to know when they ovulate? 2 questions they'll ask you. One question is the woman who doesn't want to get pregnant. See that? She needs to avoid having intercourse during that time. An egg, when it ovulates, goes in fallopian tube and can stay there for up to 72 hours and then melt away. An egg can live in the fallopian tube for 72 hours and then dissolves. Gone. So that means if she doesn't have sex during those 72 hours, then she shouldn't get pregnant. Everybody understand? This was the basis of the rhythm method. As you knew, the rhythm method was not that good. It was only 70% at best in a couple of studies that I saw. 70%. That's not good enough. But the rhythm method is used a lot in the Catholic Church, and I'm Catholic. There's a faction who doesn't believe in birth control at all. They think birth control is abortion. Now the Pope has come out and said, no, it's not. Okay, to make it okay for them to use birth control if they want. But for a long time, they said, no, birth control is abortion. How do I know who's using rhythm method? You see him in the pew, mom, dad, and you see about 7 kids. 8, 7, 6, 5, 4, 3, 2, 1, and she got one right here. Okay, that's how effective it was working. It ain't working. Okay. They have a lot of babies. 1 year apart, just kept having babies because the rhythm method does not work that well. 70% is not good enough. All right. So then somebody said, what if I take these 3 days, I put 2 days after it, put 2 days before it. What if you avoid sex in those 7 days? Pregnancy rate, less than 1%, equivalent of birth control pills. Now, I'll talk about birth control this afternoon, but just in case you got a person who doesn't believe in any hormones whatsoever, that's what you teach them. It's equivalent, less than 1% chance of getting pregnant if you avoid these 7 days. Just find out when she ovulates, 3 days. So ovulates here, 3 days of the egg, just 2 in front, 2 behind, still 7 days. Avoid intercourse is equivalent of hormones, except there's no side effects, there's no DVTs or PEs to worry about. And that's what's being used in the Catholic Church. I was so happy when one Sunday I was at church and they were talking about, I said, hey, wait a minute. Hey, I know what you guys are teaching. Because Catholic Church is not that progressive. I was shocked to hear it. I said, whoa, okay, this is good. This is good. Catholic Church is becoming more progressive. The Pope finally came out recently and just says, oh, it's okay to love the LGBTQ community. You know, the Catholic Church has never said that all these years. Now I have family members who just gave up on the church altogether. But I remember somebody taught me, it was I think she was my 6th grade teacher. She taught me years ago. She said, religion is personal. She said, you're not going there to, praise the people who are in church. It's you and God when you're praying. And I always remember that. That means even though I disagree with a lot of things Catholics do, I'm still a Catholic. That means I choose to do what I think is right. And that means whatever religion you are, same thing. You can't say your religion is perfect. Nobody in your religion, everybody in your religion cannot be perfect. Just like I don't think everybody Catholic is perfect either. Okay, but I was so happy to see we got a very progressive Pope who's finally said it's okay to love people because they're different. But for a long time, Catholics just, oh no, we don't want them in our church. And same thing with Baptists. Oh, we don't want them in our church. Oh Lord, it was crazy. But I kept thinking to myself, I don't remember any time Jesus Christ said it was okay to hate somebody. I can't find it in the Bible at all. That's man always expressing his hate for something. You can always find a reason to hate somebody. That's easy to do. All right, Cynthia. Right. So 30 days, subtract 2 weeks. That means day 16 when she ovulates. That means the egg can live day 16, 17 to 18 in a fallopian tube. Then you add 2 days after that. That means 19 and 20. 2 days before that. So 14 and 15. So from 14 to 20, she avoids sex, less than 1% chance of getting pregnant, the equivalent of birth control pills. Okay, but we'll talk about all of the things that are available later on. All right, so now day 1 through 10 is the one that varies the most. Everybody understand that? Now, I remember since the pineal gland is the one that responds to time, right? Takes care of time, but the pineal gland responds to light. You ready to follow that? That means if women are living in the same light, their periods will synchronize. You guys have heard this, right? It's right here at Champaign, right in the PASS program. I hear some of the girls talking in the hallway sometimes. I mind my own business, but I hear things. I hear things, and they all of a sudden I hear them talking about all 3 of them are menstruating in an apartment at the same time. That's because you've been here for a while. You're synchronized. That's normal. Okay, I've got my mom and 3 sisters, so I get used to that. With all 4 menstruating at the same time. Now, back in college, I used to work at a sorority. I tried to join, but they wouldn't let me. I got my application in on time, paid my fees, but they wouldn't let me join. Now, how did I end up at a sorority? You know how you eat the food at the cafeteria and it's the same damn food every day? It starts out as burgers on Monday, then they make it into chili by Tuesday, then it becomes what else do they make out of it? Sloppy Joes on Wednesday. It's the same damn burger you ate on Monday. I mean, your stomach is still upset from eating it on Monday, and here you are eating it Tuesday, Wednesday, Thursday. You're eating the same burger again, and you're paying $4,000 for your card to go have lunch and dinner. And I got sick of that. And then I was complaining to my buddy, and he said, "Hey man, I work at a sorority, and we get free food. You just become their busboy. You know, help set the tables and everything else. You eat same thing the sororities eating, fresh food delivered every day." I said, "Well, I've never seen fresh food delivered in this cafeteria." I said, "Sign me up." So anyway, I got on to that sorority. I mean, back then, every day we saw the boyfriends come to pick up their girlfriend. All day long, you hear ding, ding, doors open, and then they go out, doors closed. Ding, 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 ding. But we always just remarked, there was 1 week every month. No boyfriends ever show up. That's because all the girls are menstruating at the same time. And then you got a sorority of 60, 70 girls, and they're all menstruating at the same time because they all live in the same household. Same lighting. That's normal. All right. That's the pineal gland doing that. Now, what I've always, that one I could prove with no problem, but there was one called a pheromone theory. You guys heard of pheromones? Everybody gives off a certain scent in their body. I didn't quite believe that one till one lady finally convinced me. And then since then, a lot of women have said they do the same thing. I gave this lecture and she said, "Oh no, if I talk to one of my friends, stand next to her and we're talking and she starts telling me she started her period The next day, I start my period. That's pheromones. She was the first one to admit in class. I don't know if all the other women before that, nobody wanted to admit it, but when she admitted, the next session, I asked the same question, at least 2 other women said they have. And then since then, a lot of women, I said, oh my God, it's true then. I never saw the support for it. That's why I always just got to mention it, but I said, I'm not sure this is really real, but I still got to mention it to you guys. But now it is real, folks. A lot of women have that problem. If they stand next to their girlfriend and that girlfriend starts talking about her menses, the next day she starts menstruating. Okay, so it is possible. So living in the same household, the periods will synchronize. Everybody clear how that happens. It's just a pineal gland synchronizing the time. Okay, all right, so this is how you separate the 3 periods. So now we're going to go through actually what happens. So we're going to go talk about oogenesis. You know why we're going to talk about oogenesis first, Cynthia? Oogenesis. That's why when you see a cute woman, you say, oh, Genesis. All right, so excuse me, folks. Anyways, I like this lecture. It just makes me crack up. So anyway, oogenesis begins in utero around 5 months gestation. Bailey, you see that? 5 months gestation. Before a woman is even born, she's preparing for something that's 14 years in the future. That means genetically, that's why you guys get this habit that you guys got to prepare way ahead of time. We men, we like waiting till last minute. What's rush? What's rush? My family lives in Chicago, right? My wife's family lives in Peoria, the opposite direction. So I would say, hey, let's go visit my family. She said, okay, no problem. Just on Saturday morning. I'm thinking, go visit them Saturday, come back Sunday, no problem. She said, okay. And I go in the closet, I'm ready. Here's what I'm wearing, I'm done. And I'm thinking she's gonna do the same thing, 5 minutes. I sit down in the living room, half an hour goes by, damn. And I turn on the TV, okay, watch some sports. Game halfway through, we were at halftime, 2 hours later. I'm like, damn, how long does it take? And then one day I finally had to ask her, why does it take so long to pack? Because when she came out, she had 2 suitcases. I thought, you kidding me? We're going for a 1-night trip here. We're going to Chicago, okay? I got 1 change of clothes, I'm ready to go. She got 2 suitcases. I'm like, what the hell are we preparing for? And then one time she finally decided to answer me. Fellas, don't ask. I'm gonna tell you now, just don't ask. I could tell she was clenching her teeth, trying to avoid cussing me out for even asking. Because she thought it was enough that she even said yes to go with me to visit my family. She said, listen, you wanna go to Chicago? I said, yeah. All right, so I gotta wear this with these shoes and stockings and these jewelry. But let's say if it starts raining tonight, I can't wear this. I gotta wear this. So I brought my clothes. I gotta wear that, and I can't wear these shoes with these clothes. I gotta bring some extra shoes. And then what if you want to go out tonight? If you want to go out tonight, I can't wear these 2 things. I gotta wear something else. So she got another clothing, another outfit, new shoes, new stuff. Okay, fine. And then Sunday, hey, you always like to go to church. I gotta bring some church clothing too. And then afterwards, if we want to go out to brunch, I'm like, good Lord. For a man, pants, shirt, socks, let's go. I don't care what happens tomorrow. Downpour, typhoon, hurricane, mudslide. That's what I'm wearing right there. Okay? That's the way a man prepares. Women got all kinds of contingency plans. But this is why women take note of details men miss so much. Okay? Like you can walk into a club, walk into a club with my wife, and we're just going to sit down. And as soon as we sit down, all of a sudden she said, you see how she's looking at you, right? Who? I'm like, who the hell's looking at me? I don't know who he is. I have no idea who the hell's even looking at me, but she noticed it, and I didn't know nothing. And if you don't notice it, she said, come on, I know you noticed that. What? Notice what? Now she thinks you're trying to play it off. No clue. Men miss details. Women pick up on all the details. So now what's the problem? We get to Chicago, all of a sudden I'm like, damn, forgot to pack my underwear. Run up the street to Target, buy a pack of underwear, just so I can have one. I got so many packs of underwear. Or I forgot my socks. I got so many packs of socks. I got 2,000 pairs of socks for that reason. Or I forgot the toothpaste. Oh, damn. Man, come on, Target knows me every morning I come in there because I'm missing something. See, but women pack everything just in case. She never has to run to Target to get some. I'm the one always running to Target on Sunday morning because I forgot something. But that's why men always forget little things because we don't think about the little things. But women think about all that stuff. But look at this, at 5 months gestation, she's getting ready for an event 14 years from now. Okay. At birth, a female ovary contains about 400,000 eggs. That's the number you want to know. And then starting at puberty, 14 years later, 8 to 10 follicles begin development every month, but only 1 egg will survive and ovulate. The other 9 will die by apoptosis. That's because we don't want any inflammation in the ovary. We don't want any scars in the ovary. That's why apoptosis occurs in the ovary, no inflammation. So start at 400,000 and starts going downhill once puberty begins. The eggs that do not finish ovulation, the one who does not actually ovulate, the other 9 must die by apoptosis. Because when they didn't make it, all of a sudden some handsome guy shows up. I mean, oh man, dashing eyes, just beautiful eyes. Got nice clothes on. He likes his favorite t-shirt, got a big D on it. Big D! He comes out of nowhere. Oh, he's such a handsome young, he sure is. Oh, I'd like to go somewhere with him. Okay, yeah. He says, don't worry, ladies, we'll take good care of you. Now, I have no idea what good care of you means, but they're about to get care of. Anyway, so they die by apoptosis. And we call them corpus albicans, white nodules. No scars. Don't ever pick the answer that has scarring in the ovary. That's why we don't like do surgery on the ovary, because there's no scars in the ovary allowed. That means those eggs will get trapped in there. Okay. So if everything's going normally, eggs hatch, but there's no scarring going on. Fanta.
Hi, doctor. Sorry to take
How
this
you
back a
doing?
little bit, but I'm
Okay.
good, thank you. So for the menstrual cycle, let's say
Yes, yes.
the length increases to like 30 days. So you're
right, 30-day
saying that
cycle.
the change happened in the proliferative phase? Is
That's
that where
correct.
the extra number? Okay. Okay,
Yeah,
thank
that's
you.
correct. Luteal phase rarely ever changes. All right, so now this is the sequence of events. Let's go through it. The steps. 1 round of mitosis first. Now remember, 2N is the baseline. 1 from your mom, 1 from your dad. Everybody starts out with 2N. And then we're going to double that. That's called mitosis. So 2N goes to 4N. That means 46 becomes 92 chromosomes. That's called a primary oocyte. So they're going to be talking about N or number of chromosomes. That's why I'm giving you both, because I don't know which one they're going to use on your exam question, but I know they flip it back and forth because they know the students get all confused. How many chromosomes is 4N? They don't know. They haven't looked it up all these years. 2N is 2 sets of chromosomes, 23 from each parent. So 2 times 23 is 46. That's what everybody starts out with. Once you go through mitosis, you now have 92. That's a primary oocyte. Then you enter meiosis 1, but you're rest in prophase. That means you still have 92 chromosomes. That tells me, therefore, Saba, that every egg in every ovary of every woman in this room is sitting at 92 chromosomes. Everybody follow that? The question they like to ask on the test question is, where would you find a cell with 92 chromosomes in a female? Is that easy? Every ovary has a bunch of them for you. Okay? All right, notice they enter meiosis 1, but they rest in prophase of meiosis 1, still at 92 chromosomes. Okay? Then when ovulation occurs, so that happened in utero while she was in mom. Okay? All the eggs are rested in prophase. Then 14 years later or 13 years later, when she goes through puberty, now, whichever one becomes the graphic follicle, the chosen one, will finish developing. Okay? That means you ovulate, and then you're allowed to finish meiosis 1, and then you enter meiosis 2, and arrest again. But this time you rest in metaphase. How do I remember this? PM, like evening, PM. Prophase of meiosis 1, metaphase of meiosis 2. Just remember, prophase of meiosis 1 is in utero. That's in every ovary of every female. But after ovulation, it arrests in metaphase of meiosis 2. And any questions there? Now we call it a secondary oocyte. If that egg does not get fertilized, Zena, it'll die in what stage? What? No, I never mentioned the word telophase. That's what I'm saying. I gave you all you need to know. Meha. Yeah, remember I said it arrest in metaphase of meiosis 2. Then it's going to die in that stage if it does not get fertilized. I've seen that question. Okay. So the key is just to understand the normal process. That's what we're doing, folks. We're going through the normal process in every female. All right, so PM, prophase of meiosis 1 in the ovary, metaphase of meiosis 2 in the fallopian tube. That's the secondary oocyte. Now, if fertilization does occur, the egg will complete meiosis 2, give off what we call a second polar body. What happened to first polar body? First polar body was given off at ovulation. What that means, Justin, is that only a piece of the ovary goes with it. That means off the top, polar. That's what they mean. Because you don't want it to be an even division. We want most of the nutrient to stay with the ovum, the main ovum. So just a little piece of the top goes with it. That's called a polar body. So right after ovulation, first polar body. Right after fertilization, second polar body. And then you become a zygote, which is called a tertiary oocyte. That's the same thing as a baby just starting. Any questions on the stages? Again, it's being able to talk out the stages without looking at your notes. Then the questions are real easy when they start asking. Yes, sir. Polar body is just when you have a division of the egg, it's supposed to divide into 2 different cells, right? But it doesn't. Only a little piece of the top goes away because you want most of the nutrition to stay here with the main ovum. Yeah, so it's not an equal division. So the polar body is just what they call the unequal one, the tiny one. It goes away and dissolves. All right, so because mom's egg remained arrested for so long, folks, you can trace 80% of chromosomal problems back to mom. What does that mean? It means that if you have an autosomal dominant disease and they ask you who's carrying it, just say mom every time. Why? Because that would be the answer, 8 out of 10. I told you, I'll take an 8 out of 10. Instead of trying to guess when dad is carrying it, I'm not. The only one where they know for sure when mom or dad is carrying it is something called uniparental disomy. This is chromosome 15. That's Prader-Willi and Angelman's. Remember, if you want to silence a gene, what do you do to it, Melissa? Methylate it. So this involves hypermethylation. All right. Prader-Willi, dad silences both of his copies of 15. So that means only mom is going to be expressed. All right. And Angelman is just the opposite. Mom's a little angel. So she silences both her copies. So only dad gets expressed. So that's what they'll ask you is who's silencing and what are they doing? It's methylation, as you've already learned. And then the new one they found now is called Beckwith-Wiedemann. Beckwith-Wiedemann syndrome. Wiedemann. This one is chromosome 11. They just don't know who's methylating it, though. That one they haven't figured out yet. But they will ask you which chromosome is involved. What do we need to see here? The baby is floppy, big, and has a high incidence of Wilms tumor. That's the question they ask the majority of times. What tumor do you have to screen this baby for the rest of his life? Wilms. So big floppy baby, and there's a lot of things that cause floppy babies. But if they're talking about uniparental disomy, then there's only one. It's called Beckwith-Wiedemann. Yes, sir. No, you can start screening anytime. Yeah, every year you have to screen them. That's just physical exam. Or you can do an ultrasound if you want, but physical exam can see it. All right, Mabel, question?
Yeah, please, did you say that they'll have 2 more for the rest of their life?
They have what?
They have 2 more for the rest of their life?
No, I said they have the risk for Wilms for the rest of their life.
Okay.
Yeah, it's called risk. They don't have the tumor. They wouldn't live that long if they did. All right, now, here's the sequence of events. So what we're going to do is go through the whole sequence of events so that you see how things go on. All right, we're going to start. We're going to do proliferate phase and maybe get to ovulatory phase and then take a break. And then we'll do the luteal phase. Any questions before I begin? Question over here, Melissa. Yeah, genomic imprinting is the same thing. Genomic imprinting is the same thing as uniparental disomy. Yeah, because dad always silences his. Yeah. Yeah. The methylation is silencing, the imprinting is the other parent. Yeah. All right. Muhammad, question.
Yes, sir. So those were the Y-linked autosomal diseases? that we just discussed before this?
No, no, they're not Y linked. They're autosomal. That means they're not linked to X or Y. It's just that almost every disease, 8 out of 10, are linked to mom. Mom's one carrying a gene. All right. Why? Because her chromosomes stay exposed for so long, mutations are more likely to occur in hers. This is why the older a woman gets, the greater chance her eggs are no good, because her eggs are exposed. They are in the middle of meiosis, and then just stopped. That means they get to be exposed to radiation from the sun, radiation if she has chemo or radiation for her cancer. I mean, drugs that she's on, that means they can be damaged at any time. That's why the older a woman gets, the greater chance her eggs are no good. This is why
Okay.
women always feel this ticking time bomb in their head, you know, by getting married and having children while your eggs are still okay. Okay. All right. Good question. All right. Now, here we go. Day 1 through 10. Again, pineal gland sets the timing. All right. Serotonin in the morning, melatonin in the evening. But pineal gland knows what day it is. So what do we do first? Hypothalamus produces GnRH. Hypothalamus produces GnRH. And then it goes to the anterior pituitary, causes production of LH and FSH. Wanted to draw something, but I would have to, okay. All right, so LH and FSH are the two hormones that come from the anterior pituitary. What they're gonna do, go to the egg. I wanted to erase some of this, but I left this last time, so I'd have to go back through the whole thing and erase it all. But anyway, I'll just talk it through. So, oh no, you know what? I can draw another one. Let me just show you. So in the egg, what do we have? You have an ovum. Sorry, not in the egg, in the ovary. We have an ovum. Surrounding the ovum is a bunch of connective tissue called granulosa cells. Surrounding the ovum is a bunch of cells called granulosa cells. And then they sit on the basement membrane called theca interna. So now I'm going to label it. Theca interna. And then the other one, granulosa cells. Any questions so far? Then there's an outer shell to all of this. The outer shell, I'll put it in purple, make it dash lines. This is theca externa. Because I want you to be oriented as I'm speaking. You got ovum in the middle, granulosa cells surrounding them. They sit on a basement membrane called theca interna, and then there's an outer shell called theca externa. Any questions on the players here? All right, so day 1, once LH comes out, he's the first one to come out. LH will stimulate theca interna to produce progesterone. So LH stimulates it, and out comes progesterone. So progesterone is the first hormone to respond. But that progesterone leaks upward into granulosa cells. It doesn't go out into the bloodstream. It just goes upward into the granulosa cells. Why? Because they're going to need it. Granulosa cells are going to need that to make estrogen. So granulosa cells respond to FSH, and they're going to make estrogen. But that estrogen came from progesterone. Remember, all you got to do is modify progesterone a few steps, and now you have estrogen. So that's why we say it is the estrogen that controls the first 10 days of menstrual cycle, because the progesterone is being used up. But that means, Melissa, if I stop progesterone production by theca interna, what happens to estrogen production by granulosa cells? If I stop theca interna from producing progesterone, what happens to estrogen production by granulosa cells? Goes down. So just think about birth control when we talk about this afternoon. See that? All you gotta do is shut down one and shut down both at the same time. That's what birth control is all about. You're trying to stop these hormones. Okay, but we'll talk about the mechanism later. Yes. That's why progesterone challenge is always done, because that's the guy who's controlling. He's the one being used to make estrogen. Okay. And think about why most birth control pills or birth control methods are progesterone. See, it's always trying to feed back to inhibit the ovaries production of progesterone. Okay. Anyway, we'll talk about that more in the afternoon. So one more time, I got an ovum in the middle, surrounded by granulosa cells, and a Theta and Turner that they sit on. The LH stimulates Theta and Turner, it produces progesterone. That progesterone leaks upward to granulosa cells. FSH stimulates them, and they make estrogen. And that's why that estrogen gets released to control everything. Any questions on that?
Yes, sir. I have
Yes.
questions, sir.
Hang on, somebody right before you. Go ahead.
Okay.
Granulosa cells, yeah, needs that they can turn and make progesterone before they can make estrogen from that progesterone. And that's why there's hardly any progesterone in the first 10 days, because it's being used up to make estrogen. Yes. All right, Mabel, you were next.
Yes, sir. Please, sir, you were saying, it said that if we stop the TI from producing progesterone, what happened?
You would never get any estrogen from the granulosa cells. Remember, you need the progesterone to be made into estrogen. That's the substrate for the estrogen production, is the progesterone in the Theta and Turner. Yes, Anna. LH from the pituitary stimulates Theta and Turner to produce progesterone. Progesterone goes up to the granulosa cells. FSH stimulates them, and they use that progesterone to make estrogen. It's not going back to pituitary, not at this point in time. Remember, you got to do your actions before you do feedback inhibition. If you do feedback inhibition, that means you didn't do your actions yet. You have to, we got to go through all the actions first, and then we'll do feedback. Yeah, FSH is the one controlling estrogen release, correct. What's the point of progesterone? That's the substrate for estrogen. Estrogen is made from progesterone, yeah. Just a few steps, and now you make it into estrogen. So estrogen, what's it gonna do? Let's talk about it one at a time. Maria, you first. Estrogen at the breast will stimulate ductular growth. Remember I said anything about ducts in the breast? Estrogen did it. Ductular growth. That means when you stimulate the ducts, what do you get? Let me see, do I have it on my list? No, I don't. I just want to make sure I don't have it. All right, the list of things that you get. I'm going to talk about all the female problems that doctors run into is based on this knowledge right here. No, if you know normal, you can figure out the abnormal. So first thing, breast buds. This is the first sign of puberty for a female. That's estrogen stimulating the ducts of the breast, and all of a sudden you get this thick nodule called a breast bud. That's how you know she just entered puberty. And so the question would be, how do you know when a female has entered puberty? There it is. Or they'll say, what's the first sign of puberty in a female? There it is. Breast bud. That means estrogen has now stimulated her the ducts of the breast. What if you keep stimulating the breast ducts? Then it's going to form into a tumor that we call notice fibro tissue, fibroadenoma. That's why fibroadenoma is the most common breast tumor under age 25. Because the adolescent female goes through a lot of estrogen months without progesterone. So that's why fibroadenoma pops up first. It also explains to you why we ask her to keep a breast diary for 30 days if we're unsure what's going on. If she says that mass gets bigger in the first 2 weeks, then you know it's fibroadenoma. And then she'll tell you it shrinks in the second 2 weeks. Oh, well, that means it's benign. We don't have to do anything else. That's what a breast diary is all about. They're telling doctors now, don't be quick to go rush and take out things. Because there was an article that showed, man, we do so many mastectomies and surgery on a female's breast for false positives. So they say, do a breast diary. Let her keep it. 30 days does not make a difference in the life of a cancer. So even if it's cancer, so what? But I want to be sure before I do any surgery on this woman that it truly is what I think it is. Watch it for the next 30 days. Fibroadenoma, most common breast tumor under age 25, gets larger in the first 2 weeks. What if I keep stimulating the ducts again? Then it's going to become introductal carcinoma. And as a sign of introductal carcinoma, remember, you get a dimple. It's the most common presentation because it's pulling on the traction fibers. But sometimes you get an ulcer or a rash around the nipple. Amy, what do we call that? A rash or an ulcer around the nipple associated with introductal carcinoma is what we mean by Paget's disease. That means you biopsy directly underneath that rash or directly underneath that ulcer, you'll see introductal carcinoma is developing. And what hormone is that dependent upon, Amy? Yeah, we're only talking about estrogen. I haven't even got a progesterone yet. All right, so estrogen, that's why tamoxifen and raloxifene are used to treat it. All right, so tamoxifen and raloxifene. These two are called SERMs. They're used in the treatment of breast cancer. SERMs, selective estrogen receptor modulators. SERMs. What do? First action, they block estrogen receptors at the breast and the pituitary, which prevents the breast cancer for you. They block estrogen receptors at the breast and the pituitary, which is what saves you from the breast cancer itself. But they are pro-estrogen at the liver. No, let me not do that yet. Pro-estrogen at the bone first. But that protects you against osteoporosis, so we're not worried about that. That's just extra protection for the female. Is because they're pro-estrogen at the liver is where the first problems begin. And that's because Anam knows that when the estrogen goes to the liver, a bunch of proteins can be made. Anam, name one of those proteins. Clotting factors. That's why they cause DVTs, PE, strokes, MI. See that? That's why if somebody has a history of clots, you cannot use these drugs. Everybody understand that? When they ask you what's the number one contraindication, if you already had a PE, I'm not going to put you on this drug so you can have another one. Okay, family history is not it. If she has ever had a clot, you cannot use these drugs. All right, so clotting factors. Melissa, tell me another protein that comes out of the liver in response to estrogen. Huh? No, Halima? Another protein that comes out of the liver when estrogen goes through it. I give you guys a whole list. All right, let me ask Michael. Angiotensinogen. Yeah, that's why they cause hypertension. Because if mom's renin goes up while it's up, then she's going to get hypertension now as a side effect of these two drugs. All right, another protein that goes up. Lipoproteins. That's why these two drugs cause fatty liver, NASH, NAFL, whatever you want to call it. Cause gallstones. Cause lipid deposition on the tendons, right? Decree veins, carpal tunnel. Those are complications. But just so you see, folks, they didn't just make up these side effects. It came from the physiology of the drug. That's why I always say, make sure you know the action of a drug. Don't memorize a bunch of side effects because the actions tell me where the side effects come from. I don't have to memorize them. It's a shorter list. Just know the actions. Okay, that's a real short list versus pages of side effects. Okay, all right, I know. Fatty deposition. Decree veins is fatty deposition on the tendon for the thumb. That's why obese and pregnancy cause it. Yeah. Now you know, it's estrogen. See? That's why I say always go back to your basics, folks. It looks like everything's complex. It really isn't. Everything complex was made up of something basic. I want to know the basic stuff because it's easier to retain that information. All right, so that's tamoxifen raloxifene. Now, tamoxifen is also proestrogen at your endometrium. So if they're postmenopausal, you have to do endometrial biopsy every year. If they're premenopausal, you just go by symptoms. It used to be endometrial biopsy every year for everybody, but now they say no. It means they did a retrospective study, found if they're postmenopausal, yes, high risk, but premenopausal, nah, risk is so slim, they say just do a physical exam for that one. Tamoxifen raloxifene. Other proteins that come out of the liver, remember, TBG. So it's going to mess up her thyroid profile if she has hypothyroidism. You got to know that. Her SED rate and C-reactive protein will be extra high. And you gotta know, it doesn't mean she has inflammation. It's the drug that you put her on does that to her. See? Again, just by knowing normal, it outlines pathology real easy for you. All right, another thing we can do is block estrogen production by aromatase. Remember, aromatase is the final enzyme. And so we got AIs now, aromatase inhibitors. And that is, let me think, letrozole, exemestane, and anastrozole, that's it. Anastrozole. These are aromatase inhibitors. There's aromatase in adipose tissue. That's why adipose tissue makes so much estrogen. There's aromatase in the ovary. That's why the ovaries make estrogen. But we now block it. So if you got an obese female, then the AIs work real well for her because she has a ton of it. Like right now in Puerto Rico, they use a lot of AI treatment for breast cancer, whereas America like other chemo. But they get good results with the same thing. The key is to shut down estrogen production, then the cancer doesn't grow anymore. All right, any question on ductular growth? I'm just taking one piece at a time. All right, that's the breast. Now, let's go to endometrium. So let's go to endometrium. Karina, you go to the endometrium with me. Ready? All right, so I go to endometrium with estrogen. What does estrogen do? Proliferation. Remember that, right? Proliferation. That means cellular numbers. All of a sudden, you got cells growing. So increased proliferation of what they call decidua functionalis. So in your endometrium right now, Karina, there's a layer called decidua basalis, the basal layer. And all of a sudden, the cells start growing out and creating another layer we call decidua functionalis. Serves a function, which means every month slopes right off. You're right back to basalis again. Everybody understand? There's a second layer that builds on top of the basalis. That's called decidua functionalis. Okay. So what if you build too much of it, Karina? And the problem you're going to run into is that you got a bigger layer to slough off at the end of the month. Make sense? We now call it abnormal uterine bleeding, or you call it dysmenorrhea. What does that mean? Heavy menstrual bleeding. That's it. Very common, right? Because obesity is such a big problem in America now. 50% of adults are obese, 30% of children are obese. So you got a lot of young girls now who are so overweight that they have heavy menstrual bleeding as soon as they start puberty. At least now you know the connection. So abnormal uterine bleeding or dysmenorrhea is estrogen caused. What if I keep stimulating the endometrium with a whole lot of estrogen? Well, that endometrium will become real thick. And sometimes it grows into the myometrium. And we call that adenoglandular into the muscle layer meiosis. See, again, the word tells me what I need to know. This is overstimulation of the endometrium so much that it's actually growing into the myometrium now. Obviously, you only know that when you do the biopsy, okay? With adenomyosis, heavy menstrual bleeding, and it can be painful, is the presentation. So all of this will give you heavy menstrual bleeding. They all present the same way. So adenomyosis, though, they'll describe and symmetrically enlarged because it's going into the whole uterus. So symmetrically enlarged, but it'll be squishy. So they'll say boggy. Squishy or boggy uterus. That means it's all glandular. Remember, tumors are not squishy. So adenomyosis, overgrowth of the endometrium into the myometrium. You only know that with a biopsy. Okay, when you do a hysterectomy, sometimes we have to do that. And you see that. Any questions on that? Symmetrically enlarged. That physical exam, big, and pay attention to what they say. That's adenomyosis. Then if you keep stimulating the endometrium, you can actually get the endometrium, Karina, to go backwards, start flowing backwards into the pelvic cavity. Follow me? That's called endometriosis. Endometriosis still remains the #1 cause of chronic pelvic pain for a woman of childbearing age. So any childbearing age female who has chronic pelvic pain is endometriosis until ruled otherwise. That means until you rule that out, you don't worry about anything else. What is the problem here, Karina? It means your endometrium, rather than draining forward, is draining backwards and pouring right into the pelvic cavity and getting stuck everywhere. Remember, you learned that blood is the most adhesogenic material there is. So it causes scarring of everything. So endometriosis, she'll have pain with defecation because it's stuck on her rectum. Pain with intercourse because it's stuck on the back of her vagina. See? Pain with urination, stuck on our bladder. That's why they give you all these features for it. So anytime they got all those pains, and that's different from all the other causes I've talked about so far. The key is to know how to make a diagnosis by a few extra words, not what they all overlap with heavy bleeding. So that doesn't tell me anything. I don't pay attention to that. I just come with my differential and I wait till they give me some more information. Endometriosis. The only way to diagnose endometriosis is laparoscopy. You got to look in there. Ultrasound, CT scans can't see it. You go in there with a little camera and then take a look. Shine a light on it. What do you see? When it's a fresh one, it's described as a chocolate cyst because it just stuck to something. It looks like a chocolate cyst. When it's an old one, it looks like a powder burn, a gunpowder burn. It means it's been there for a while. But any one of those terms tells me you got endometriosis. She was first. Sabu, you had a question? For endometriosis pain? It's primarily during the period. That's when it gets real bad. But in between periods, the pain is from the scars. Yeah. All right. Steve? Falling out of fallopian tubes is exactly what it's doing. So let's say, Karina, I want you to crawl through your own fallopian tube. I'm going to give you one of those miner's hats with the light on it like that. All right. That way you can see where you're going. Okay. As you come out of the fallopian tube, what's the first organ you're going to see? The ovary. So there's a side that faces the fallopian tube. I'm going out like that. It's going to splatter just like that, right? Then there's your uterosacral ligament underneath it, splatter right on top of it. And then down at the bottom is called the pouch of Douglas. This involves a study they did years ago. Hundreds of women were coming with chronic pelvic pain. And they said, well, it's got to be endometriosis. They scoped every one of them. Laparoscopy. They couldn't find anything. They said, no, you're okay. Probably all in your head. Yeah, remember, they used to explain everything, just like the period, PMS. They thought it was all in your head. So they didn't know. So they just said, okay, go home. These women had years of a lot of pain. Till somebody said, you know what? I wonder if it's there, but we just can't see it with the naked eye. So he said, what if I just biopsy the surface that faces the fallopian tube, the sacral ligament, biopsy the surface that is up, and then the surface of the pouch of Douglas? Folks, over 45% of those women had positive biopsies. So the point is, it's still the most common cause no matter what. I mean, even in laparoscopic negative cases, you still got to rule out endometriosis. And how do you do it? Biopsy those 3 sites. Okay, and it'll still be positive. And that means you got to treat her. So endometriosis. If you keep stimulating it, it'll become cancer. And we say endometrial carcinoma. Adenocarcinoma. Why is it an adenocarcinoma, Zena? Because it's glandular. Hopefully you guys still remember how to name every tumor in cancer now. Don't lose your advantage. So endometrial adenocarcinoma. Well, that's if you stimulate endometrium. Part of uterus is smooth muscle. So now we're going to stimulate your myometrium. What happens when you overstimulate the myometrium? You get fibroids. And fibroids can be submucosal. When they're right underneath the mucosa, they're adding to the surface area of your mucosa. That's why you get so much more bleeding. The problem with that, however, Lillian, is that thing is taking up room in your uterus. Have you ever seen that? It causes late 2nd and 3rd trimester abortions. So that means if you get, everybody, does that make sense to everybody? Because the baby can grow for a while. All of a sudden, late 2nd or 3rd, when they're so big, all of a sudden this mass smashes their skull and they die. Submucosal fibroids, one of the things you have to rule out for 2nd and 3rd trimester abortions. Okay, it's usually anatomical. All right, so submucosal is 90% of the time, and subserosal. If you remember, serosa is the surface of an organ, so that thing is pushing out on the surface. At least it doesn't bother the baby in the utero, but it'll push on other organs in their pelvis. So it's one of the causes of pelvic pain, but nowhere as much as endometriosis. So fibrosarcoma is very rare. They don't even talk about it. All right, so now let me talk about how to treat each one of these. Any questions on these? Yes, sir. Is blood moving out, but remember, is blood moving out along with the endometrium. And that's why endometrium gets dumped in there too. Okay, so now how do we manage these? First thing you do, who's speaking?
Please, sir, I have two questions, please, sir.
Okay, Miss Mabel.
Yeah,
Oh,
you said that
Go
you
ahead.
said that the endometriosis, that when it's fresh, it's a chocolate cyst or chocolate color.
Chocolate cyst, correct.
Okay, then when it's old is what?
It looks like a powder burn in a gunpowder.
Poker bone. Can you write it
Yeah,
for me,
remember,
please, sir?
blood is just blood looks dark. That's it. Blood becomes dark, becomes black. So it looks like a gunpowder. If ever you've seen gunpowder.
Okay.
Yeah, even if you haven't seen gunpowder, just if they say powder burns, that's just endometriosis, just so you know. Okay.
Okay, so what about what do you say about adenomyosis?
What'd you hear about adenomyosis?
I didn't hear any much thing about it.
Okay, make sure you ask me when I'm talking about it. So
You
I
said
don't
that
get
you said it bleeds. It bleeds. I just want to know
the problem
features.
is growth of the endometrium into the myometrium. Look at the word adeno, glandular, myo, muscle layer. So you got glandular tissue, that's endometrium, growing into the myometrium. Put the two words together, adenomyosis. All right, the one thing I do want to add to that, the only exposure that's been known to cause this is DES exposure in the mom. They will ask for that, because that's it. That's the only one risk factor we know about it. All right, now I want to talk about management. Because now once you hear the physiology, the management makes sense. That's why I say you always got to know basics first. Okay? They're treating for every one of these. What do? Oral contraceptives. That means just stop the whole period from happening. Why? Then you don't have estrogen being produced every month. Okay? Use oral contraceptives. If the woman is very obese, use AIs, aromatase inhibitors, because you need to stop the aromatase in her adipose. She's just producing so much estrogen. Okay. If OCPs don't work, we got Leuprolide, which is GnRH analog, Leuprolide. What am I going to do? Shut off GnRH from the hypothalamus. I'm going to just shut everything off from the top. Notice all we're trying to do, shut down the whole cycle, because she is already making too much estrogen in adipose. I can't control that, but I can at least stop the normal one. That at least decreases how much estrogen she's making every month. So oral contraceptives, the treatment for every one of them. Leuprolide, the second line, or now with AIs, you can use that if you want. Okay. Any questions so far? All right. If everything fails, surgery. The only one that has a third line therapy before surgery, so let me move this down a little bit, is endometriosis, danazol. If you guys remember this. Danazol is a very androgenic steroid that just throws off her balance. Now she's more androgenic than estrogenic. That means more male-like than female-like. Look up all the side effects of danazol, more male-like. Hirsutism, deep voice, muscle mass, hypertension, increased appetite. See that? Instead of my trying to remember what the book said, I just remember male-like, there it is, good enough for me. And then if you look at the list of answers, you'll see your answer real fast. All right, Justin went first. Leuprolide, what about it? Yeah, if you give it consistently, then it shuts everything down. Pulsatile is to cause a surge of LH and FSH. Yeah, so we don't use it for pulsatile nature. Okay, so for AUB, OCP, Leuprolide, surgery. Adenomyosis, OCP, Leuprolide, surgery. Endometriosis, the only one who has a third danazol before surgery. For endometrial carcinoma, we go straight to surgery. There's no in between. You do total abdominal hysterectomy. That means cut out the entire uterus and take away every source of estrogen. That means cut out the fallopian tube, cut out the ovaries. So bilateral salpingo-oophorectomy. And then add an AI if she's obese. That means shut down adipose tissue production of estrogen as well. That is the current treatment of endometrial cancer. And then with fibroids, same 3 steps: OCP, leuprolide, then surgery. Anders. Aromatase inhibitor is what AI means. Any questions? So at least this way, the last piece here is cervix, cervical mucus. We're going to make it thin, mostly water. How do we know that? That this is, it's called a cervical mucus test. The OB-GYN takes a sample of mucus between the 2 fingers and then pinches it and then separates it like that. When it's mostly water, it pops almost immediately. That's how you know you're still in the first 2 weeks. Okay? And that's what they'll describe. That's how you know you're still in the first 2 weeks. Leiomyomas. Yeah. The medical name for fibroids. All right, so we've done the first 10 days of the menstrual cycle. And then I want to take a break, and then we'll go through the luteal phase. Not luteal phase, sorry, ovulatory phase. Yes, Anna. Oh, good question. Is there a certain size where you would start the OCPs or do surgery for fibroids? No, it's based on level of discomfort. That means if it's big enough and causing a lot of pain and discomfort, that's the only time we do surgery. Because you have some women who have big fibroids, but it's not causing that much discomfort. You leave it alone. It's benign. You always start OCPs first. Yeah, it doesn't matter how small or how large it is. Yep. Any other questions? All right, take a break here. Start back at 10:40. All right, let's continue with female physiology. We've done the first 10 days, which is estrogen controlled. Now we're going to make our transition. After estrogen does its 3 actions, that's ductular growth at the breast, proliferation of decidual functionalis at the endometrium, and thin out the cervical mucus. Then you have to have feedback. Okay, close the door down. All right, so now you gotta have feedback. Remember, feedback inhibition is the rule in all of physio and biochem, whether they wrote it or not, you're supposed to know that. So estrogen will then feedback to inhibit the pituitary for FSH, and estrogen will feedback to inhibit GnRH, because both of those control them. What if I could block that feedback? So if you look at the this graph here, it's like the first 7 or 8 days, estrogen is going up. And then it starts to go down after that. That's from feedback inhibition. Okay, what if I could block that? And that means after day 7 or 8, what's going to happen to GnRH levels? Cesar. You know, it's supposed to go down, but if I block that, then it goes back up. Everybody understand that? That means after 7 or 8 days, GnRH starts to go up again. Now you're having a menstrual cycle within a menstrual cycle. Yes. You're blocking the feedback inhibition of FSH and GnRH. So hopefully everybody's following. We're on day 10. So near day 10. So estrogen goes up for about 7 or 8 days and then starts going down. That's feedback inhibition. And I said, what if we could block that feedback inhibition? That means GnRH will start going back up after 7 or 8 days. That means now you're starting another menstrual cycle within a menstrual cycle. This is how a drug called clomiphene works. Clomiphene used to be the most effective ovulatory drug on the market. The way it works is to block the feedback of estrogen on FSH and GnRH. That means GnRH will start up again. That means after 7 or 8 days, guess what? You got another egg that's going to ovulate. After 7 or 8 days, you got another egg that's going to ovulate. That means within one cycle, you may have 3 or 4 eggs ovulate. That means 3 or 4 chances to get pregnant. You understand that, Halima? You understand that, Ashley? But the bad side is all 4 of them can get fertilized. Multiple gestation is the #1 side effect. I was on call tonight. We had a woman who gave birth to 5 of them. 5 of them from one cycle. She fertilized all 5 of them. So of course they're all premature. So we took care of all 5 of them. All 5 of them survived. Typically when you have 5 like that, we estimate 2 or 3 are going to die and 2 may survive, but all 5 survived. So it was made the literature, made the news, everything. The last time I saw them on CNN, all 5 graduated from college. Yeah, they had severe cerebral palsy, but their mind was completely intact. Yeah, man, it was so nice to see that. It means we did a good job. Nobody had brain damage. So it was great. So anyway, that's how clomiphene works. Multiple gestation is the #1 side effect. Clomiphene now is no longer the most effective ovulatory drug on the market. Letrozole is. The one I just gave you, a aromatase inhibitor. Letrozole is now #1. Clomiphene has dropped down to #2. Leuprolide now is #3. So if you want to induce ovulation, you know, for in vitro fertilization, those are the drugs that we use. Any questions so far? All right. Now, let's go back a moment before I go to my ovulatory phase and talk about puberty. Because we talked about the first sign of puberty for a female was what again, Chris? Chris was a C? The first sign of puberty in a female? Breast buzz. So we're going to go through the Tanner staging of puberty for boys and girls. Okay. And then talk about what if things go wrong, you know, like precocious puberty. Okay. So Tanner staging, I have a way to remember this. I call a tap them. You want to tap them. This is the 4 phases of puberty. So T is for thelarchy. Has breast bud development. That means thelarchy precedes everything else. A is for adrenarchy. That means the adrenal gland suddenly wakes up, starts producing testosterone. That's what then causes pubic hair development. See, pubarchy. And then before you know it, that androgen gets aromatized to estrogen. That's how you get menarche. So it's just a good way to remember what order things should occur. So that if anything goes out of order, that's how you know something's wrong. You always got to know what normal is to catch an abnormal. So tap them are the 4 phases of puberty that any child's got to go through. That's between the boys and the girls. Okay, Tanner staging. Dr. Tanner, pediatrician, came up with this Tanner staging for breast development and pubic hair. And on the exam, they'll just give you the physical exam for some little girl and ask what stage she's at. All right. So first, big picture. Was it growth spurt? For the girls, Tanner 2. Remember, the girls go before the boys. For the boys, Tanner 3. So any question about growth spurt, the girls go before the boys. Tanner 2 for the girls, Tanner 3 for the boys. Menses. First period for a female, Tanner 3. And the overall rule is puberty should start by age 13 or I'm concerned. That means when you start working children up. If puberty has not started by age 13, I'm concerned. That's when I start working them up. And menses should happen by age 15 or something's wrong. You start working them up. Because they'll give you a 14-year-old, a 14-and-a-half-year-old. The answer is no, wait till after 15. That's when you start working them up if they haven't had a menses. The rule is menses should occur within 2 years of pubertal changes. So notice puberty by 13, menses by 15. So if some little girl started by age 12, then by 14, I should be seeing menses or else I'm concerned. Any questions on that? That's the big picture. All right, so Tanner staging. I'm going to do breast and pubic hair. Now, all this is in your notes. Just follow along. That way, in case you have any questions. But you don't have to write anything I'm saying. Just follow along. Tanner 1 for the breast. All right, prepubertal nipples. That means before even the breast buzz come in, it's Tanner 1. Once you get breast buzz, read Tanner 2. That means you just entered puberty. Tanner 3, areola comes in. Notice that's when she should menstruate. So once I see areola come in, I'm asking mom if she started her period yet, because they should coincide. All right, so areola. Tanner 4, secondary mound. That means you can feel some more breast tissue underneath that areola. That's Tanner 4. And then when it separates from the chest wall, Tanner 5. Those are 5 stages you want to know. You understand, Abdullah? Fanta, do you understand that?
Yes, sir.
All right, good. So those are 5 stages for breast development. All right, go to pubic hair. Tanner 1, no pubic hair. Tanner 2, sparse is the word they'll use. That means one here, one over here, one over here. Sparse pubic hair, Tanner 2. Tanner 3, a patch. That means now you actually see a patch of pubic hair around the base of the penis for a male, on the mom's pubis for a female, but it's a patch. Tanner 4, the whole area is covered with pubic hair now. That means the entire base of the penis is full of hair, but the female, the entire mom's pubis is full of hair. Now you're Tanner 4. And Tanner 5 is when it touches the medial thigh or rises above the pelvis, the pelvic brim. Then you're at Tanner 5. So again, like I said on the test, they'll give you the physical exam of a child and ask you what Tanner stage the person's in. That's why it's worth looking at this to make sure you know it. Because we use it a lot in peds. Any questions on that so far? So the next point then is called precocious puberty. What if it happens too early? Puberty used to be 12 and 13, and just a little more than 30 years ago. Now puberty is 11 and 10. 11 for the boys, 10 for the girls. That's the average age. It's not supposed to fall 3 years in just one generation, but it has. Why is it falling so fast? Because all the additives we have in our foods. We give growth hormone to everything now, chickens, pigs, goats, cows. So it's accelerating everything for us. And then for the female, obesity causes her puberty, because that's where estrogen's coming from, adipose tissue. So because it's puberty, you got to think of the standard deviation. Standard deviation is 1 year. So for the girl, 10 is normal. That means if you have puberty before age 8, see 8 or below, that's because of puberty. For the boy, 9 or below, it's because it's puberty. Everybody understand? If you know what normal is, just subtract 2 years. That's because it's puberty. Okay? Any questions on that so far? All right. Once you're precocious, the question is why? Is it coming from the pituitary? We call that central. Or is it coming from peripheral tumor? We call that peripheral. How do we know which one it is? First thing we do is a leuprolide challenge. We give you GnRH injection. That GnRH should affect your estrogen if you're a female, or affect your testosterone if you're a male. If it affects it, we check it tomorrow. The levels have changed. I don't even care if it goes up or down. It changed. That means up here is controlling it. Because my GnRH can only affect what's going on up here. It doesn't go to ovary. Doesn't go to any place else with a tumor. All right. It can only go up here. So if that testosterone estrogen changes, folks, the answer is central precocious puberty. That means this person is going through real puberty and is having way too soon. So what do? Keep that person on GnRH. But now it's a consistent level. Remember, it's suppressive if you give it consistently. We just use the surge just to see if it changes the levels. Once you realize it's central, they stay on GnRH until the appropriate time to go through puberty. Like the little girl I told you guys, I think, she came in age 6. She had 10 or 3 breasts. She had curves in her waist. I'm like, good Lord. And I'm present, grandma, what's going on here? Anyway, mom was in jail, so we didn't have any history from mom. I said, I said, grandma, she's about to menstruate. I'm seeing 10 or 3. She's about to menstruate. What does a 6-year-old girl know about menses? Absolutely nothing. She's still playing with dolls. All right, so that's why we had a mess on our hands. Okay, how do we deal with this? GnRH. We just put on GnRH, stop the whole thing. That way she wouldn't go through it. That means menses would not occur for another, we'd wait till it's about age 12. Okay, now we'll let her go through. I mean, stop the drug at that time. But that's how you treat central precocious puberty. Yes, sir. I'm giving a GnRH antagonist on a consistent basis. That will actually suppress the pituitary. It's going to stop puberty because she's going through it at age 6. It's too soon. So it's going to halt their growth, but they'll do catch up growth once you stop it. So they'll still grow normally. Yeah. All right. So that's how we treat central precocious puberty. What about if GnRH didn't make a difference in the hormone, then it's peripheral? That means you got a tumor somewhere or the hormones come from someplace else. For little girls, the most common cause is adipose tissue because obesity is #1 cause. Blacks and Hispanic girls right now, the average age is about age 8. Yeah, why? Poverty. Did I tell you about adipose? It's just poverty. It's not about race, okay? All right, because of puberty is because of just poverty. You're eating too much junk food, you get obese, and you start producing all this estrogen we cannot control, and that's why we're seeing because of puberty having a lot of girls, okay? The problem is these little girls, they still have the mind of a little girl, but the body of an 18-year-old. The sad part is some of them come in pregnant because they don't know what they're doing. Why? Because they have the mind of an 8-year-old. I remember when I was on the OB rotation, we had an 8-year-old girl come in pregnant. Now, I remember I overheard the residents and the nurses calling her a slut. I said, listen, aren't you concerned about who the hell screwed this little girl? Why do you think she's the bad person? I say, you got to be careful. But that's the way they felt. Oh, she's a slut. 8-year-old don't even know what a slut is. I said, 8-year-old girl, she just liked the attention some 18-year-old guy gave her. The 18-year-old guy sees the body of an 18-year-old. She still has the mind of an 8-year-old. So guess what? It's easy to get her to take her clothes off because she just likes the attention he's giving. So she has no idea the consequence of getting pregnant. You know, so it's not her fault. I always say, well, why don't you guys go after the 18-year-old? I mean, of course, now they do. That's called rape. Yeah, that's called rape. You can't just get her pregnant and just leave her to have a baby. But that's what was happening for a long time. Okay, so be careful so your prejudices don't come out because this little girl, if she's pregnant at age age 8, somebody did something bad to her. You know, even if it was a guy who was trying to be nice to her, he shouldn't be sleeping with an 8-year-old. Something's wrong with you if you're sleeping with 8-year-old kids. Okay. But anyway, that's why you got to know how to deal with it. Put them leuprolide till the appropriate time, let them go to puberty. What about if it came from the periphery? Then you figure out where it came from. I'd say if it's an obese female, you already know where it came from. If they want a tumor, what tumor produces a whole lot of estrogen, Jess? Granulosa cell tumor. See, granulosa cells produce estrogen. Yeah, so if they want it to be an ovarian tumor, then I know exactly what they want. Okay, for a male, where would you get a lot of testosterone? Number one cause, adrenal insufficiency, 21-hydroxylate, followed by 11. You've already heard it all, folks. The key is apply what you already learned. That's how you know. That's the number one cause. So Sertoli latex cell tumors producing testosterone, man, that's rare. That's rare. CAH is number one. Over 90% of cases is CAH. Yeah, always go for the number one answer before you look for anything else. Okay. All right, that's puberty and because of puberty. Any questions on that? All right, Anna. Why do we do bone age? Yeah, you can do a bone age on somebody. You look at her chronological age. Let's say she's 13. I look at her bone age and it says 11. You know, so that means she has not started puberty yet. This is somebody where you're trying to figure out why come they haven't started growing yet. Well, let's see if they started puberty yet. If the bone age lags behind their chronological age, it just means they haven't gone into it yet. You do nothing, just follow them. They'll go into it. What about if the bone age matches the chronological age? That means they are in the middle of puberty. But if they're still small, that's called constitutional short stature. Your parents made you short. Nothing I can do about it. You can, but it'll turn out bad. We used to give them some growth hormone injections. All they did was accelerate their growth. So now they're tall children, but short adults. Because they will only go through the growth that they're not supposed to go to. So if they're supposed to be 5'6", they'll get to 5'6" much faster. Now they're tall children. We don't like to do that to people. Because when you're a tall child, guess what? People make fun of you. And now you're a short adult, they start making fun of you again. So that's why our treatment made no benefit. So we don't do that anymore. Okay. So that's how you decide whether it's appropriate height or not. That's usually for short stature. And, you know, here they are at puberty, but I'm wondering how come they're still so short? Is it because they haven't gone to puberty or they have gone into puberty and this is just their normal constitutional height? Nothing you can do about it. The other place we look at the growth chart. If they're perfectly in the middle of growth chart, you don't have to do anything. That's constitution. It's their parents. It's genetic. Okay. So that's when bone age can help you. All right. So any questions on that? Now, in the first 2 or 3 years, when a woman starts puberty, okay. Let me see. Should I do that first? No, I'll do that later. Let me go through ovulation because it plays into what I'm about to talk about. So, all right, here we go. Day 10 to 14. Who knows when day 10 is? It's called your pineal gland again. Pineal gland knows when it's day 10. It says, wait a minute, we need to ovulate. So there's like 7 things that have to happen for you to ovulate. It's all your notes. Just follow along. Pineal gland, number 1, goes to the ovary, so to speak. He doesn't actually go there. He goes to the ovary and says, okay, ladies, there's 10 of you developing. I only need 1 of you. 1, what are we going to do? All right, pull straws. Whoever gets the long straw gets to say, the other 9, don't worry about it. We'll take good care of you. And they don't know what that means, but they thought there's coffee and donuts coming. All right, so they draw straws and 1 egg named Mildred. I got the long straw, All the other ones, oh man, Mildred won again. Man, you know she won bingo last Sunday, right? Now she won this one too. Man, she's lucky. Yeah. And then all of a sudden, you got coffee and donuts? Yeah. A guy's bringing it. And the guy shows up just handsome as all heck, man. Just debonair, man. Cameras flashing. But he got a big deal on his t-shirt. And they're all looking, oh, he's so handsome. Okay, well, what is job? Plant phosphatidylserine all over their backs. All right? Because then all of a sudden, they're gone. All right? Gone by apoptosis. All right? And then 1 egg is left. Everybody understand? That's just all that is just event number 1. Pick 1 graphene follicle. There it is. The other 9 are now gone. Second event, is to develop the graphene follicle. We have to go through 3 stages of development. 3 stages of development. Stage number 1, this is all still number 2 event. Stage number 1, cellular proliferation, but no antrum. Now I'm giving you the short version. They got a whole paragraph full of crap. I don't even read that stuff. You say proliferation of cells, I don't see any antrum in there. I said, good. It's a primary follicle. I don't care what else they say about that because they'll give you the staining and chromosomes, all that. You're reading too much. Cellular proliferation, but they don't mention the antrum. That's a primary follicle. Small antrum, secondary follicle. Large antrum, that's your graphene follicle. Because, Kathleen, your graphene follicle says, here's the ovum like this, a big space, right? And then the egg, which the ovum started here in the middle, is now attached to the side, hanging on like this, waiting for permission to ovulate out of there. That's why you have all these clear areas called the antrum. So when it's a small antrum, it means the egg is just starting to move. And when it's a large antrum, he's now hanging on the side. All this tissue's been dragged with him. So all this is clear area now. Everybody understand so far? That's all event number 2. Event number 3, the graphene follicle starts to produce large amounts of estrogen. That's why you see another surge of estrogen. We go to this graph, let's see. See that? Oops, sorry. Go back. All right, you see that? You see an initial rise in estrogen that's caused by all 10 follicles developing. Look at this bigger surge. This is a graphene follicle. 1 follicle makes more than when 10 are making it. Okay, but they'll ask you to explain the 2 peaks. First peak is done by all 10 follicles. Second one is done by the graphene follicle because this is a bigger cell now and makes huge amounts of estrogen. Any questions? That's event number 3. Graphene follicle starts to make huge amounts of estrogen. Event number 4. The estrogen by the graphene follicle now stimulates LH receptors on the granulosa cells. Because up until now, I've never mentioned there was LH receptors on there. That's because it's usually controlled by FSH. There's not supposed to be LH receptors on the granulosa, but starting from day 10 to day 14, I'm just going to put 2 of them. Suddenly you see LH receptors. What's going on? The graphene follicle is getting that egg ready for pulling the egg out of there. Remember, LH causes ovulation. You need receptors for that. That's the job of estrogen from graphene follicle. Any questions on that? So this is all, again, event number 4. Stimulates LH receptors on granulosa cells. And also stimulates LH receptors right here on the theca externa. I never said anything about theca externa until just now. There was no LH receptors there before. Now there is. They 10 to 14. That's how we know pineal gland is controlling all of this. And then the estrogen from the granular, sorry, man, I'm trying to make sure I'm saying the right word. From the graphene follicle. So these are all caused by estrogen from graphene follicle. He's going to go to hypothalamus and the pituitary and actually stimulate GnRH to come to rise. What? Yes. That means at day 10, GnRH starts to rise again. Remember, it's feedback inhibition till then. Now it's feedback stimulation. So again, we know it's got to be pineal gland controlling this. There's the same receptor, which you have to reset the action when the estrogen binds it. And this is estrogen specifically from graphene follicle. Regular estrogen couldn't do that. Okay? So now you get GnRH starts to rise. That means LH and FSH will start to rise. But who's going to rise faster? LH. Why? Because FSH has to overcome, remember, feedback inhibition. Estrogen feedbacks inhibit FSH. Nobody feedback to inhibit LH. That's because there's no rise, no big rise in progesterone in the first 10 days. So progesterone doesn't need time to surge. So this is explaining the LH surge, which is event number 5. They love to ask, how do you get this? Okay, so again, estrogen feeds back to stimulate GnRH, which then stimulate LH and FSH. But LH will surge faster than FSH because FSH was under inhibition from estrogen for the first 10 days. So you have to shake off the inhibition before you can stimulate it to come out. So he lags behind LH. And that's how you get the LH surge. Any question on event number 5? Event number 6, now that we have LH receptors on the theca the granulosa cells. LH is surging at day 14. LH then grabs that ovum and pulls it out of there. And that's where my picture, that's where this picture is from. The egg pops out of there now. And now you got an egg sitting out here. Back at the ovary, what do we got? An empty pocket, which is really the theca externa. Now we call them corpus luteum. All you do is rename them because there's no ovum here anymore. Just a pocket. So corpus luteum. Any questions there? Now, that means every time that happens, you can easily get a luteal cyst. That means what if that egg didn't pop out there? Then it'll still inflate like a little balloon, but then the egg never popped out. So we call that a luteal cyst. If it enlarges so fast, Kathleen, as it causes bleeding, then we call it a luteoma. So luteoma is just a luteal cyst full of blood. Again, these are all things that happen during the menstrual cycle for a female. What do we do with both of these? Nothing. Leave them alone. Because remember, we don't want to carve out anything off that ovary and then cause scarring. That's going to mess up some other eggs. All right. So only, again, when it gets big enough and it becomes uncomfortable enough, that's about the only time you can justify cutting it out of there. Typically, it's got to be like more than 8 centimeters. That's huge. It's almost like, yeah, that's big. So 8 centimeters in size and causing a lot of discomfort, then we'll cut it out of there. Otherwise, just leave it alone. Okay. Now, after this corpus luteum is made, you got LH receptors on the theca externa. All of a sudden, LH now leads to progesterone production by the theca externa. Remember, these LH receptors just showed up between day 10 to 14. Once you ovulate, that progesterone is now allowed to be secreted into the bloodstream. And that's how we smoothly go into the luteal phase. Is that sweet or what? Wow. Physio. Good stuff, man. All right. Any questions on how we made that transition? So that's our 7 events. So the 7th event is that the corpus luteum, theca externa, now starts producing progesterone. And that progesterone now pushes into the luteal phase. So 7 individual events must occur between day 10 and day 14. All 7 events are time sensitive. That means before day 10, you don't see it. After day 14, you don't see it either. That's how we know pineal gland controls all 7 events. Any questions at all? All right, let's go to what happens if something goes wrong. That's always start with normal first. Then what if something goes wrong? So luteoma and luteal cyst we already talked about. Oh, sorry, Leslie, you go ask me a question first.
Can you explain me again, like why FSH get low because of feedback inhibition?
Yeah, in the first 10 days, after about day 8, estrogen already did its 3 actions. Estrogen will feedback to inhibit FSH because that's her signal. It was also feedback inhibit GnRH because that's her signal as well. So that means there's feedback inhibition after day 8 on GnRH and FSH. And that's why that has to be overcome after day 10 before FSH can start to rise. And that's why LH rises first and faster.
Okay, got
Yeah,
it.
that's how you get the LH surge. All right. So now, when the woman when she ovulates, we have fancy terms for it. We call it metal schmerz. Metal schmerz. Metal schmerz is also known as mid-cycle pain. So the times I've seen a question is a female who always complains about a little discomfort in her flanks. And they say about the middle of her cycle, about 2 weeks after the last menses, that's the middle of your cycle, or 28-day cycle. You got to realize that's just a mid-cycle pain that every little girl gets. I mean, obviously for a teenager, she doesn't know what it is until mom explains it to her. That's normal. Metal schmerz is normal. So she can be sitting at Starbucks, sipping on a latte for $7.50. And then all of a sudden, while she's talking to her girlfriend, all's on, ooh, girl, I think I just ovulated. Okay, it's not that pronounced. I'm just making stuff up. But, but some women can tell you the exact moment and exact minute that they ovulated. It is that significant that they can tell you that they just feel a little twinge, enough to make her, oh, that's ovulation. But she knows that's normal for her. That's metal schmerz. Any questions on that? All right. Now, after you ovulate, you're supposed to go through the luteal phase so you can menstruate. In the first 2 to 3 years of puberty, a lot of young girls go through the estrogen phase, but they don't ovulate, which means you cannot menstruate. Everybody follow that? If you don't go through the last stage, you cannot menstruate at the end. So if you do not ovulate, you do not menstruate. So we have the word called anovulation is a problem. Anovulation is the most common cause of primary amenorrhea. And then we'll talk about secondary amenorrhea. Anovulation. Notice how something that's normal is the most common cause of abnormal. That's why I keep saying, make sure you know your normals. That's where all this abnormal stuff is coming from. Okay? So anovulation means she's going through the estrogen phase, but then she doesn't ovulate, so that means no menstruation. That happens so frequently in the first couple of years that it is the most common cause of primary amenorrhea, meaning she's never had a period. Now, remember, that's primary. Secondary says she used to have a period, now she doesn't have one. Okay. With primary amenorrhea, we always still do a pregnancy test, but that's not the most common cause of primary amenorrhea. I want to make sure nobody picks that when they ask, what's the most common cause? Don't pick pregnancy. Okay? It's anovulation. How do we prove it? We prove it, Ashley, by giving her progesterone, synthetic progesterone. I'm going to make her body think she's going through this last phase right here. It's Provera, it's called a Provera challenge. It's progesterone. Provera, 5 milligrams for 5 days. So easy to remember for the step 2 and 3, 5 for 5. And then you suddenly stop. Notice for a female, when progesterone suddenly goes away, that's the end of her cycle. She should bleed. So the progesterone challenge, Provera, 5 milligrams for 5 days. And then you stop. On day 6 or 7, she should bleed. If she does, then it's anovulation is the answer. You don't have to do anything. You give her reassurance. Say, Mom, this is normal. A lot of little girls have this problem, but eventually she's going to menstruate. It's just an immature HPO axis. I've seen it written that way too. That's the same thing. It just takes a while to get everything all synchronized. Now she's bleeding every month. Any questions on anovulation? Progesterone challenge is how we prove it. You give her Provera, stop it on day 6 or 7, she should be bleeding. What if she does not bleed? Then anovulation is not the problem. Everybody understand? That means she doesn't have an estrogen phase either. Everybody understand the conclusion, first of all. Remember, if you have the estrogen phase and you don't ovulate, you cannot go through progesterone phase. Well, I'm going to provide you the progesterone phase, and then you should bleed at the end. That's how I know anovulation is the problem, because I've just proven it to myself that there is an estrogen phase because you responded to my progesterone. But if you do not respond, that means you don't have estrogen phase either. You understand it, Halima? You understand it, Anam? If you don't have the estrogen phase, then I need to work up your pituitary and your ovary. One of them is not working. So hypothalamus, pituitary, ovary. Which one should I look at first? You start with the ovary. What's the best test to run to see if the ovary is working? Naif. The man Saba. Not the estrogen. Just remember this, folks. We don't normally measure the hormone coming out of a gland. You measure the signal to the organ. Physiology, you cannot fool physiology. So if you don't have enough ovarian function, FSH should rise. So we check FSH next. If the FSH is high, where's the problem, Angie? The problem's no, not pituitary, ovary. The signal for pituitary is going higher, which means ovary is not responding. See? There's too many things that affect the hormone levels. That's why we don't check the hormone. Be careful. That answer is always on the list, but that ain't the answer. Measure the signal to the organ. You cannot fool physiology. Physiology knows what time of the month it is, knows what she's doing. And at FSH, if it stays normal, then everything's fine. But if FSH rises, that means that ovary's not working well. Anna. Yeah, that means ovarian insufficient. That means the ovary's not working. Yeah. Yeah, streak ovaries will give you the same problem. Yeah, like in Turner's, the ovaries doesn't work. So we check the FSH. If it's high, then we know it's the ovary. Then you go ahead and evaluate the ovary with ultrasound. If it's low, then we know it's up here, hypothalamus and pituitary. Then we scan your head. You see, that way you understand the management because it makes sense. That's why I say learn the physiology and biochemistry of things rather than just learn how to manage things, and yet you don't know how they're coming up with this stuff. Okay? Any questions on primary amenorrhea? What about secondary amenorrhea? Let's say, Jess, your friend calls you and say, you know what, girl, I'm so glad you're in medical school because you know I have my period every month on the 15th. I can set the calendar. But you know, the last 3 months I haven't had a period. With your wisdom and physio, can you please tell me what could be the problem? She's pregnant to rule otherwise, no matter how fancy to make it sound, folks. It is pregnancy or to rule otherwise. So now we run a pregnancy test first because that's the most common. Remember, the first one was just because we just want to rule it out before you start doing things with radiation in it. But it's not because it's one of the most common causes at all. Anderson. Immature, either you say ovarian insufficiency or immature HPO axis, which means hypothalamus pituitary ovarian axis and ovulation. Yes, Anna. Yeah, go through the same steps and try to figure out where the problem is. That means, is it ovary, pituitary, or hypothalamus? And then you respond to whatever you find. Paris? Is anovulation, which causes amenorrhea. Because you can have amenorrhea without anovulation. That's why I'm showing you it's two different things, but one causes the other. Yeah. Anovulation happens first, and that's why you're not having menses. That's amenorrhea. So anovulation is therefore the most common cause of primary amenorrhea in a teenage female. Any questions on that? Now, what if
Excuse me.
who's this? Is that Mabel?
Yes, sir.
Okay, what's your question, Mabel?
Lisa, did you say that when the FSH is increased is ovarian problem?
Yes.
Then when it's decreased is coming from where?
Hypothalamus and pituitary.
Thank you. So you also said that the amenorrhea will come before ovulation.
No, anovulation happens first. We see it as amenorrhea. If she's not ovulating, she's not menstruating. So she comes in complaining, I'm menstruating. And then you get a history that says, oh, she's never menstruated. But that's because she's not ovulating. Once you finish working her up, then you find out anovulation is the cause of it. But that happens first before you get to amenorrhea. But it
Okay.
doesn't mean amenorrhea causes anovulation. It's the other way around.
Excuse me, doctor, I have a question regarding
ahead, Leslie. Go ahead, Leslie.
steps. So I always thought that you do pelvic ultrasound first to check if a uterus is present, because if the uterus is not present, you go forward to karyotype to know if it's a man or if it's a girl. All right.
Yeah, you
Right?
can do that.
Okay.
That's if they want to start down there, but you're right. If you have any reason to suspect it, yeah, then check the uterus. Okay, and then karyotype if the uterus is not there. That means there's a genetic problem if the uterus is not there. Or it could be Mullerian agenesis. You didn't have Mullerian duct to even develop a uterus.
So if I have the uterus present, then I go to FSH.
Yeah.
Check.
Right,
Okay.
so all I'm talking about right here is just the amenorrhea part. Now, if you want to see if the person has a uterus, so that means on physical exam, you should be able to feel it. If you don't feel it, okay, then we start down there and say, how come I didn't feel a uterus? Then you can start your work up down at the bottom. Yes. If you've done your physical exam and she has a uterus, then it's not a uterus problem. Then we go progesterone challenge. Do the what at that time? You can do it after that. So meaning if you do, what was the step you just said? Yeah, if you do progesterone challenge and you don't get any bleeding, then you can say, okay, well, let me just check and make sure she even has a uterus. You can do it then too if you want. Yeah, that's how most of us did it, but now some people just do the ultrasound first. I don't like to start doing tests when I haven't really finished evaluating the person. I'd rather do it afterwards. All right, so that's amenorrhea. Now, what if this cyst stays here? And then the next month, another cyst develops. Then the next month, another cyst develops, but you're not ovulating at all. So the extreme of anovulation is called polycystic ovarian syndrome, PCOS. Why is it so common now? Because it's all over the literature, folks. Because obesity is causing it. Why is obesity causing it? Because adipose tissue is producing so much excess estrogen, it messes up the whole pituitary axis. And all of a sudden now, a lot of normal women stop ovulating and then develop PCOS. That's why PCOS is so common now. Okay, it's caused by obesity. So let's go through how this happens. Whether you developed a cyst and then stop ovulating, or you were obese and then developed cysts and stop ovulating, either way. The most common presentation is oligomenorrhea. That means fewer periods than usual, or secondary amenorrhea. It just stops altogether. Does everybody understand that part? I'm going to show you how to talk it out without memorizing any of this stuff. Okay? Because one day, all of a sudden, you're not ovulating anymore. But you were ovulating last year. That's why it's secondary amenorrhea. Because all the woman comes in and says, I haven't had a period in 6-8 months. What's going on? Then you check her over, you see about a bunch of cysts all over the place. You say, oh my gosh, she got PCOS now. All right. So the presentation first. Oligomenorrhea or secondary amenorrhea. Everybody understand that part? Okay? If you're not ovulating, you cannot get pregnant. That's why, and you can't have menses either. All right, so now she shows up to you. So what you got is all these cysts that develop, but none of them opened up like that to allow the egg out. Everybody follow? So presentation. Within each cyst are the precursors to progesterone. Remember, that's what the ovary is supposed to release, progesterone, right? Well, if you got a cyst, then that means the precursors to progesterone are trapped in here. They never got out. But eventually, by concentration gradient, they're going to start leaking out. Remember, concentration gradient guides everything. And once they start leaking out, what do you got? The masculinization effects, because progesterone is androgenic. That's why all of a sudden got increased muscle mass, increased appetite, increased weight gain, polycythemia, hypertension, right? Obesity, which then leads to diabetes. Sound familiar? Everything they write about PCOS. Okay? So what's going on here, Sabu? What's going on is the precursors are all steroids. Remember, progesterone is a steroid. And steroids break down proteins and take the amino acids and make what out of them? What do you do with the amino acids? Steroids, when they break down proteins, they put the amino acids into what cycle? Gluconeogenesis. That's why they have hyperglycemia. That's why they have insulin resistance. That's why they get diabetes. And what drug do you know so we can block gluconeogenesis? Because you've learned it very well. Metformin. Why do you think metformin is a drug of choice for PCOS? That's what I say, folks. Learn your normals. Abnormals are easy to explain, but if you don't know what normal is, you try to write down and memorize everything about abnormal. Now I realize this is an easy way to understand all that stuff. And you don't even have to memorize it. You just got to know what normal is. So we got presentation. All right. Now we got all the signs and symptoms. Let's look at labs. They love to ask about labs. So hyperglycemia, I just explained to you. Hyperinsulinemia, I just explained that too. That's how to get insulin resistance. And then if you got insulin resistance like a diabetic after hyperglycemia, what do you get? Hypertriglyceridemia. See that? Same thing we talked about in biochemistry. Once one goes up, the other one's going up after because glucagon controls both of them. You understand, Nolan? Understand, Kathleen? All right. Then the other thing they want you to check, folks, is LH over FSH ratio. If you're not releasing progesterone, then there's nobody feeding back to inhibit LH. That's why LH rises much higher than FSH. So LH over FSH ratio of 2 to 1 or greater. Again, so we got glucose, triglycerides. All right, we got high insulin we can check. We can check LH over FSH ratio. These are just labs they like to test you on. Any questions on that? Now, the question then becomes, how do we manage this thing? Well, obviously, if she's obese, the first thing is get her to lose weight. If she qualifies for bariatric surgery, get her in there. Okay, because this is only going to get worse. If she's not, first thing to do, hang on, let me just finish this. If she's not obese, the first thing you need to do is stop her periods altogether. Gloria, how do I block your periods? Say it. It's called OCPs. OCPs, first line. That doesn't work, Leuprolide, just the same way we did it before. You can't block it from the periphery, block it from the top. Leuprolide is next. And then when she gets ready to get pregnant, And now what can we do to help her ovulate smoothly? Take what off? Take what off? Take the OCPs? That won't work. She's not ovulating. Is there a drug we can give her to help her out? I said we'll help you. No, that's not first line. GnRH lupuli is third now. What do you do first? I gave you guys the drugs for ovulation. Why don't you just follow that? I know. Yeah, letrozole is first drug, then clomiphene, then lupuli. All right, that's it in order, folks. Always look for the in order. I told you the best trap is the one you pick an answer, but it's out of order, so you never got a point for it. But you thought you did. All right, so you got to know things. Letrozole is now the best ovulatory drug. Clomiphene is now number 2. Lupuli is now number 3. And you're going to learn later, HCG is number 4. It's the least reliable. And that's what we do. Whenever she's ready to have babies, give her one of those medications, pop, pop, pop. 3 or 4 of them will finally ovulate, and then she gets pregnant with one, that's it. And then we put her back on OCPs after she delivers the baby. Yes. Good question. Does any information shows that bariatric surgery increases fertility? Slightly does, yes. I was just reviewing that a few weeks ago. Yeah. So bariatric surgery, if you get her to lose the weight, there was a slight increase in fertility. Even metformin. When you give them metformin increased the ovulation rate. Yeah. It's just not reliable as an ovulatory drug, but it did clearly increase in the study. Okay. Isis, you have a question?
Yes, Dr. Francis, could you repeat why in PCOS, the patients gets hyperglycemia? I'm sorry, I didn't follow you when you were explaining.
The hyperglycemia is from the precursors for progesterone. They're all steroids. Remember, progesterone is a steroid hormone, right?
Correct.
Yeah. So 17-hydroxy progesterone, 17-hydroxy pregnenolone, DHEAS, they're all androgenic steroids. But steroids break down proteins and put the amino acids into gluconeogenesis. You understand that?
Okay, yes.
That's
got
how,
it now.
that's how you get hyperglycemia. And then after you get hyperglycemia, what do you get? Hyperlipidemia. And now you got insulin resistance. And then before you got diabetes. It's all straight out of biochemistry. You mess one up,
Thank
the other
you.
ones get messed up too. Yeah, no problem. Syed, question.
Question regarding letrozole. So I was a bit confused. I think earlier you said it can be used as an OCP, but how can it also like be used to as like a
No, letrozole is an AI, aromatase inhibitor. It's not used as an OCP. It's used to induce ovulation. It's not used as to suppress anything.
Oh, okay. Maybe it was like for the endometriosis, was it? Or
Yeah, it's to suppress estrogen production by adipose tissue, though. It doesn't suppress your period.
oh, okay, thank you.
Yeah. Question, Stephen?
I don't understand day 10, if you're secreting estrogen, you think that stimulates GnRH? Isn't everything a negative feedback?
Yeah, remember estrogens feedback to inhibit FSH and then to inhibit GnRH only in the first 10 days. I told you between day 10 and day 14, probably again recess those receptors. Now it's stimulatory. That's how you get GnRH to surge. That's how you get LH and FSH to surge, but LH surges faster. Pineal gland will reset what those receptors will do. The response is totally opposite. Now you're going to stimulate GnRH to come out, and FSH and LH will come out. Rather than feedback to inhibit in the first 10 days, all of a sudden now it's doing something different. Only between day 10 and day 14. Otherwise, it's feedback inhibition. Yeah, that's how we know it's time sensitive, which means pineal gland controls it. All right, let me see. So we've done an ovulation. All right, now let's go into the luteal phase. So everybody understand? Hang on. Let me remind you of my transition. What have I done? I've gotten through the 7 events that occurred between day 10 and day 14. I've ovulated, and now theca externa, which is now called corpus luteum, is producing progesterone, which is why we're going into the luteal phase, because progesterone then controls the luteal phase. All right, Mabel, your question.
So you said that for ovulation induction, we have to give some medication. What is the 4th medication that you called?
For what?
For us for induction of ovulation, you called
Induction
it.
of ovulation. I just gave you the 4. Did you catch any of them?
Yes, yes.
What was the first one?
I need the first one is Lupro. Is that?
Letrozole is number 1.
Okay,
All right.
letrozole, then
Clomiphene is
clomiphene
number 2.
and leuprolide.
Leuprolide is number 3, and HCG is number 4. That's the 4 I gave you.
ACG. So what is ACG, please?
The HCG for pregnancy, human chorionic gonadotropin.
Okay, it said ACG. I was like, what is it? Okay.
Okay, HCG is the same one as test for pregnancy. All right, so now we're going into the luteal phase. Progesterone takes us in there. Let's look at the 3 things progesterone will now do. Read. No, let me figure out Sandra first. So Sandra, we're going into the luteal phase. That means it'll go to the breast just like estrogen does, but look what it does, increase glandular growth. You understand that? This is why for a female, therefore, her breast will enlarge in size because you're stimulating the glands to enlarge. That means the breast has to enlarge. The breast will always enlarge in the 2 weeks before menses in a female. This is why a female will start complaining about breast tenderness in those 2 weeks because the glands are enlarging. That means they're pulling on her bra straps quite a bit and it hurts. Okay, now you know. What if I stimulate the glands too much? Then they'll inflate into a bubble, which we call a cyst. That's why a cyst is the most common breast mass. This is from the neoplasia lecture. Now you know how it got there. This always explains why too much of that causes fibrocystic disease. Most common breast tumor after age 25. Now you know why. If you stab one of the cysts or fibrocystic disease with a needle, what color is that fluid, Nolan? Yeah, green. Remember, it's therapeutic and what's it, diagnostic at the same time. If it's green and the bubble go down and stay down, there it is. You've proven the diagnosis. We don't do anything else after that. All right, but anyway, I just want to show you how it got there. Glandular growth. This is why a female put on all these IUDs, which are progesterone only. Why do you think they complain about breast tenderness? Now you know why. Any questions on that? Yes. No, this is luteal phase I'm in now. I'm done with ovulation. Yeah. No. During the ovulatory phase, it's just ovulation. Yeah. The other 3 areas are not doing anything different. Now we're entering the last 2 weeks. That's progesterone. So we go back to the 3 places and see what it does. Glandular growth. This is why pregnant women increase their breast size. This is how one of the ways a mother in Nigeria knows when a little girl is pregnant. Because the little girls will say, no, mommy, I'm not pregnant. You should see my girl, put out your hand. You liar. Put out your she can see, I'll tell you about the line that tell you you're pregnant, but the breast, she knows what size your breasts were last month. Why they're bigger this month? Mom knows you're pregnant. And because we don't have no beta ACGs in Nigeria. We live in the forest, man. So moms know those. I'm telling you, moms know everything in Nigeria because they're forced to know because they're too poor to run their daughter to a clinic. The nearest clinic is hours away. So we don't run them anywhere. But it's amazing how those mothers know you're pregnant. All right, so that's one of them, glandular growth. All right, then look what else it does. Endometrium. It stimulates coiled arteries. All of a sudden, you got a bunch of coiled arteries in the uterus. All of a sudden, it's oozing blood. See that? Getting ready for menses. See it? Arteries start producing more RBCs. The progesterone that's high has the sequence of erythropoietin in it. The woman makes the extra RBCs that she's about to lose every month, which makes sense. Otherwise, every woman would be severely anemic in just a few months. Okay, but she actually makes the extra blood that she's about to lose, which means the net should be right back to baseline again. Okay, coiled arteries. And then what else? Deposition of lipids and glycogen in the wall. Why? To get ready, blood supply and food for the fetus in case she gets pregnant. So it is progesterone's job, Melissa, to prepare the way for that fetus. I need the blood. I need food. Burgers? No. Lipids and glycogen. Fries? No. Lipids and glycogen. So in other words, the uterus is now engorged with blood, lipids and glycogen. You understand, Melissa? This is what we now call the endometrial stripe of pregnancy. When you do that first ultrasound, why do you think we're measuring endometrial stripe? That you want to see if the endometrium is thicker than usual. That means, oh, she's already preparing for implantation. She's definitely pregnant. But on the test, they'll just say thick endometrial stripe. I just want you to know what that is. It means you're pregnant and implantation is, the wall is getting ready for that implantation. What if I give you an implant that's Norplant, Explanon, or IUDs, they're all progesterone. What's going to happen to the uterine wall, Solange? Thicken with what? Lipid, glycogen, and coiled arteries. So watch my hand. Oh, let me zoom in a little bit. Hey, come on, come on, come on. Okay, here's the uterine wall. And then all of a sudden you give that person progesterone. And then here comes the coiled arteries coming through the uterine wall like that. That means they outgrow the uterine wall and start spraying blood into the uterus like that. You know what that's called? Breakthrough bleeding. It means that coiled arteries are breaking through the wall like that. That's what breakthrough bleeding is. That's the number one side effect of every progesterone contraceptive. Mirena, Skyla, Loletta, all of them. You know, Nexplanon, all of them. Norplant, all of them. Breakthrough bleeding, number one side effect. I just want you guys to understand what breakthrough bleeding really is. Okay, that's the coiled arteries just popping out of there. Well, if the bleeding gets real bad, we got to do something. We got to do something, Zena. Watch my hand again. Here's the wall. Here's the coiled arteries. How can I get this wall to start proliferating and therefore cover up the vessels so that bleeding will stop? Progesterone doesn't stimulate proliferation. Match it up to word. Cynthia? Constriction doesn't match up either. Maria? It's called estrogen. Look up the treatment. IV estrogen for 3 to 5 days. Look at that. I told you it's all from basic physiology. But that's not what's being taught to physicians. That's the part I can't stand. You always just tell you that's the way that we do it. That's the way we do it. No doctor ever seems to know why we do anything that we do. All right. That's why we do a lot of things wrong. If you don't understand what it is you're doing, after a while, one day you're going to forget it. And then you just wing it and do something else and somebody gets hurt. Okay. All I got to do is talk it out. That's why I talk it out a lot, folks. Talk it out. That way I can see the physiology again, and then I can come up with the therapy because I now understand it again. Solange. Is this why some of the oral contraceptives can make you fat? Let me tell you what the literature says. The literature says that weight gain is not a problem. But when you ask the women who are on it, half of them say, no, they gain weight. Okay, and that's what she's telling you. Do you gain weight? Are you wondering what? Yeah, I'm telling you, there's no way that literature can fool me. I'm telling you, we don't talk to gain weight. You telling me it doesn't? Here's what that means, just so you guys understand what it means. It means when they did the study, because they did a study, and what they do, half said we gain weight, half said we don't gain weight. Guess what? It was a wash. And that's what they're talking about. But they don't tell you that's what they mean. That's statistical. It doesn't cause weight gain. Not that nobody gains weight. It's just that when you use statistics, it's a zero. Yeah. So there's no way they can convince me. Oh, but I got to tell you that because on the test, if they say, well, yeah, the answer is you don't gain weight. You got to pick that answer. I'm just telling you. But in the real world, yeah, please. If a woman calls me and says she's gaining weight, I say, yeah, it's those pills I just started you on. Yeah, that's normal. Your key is to be open with her. Because otherwise she's going to stop taking the pills. Once she gains too much weight, she says, no, I don't like these pills. And that's it. She stops the pills altogether. Now she doesn't trust anything else you want to put her on. Yes. Progesterone stimulates appetite. That's what I'm saying. There's physiology behind all of it. That's what I'm telling you. That's why when they say, oh, it doesn't cause weight gain, I'm like, okay, how are you figuring this out? And then when I looked at them, oh, okay, it's just because half said this, half. I said, now I know what they're talking about. But that's not the real world. The real world says, yeah, you may gain weight, but just call me if you think it's too much. Okay? Then we lower the progesterone. But anyway, we've done endometrium, and let me make sure I've got everything covered. Yes. No, one more thing. Hang on, let me just make this other transition. Here's the things you need in the endometrium to implantation occur, right? So what if I were to block that implantation? Does everybody understand, Oxy, that you can't get pregnant? Everybody follow that? Emergency contraceptives. Mifepristone. Mifepristone is what is it? Progesterone receptor blocker. That means, yes, you had a lining, and then today you don't have a lining anymore. That's because I can make it disappear. Mifepristone is also known as RU 486. I'm sure you guys have heard it on the news. Why? It came out of Europe, and when it came here as birth control, the Right to Lifer said, oh, no, that's not birth control. That's called an abortion. And it is an abortion. So they moved into a chapter called abortifacients. But it's one of the drugs you can use, Plan A. Or you can call it morning after. That means the earlier you use it, the better. It's good for up to 72 hours, but it's best used in the first 24 hours. Yes. No, levonorgestrel is coming up. There's no longer, there is a way to make it morning after, but this was the original morning after pill. Yeah, this was the original one. Yeah, levonorgestrel, that's what I'm going next. This is Plan A. This was Plan A. Now, I didn't say Plan B, this is Plan A. So Plan A was come in as early as possible. I will give you this thing that block progesterone receptors. That way, if you did get pregnant, the baby has nowhere to implant and it will just spontaneously abort. Everybody understand that? So that's why now it's listed as an abortifacient. Okay, Mifepristone. What about Plan B? Plan B is levonorgestrel. How was this developed? In the old days, doctors always thought things through and came up with a way to help women. So let's say you missed your period and you think you must have got pregnant. All right, the doctor would tell you, okay, take 2 of those progesterone pills I gave you right away, and then repeat it in 12 hours, which means you got a big surge of progesterone in these 24 hours. Everybody follow? And then tomorrow, no more pills. Yeah, her body thinks she just came to the end of her cycle. She'll slough off tomorrow. It was a way to force the lining to slough off. That means same thing. And that's why it's called Plan B, because this was the second one they came up with. Okay. Levonorgestrel works all the way out to 5 days, but best used in the first 3 days. Just like mifepristone works in the 3 days, but best used in the first day. Okay. Some new ones now called ulipristal. Ulipristal. I might be off by a letter, but you'll recognize it. Ulipristal is a progesterone receptor modulator, is the way they say it, which means just like tamoxifen relaxant, it can block the receptor. That's all you're doing, just like mifepristone. And ulipristal works all the way out to 5 days too, but best used in the first 3 days. Now, you can also use the IUD, copper IUD, as a emergency contraception. So copper IUD can now be used. How is this going to work? That means if she had sex last night, let's say it's a Sunday, and she comes to see me on a Monday, I can just implant the copper IUD. What's it going to do? Cause inflammation right around the cervix, so that any sperm who tries to pass that area will just die, just dissolve in the liquid. 99.8% effective. Copper IUD is now able to be used as contraception for an emergency. Leslie, you were first?
Yes, I have a question of the mechanism of levonorgestrel.
Yeah, levonorgestrel is high progesterone. A company just saw what doctors were doing. They didn't even test it. They heard doctors were doing this. 2 pills when I see you, 2 pills in 24 hours, in 12 hours, tomorrow, nothing. And you will start sloughing off the lining tomorrow. So what they did was put all 4 doses together as 1 pill and say, you can do the same thing with this 1 pill now.
Yeah,
And it worked.
I have when I was doing my OB-GYN rotation, Plan B was very expensive. It's very expensive. So the doctor just make patients take all the OCP pills from the clinic, and it's cheaper and it's the same.
Much cheaper. It's the exact same thing. Yes. See, that's what I'm saying. And because my partner and I, we serve the poorest part of the city, you got to think of ways to do the same thing as what the FDA is telling you. And it's cheaper because I'm helping people who are poor. They can't afford the expensive pills. And so you just say, take 2 of these and then do the same thing in 12 hours. If I see you in the morning, I say, okay, 8 p.m. tonight, take another 2 pills. And that's much cheaper than going out to get one of these. Okay. Yeah, but it's the same exact thing. That's how the company got that idea. Yes. Why is there weight restriction? Oh, good point. I'm about to do that in a second, but weight restriction, there's weight restriction on all OCPs. I think the upper limit is 50 No, BMI of 50, I believe is what they said. That means if the person is that heavier than that, that means they got so much adipose tissue. What does that mean? Fat soluble hormones, like the one I'm about to give you, is gonna be sucked up into the adipose tissue. I can only give you so much before I hurt you with it. That's why they say, okay, certain weight limit, don't give any more than that. That means let's try something else. Yeah. It decreases efficacy because adipose tissue is sucking up all the hormone. Yeah. No, without weight loss. Yeah. All right. Wait a minute. Jess was next. Since progesterone increases spiral arteries, yes. Why do we get bleeding or do not get bleeding? Yeah, if you give progesterone only, that's all the IUDs, all of them are progesterone only, all the implants, progesterone only. Breakthrough bleeding is one of the most common side effects. No, it's temporary. That means if your body sees this going on, eventually your body will respond by having this happen. But I can speed that up by just giving you IV estrogen. Okay, yeah, so that otherwise you can never use just progesterone only contraceptives if bleeding was that heavy, it was that bad. Typically, the breakthrough bleeding happens in the first 1 or 2 months. After that, the body's figured out what to do and just stops it, and then they get used to it. That's why only when it's severe, they actually even end up in the emergency room with it, and then we hospitalize them for IV estrogen. So you accelerate a natural process. All right, question, Mabel?
Sir, please, I have 2 questions. Please, did you say that we should use a levonorgestrel at the first 2 to 7 days, 3 to 7 days?
No, I said 5 days. I've never said 7. I said it
Okay.
works for 5 days, but it's best used in the first 3 days. Same thing, ulipristal works out for 5 days, best used in the first 3 days. Copper IUD is best used the day after. Put it in so the inflammation starts right away before that egg migrates down. And therefore, before the sperm can even come up, that's it.
Okay,
They
so
all
that
die.
means in copper IUD, if somebody have sex today, tomorrow you can fix the copper IUD,
Yeah,
right?
you can put the copper IUD tomorrow to stop her from getting pregnant. And it works. Okay. All right. Now, if everything goes well in the cervix, progesterone thickens the mucus. Why? Because now she's ovulated. There's an egg that can be fertilized. So she wants to put a barrier between her and that sperm. That means if the sperm try to comes through, it's going to stop right there at the cervix and die. This cervical mucus is so thick, it keeps out 99% of sperm. When they figured that out, what did the company do? What if I just wrap progesterone around your cervix? It's called all the IUDs. Progesterone, Mirena, progesterone, Loletta, progesterone, Skyla, progesterone. Folks, that's how they figured it out. When they realized, oh, the mucus is thick enough to keep out 99% of sperm, why don't we just put an implant in there with just progesterone, and now we call it an IUD, just progesterone, or implant, Norplant, Nexplanon, same thing. The thing is the mucus, but the benefit of the mucus in a normal female is that it keeps out 99% of germs as well. It has to really keep the germs out, but it also keeps 99% of sperm out. So that's why I like when a woman is pregnant, close to delivery, notice that mucus plug will fall out. She can tell you the day it fell out. That's because it stayed there after she got pregnant to protect the baby all 9 months, make sure germs can't get in there. Okay, and that way when she's ready to deliver, it'll pop right out. Okay, so that's how all those IUDs work. Then next issue is, wait a minute, I want to make sure I didn't get her. No, okay, that's IUDs. Any questions on those? All right, because let me just make my transition to birth control, because that's where I'll take it after lunch. Birth control says, I want to stop you from getting pregnant. If I want to stop you from getting pregnant, Meha, that means I got to stop you from ovulating. If you don't ovulate, you can't get pregnant. Does that make sense to everybody? And how can I stop you from ovulating? What hormone is responsible for ovulation? Huh? LH is. So what hormone would feedback to inhibit LH? Progesterone. So Meha, I just told you how all birth control pills work on the market. It's the progesterone in the OCPs, folks, that stop the pregnancy because they block LH, feedback to block LH. Without an LH surge, there is no ovulation. There's no egg to fertilize. And that's why OCPs or all the hormonal contraceptive methods, 99.8% effective. Now they're calling them LARCs. That's why I left the two words in. Long-acting replaceable contraceptives versus short-acting replacement. The pill is short-acting. Teenagers love the pill. I mean, a lot of older women like the pill too. But the rate of pregnancy with a long-acting, 0.2. No, not 0.2, 0.02, sorry, 0.02. That's very small. And yet it was 7% with the short-acting. That's a no-brainer, folks. That's a huge difference. That's why they're encouraging every physician to push towards the LARCs for women, but don't tell her she needs to take it. Let me just tell you this before we break. If this is for the guys, listen carefully. If you tell a woman what birth control to use, 90% will never use it. Why? Because women get offended if you tell them what to do with their bodies. So just letting you know as a man, just don't make that mistake. That woman would never listen to you after that. That's what they found in a study, 90%. They don't like a doctor telling them what to do. You can suggest it, but don't tell her you should do that. Never say you should. I think you'll be, or some doctors become so, especially if it's a poor woman. Well, you need to stop having babies. You don't realize your prejudice is coming out. And you're telling her you need to do something about having all these babies. That's it. She'll never do it because you're trying to make her do something with her body and you don't have that right ever. Okay. So be careful. And after lunch, I'll talk you through what the article said about how to get a woman started on birth control without getting yourself in trouble. All right. Because again, you don't want to try to make somebody do something and in the end, they didn't do it. That means all that effort you just put through was for nothing. Cynthia. Suggestive vasectomy works for me. No accidents here, babe. After 2, I said, I'm done. Tie it, burn it, cut it. Shit, man, I don't care. That way, no mistakes. I don't want to hear about no mistakes. I'm done. Okay. Having children are expensive, man. I don't know how people have 4, 5, 6. Jeez, that's a lot. If they want to have a baby, adopt. Adopt. That's what I said. I said, I'll adopt if I change my mind. Yes.
Will you adopt me?
Will I adopt her? Maybe wants to be adopted now. Okay. I said, what's your question? No, how they get pregnant? Nothing works 100%. That's all you can say. Yeah, nothing's 100% proof. So that's why there's always a chance that still everything goes well and goes around the hormones. Yeah, so let's stop there. Abdullah, you had a question. Last question. Hang on.
Yeah, with the copper IUDs, if it's increasing inflammation, can't that lead to scarring eventually?
Oh, good question. Can a copper IUD cause scarring of the cervix? Well, the copper itself causes a gentle inflammatory fluid to build up around the cervix. They've got women with IUDs in Europe, 30 years and counting. They have never taken it out. Okay, it works. You can leave it in as long as you want. America says 10 to 12 years. That's just to make money. It's got nothing to do with medicine. Okay.
Also, can it
But
cause?
wait a minute, let me just show you give you the data. And these women who've been on it for almost 30 years now, they found no increased incidence of cervical stenosis from scarring, like you thought. The inflammation is so mild, it doesn't cause scarring to cause stenosis. No increased incidence of ectopics, no increased incidence of STIs, no increased incidence of UTIs or fetal loss. None. 30 years worth of data, folks. 30 years. So just so you know, that data is out there. All right, so a good place to stop. Any other questions? Let's stop here. Stop back at 120. All right, let's finish it up. A bit more to do with the women and then straight into the men. All right. Let's see. Oh yeah, birth control. That's where we left off. The first lesson they want you to know about birth control, remember as before I said, never tell a woman what she ought to do. You advise her. And the question they say you ought to ask is just, have you thought about family planning in the next 5 years? That means it's wide open, it's non-judgmental, there's no confrontational. Let her then tell you, yeah, I plan to have children in the next 2 years. Okay, then we don't have to worry about birth control. But if she says, well, I don't plan on having children for the next 5, 10 years. Okay, well, have you thought about birth control? And then she will tell you what she's thought about. And most women will start with whatever their friends have been using, okay? But, you know, let's say she says, well, my friends are on pills. So I thought about that. You say, well, have you thought about longer acting methods, which means you can take it for 5 years and not have to think about taking it every morning. So that way, notice there's always have you. That way you're causing more discussion. You're not telling her what to do. You just have you thought about this. Like I said, the LARCs, long acting, are way more protective than the short acting. And it turns out most women don't take it the right way anyway. They forget. They're going away for the weekend. They forgot their pills at home. That's 2 days. They're going to miss a pill now. All right. And that comes as a problem. They're always calling you. Oh, I forgot this. And then you got to know how to respond to that. Okay. All right. So that's an issue. Next issue. How do you start? Before it was, you start her on pills and she would start on the Sunday following her next menses. So if her next menses was on a Tuesday, she would start that Sunday. Any day before that Sunday, she would just start on that Sunday. That because it was a day that people could remember after church or before church, that kind of thing. Then they did a study called Quick Start, meaning what if we just start birth control the same day you come to see me? Would it be just as protective? And the answer was yes. It was the exact same protection. So now Quick Start is the standard care. You start birth control the same day the woman comes to see you. Everybody with me so far? So now the next issue is what do we do before we start the birth control? Okay. Again, we're pushing towards the LARCs, but if she wants a short act, that's up to her. But there's things you got to do. Number one is always a pregnancy test. You don't start any kind of birth control and then you find out she's pregnant. And now if anything happens, she's going to blame you for it. So you must do a pregnancy test before you start any of it. Number two, you rule out STIs, especially in young women or any woman with risk factors, meaning if you change men in the last 2 men in the last 6 months or 3 in the last year, then we're going to check you. Okay. So check for STIs. And now remember with the NAT test is easily done. She can go in the bathroom and do it herself. 1 drop of urine, bring it back. That's it. Okay. And because she's a patient of yours, you know she's going to come back and find out the results, or she's definitely going to call you and find out the results. All right. If any concern, treat it right then and there. If not, don't treat. Wait till you get the results. Remember, now you only treat what the culture tells you. Only cover chlamydia if chlamydia is there. Only cover gonorrhea if gonorrhea is there. We don't have where you have to cross cover anymore. The NAT test is that specific and that sensitive that we trust whatever it says is positive. Any questions so far? All right. Then you want to get a history. Have you had any history of blood clots? Then we can't use hormones. Okay. Do you have any unresolved bleeding that you haven't told me about? Then we can't start birth control yet. Anybody follow? All these things got to make sense to you for you to remember it. If you just memorize that list, it won't make any sense. You won't remember it tomorrow. Okay. So those are things that concern me if I'm the physician. And I say, okay, I don't want to start hormones and then cloud the issue and then I miss something like cancer. Okay. And then you're in big trouble. So once everything is cleared up, you start whatever birth control she wants. All right. The IUDs, the progesterone IUDs, all of them last 5 years. That's why they said long acting, 5 years. Nexplanon and Norplant, those are usually 5 years as well. The copper IUD, 10 to 12 years. All it does is cause a little gentle inflammation around the cervix, and it kills over 99% of sperm. Okay, but it doesn't cause any bad things that people are worried about, you know, like infections, STI, UTIs, ectopics, abortions, doesn't cause any of that. You got 30 years of research in Europe, and it has not shown any of the bad things that people were worried about. Okay. All right. Any questions so far? Yes. Yeah. I mean, so you're saying, so he was asking if you have obesity, so beyond, I think 50, BMI of 50 or greater, and some of them are BMI of 25 or greater. No, that can't be it. It's gotta be 50. Yeah, so 50 or greater, you can't use their pill because the dosing is based on you're under 50 BMI. All right, so that means you try something else. Okay, that means you want to use copper IUD. This way you don't have to worry about hormones at all. Okay, because if they're over that, the manufacturer's BMI peak, you cannot use that pill, because that means that dose of progesterone is not going to be enough for that person to stop the pregnancy. That means if she gets pregnant, she's going to turn around and blame it on you. It's called a wrongful life lawsuit. You made me bring in a life that I really didn't want. Man, people always find a way to blame somebody else for everything. All right. But anyway, just so you know, that's why they're going to test you on it. All right. So what about the pills? Here's how you start the pills. You start the pill just like anything else, quick start. And you say, okay, take one pill every morning at the same time. You should do it around an activity that you do every morning. So that means if a female, there's a special merit where she goes to comb her hair and put on her makeup, have the pill sitting right there. That way, as soon as she shows up to put on her makeup, do her hair, wham, she knows, take my pill. Okay? Because otherwise, if they just keep it in their purse, guess what? Some mornings they're going to forget. So you have to advise this to them so that they remember, okay, let me see, where am I going to put it? Oh, yeah, where I put my makeup on. Or where I put my keys, because I can't leave in the morning without my keys. That way she knows, take your pill before you leave the house. It's better take it at the same time every day. Because remember, circadian rhythms are based on a 24-hour cycle. So if the brain sees a hormone comes in every 7 o'clock in the morning, guess what? It sets a 24-hour cycle based on that. And therefore now everything is completely suppressed the way you want it. If they jump around, you might confuse your pineal gland. If the pineal gland, like jet lag, gets confused, it shuts down for 2 to 3 days. That means you can get pregnant in those 2 to 3 days. That's why you don't want the pineal gland confused. And when they did research on teenagers, these were young girls, and found out, well, how do you take your pill? Man, they found out 9 out of 10 don't even know how to take their pills correctly. But it fell back on the physician, because the next question was, did your doctor review with you how you ought to take your pill? Nope. He just gave me the pills. Take one every day. See? Now, I'm not sure why doctors don't do that, but you should. There's a code for educating people. Doctors always complain, oh, I don't get paid for that. Yes, you do. The problem is most physicians have never studied the code book. I mean, I had to learn all this on my own, because there's no class for it. I mean, now they got classes because they're showing that doctors, they had cases where doctors can double their salary just by using a code that they didn't even know even existed. I went through and I happened to find one because I love teaching, obviously. So I found codes like for asthmatics. I was interested in asthma, how to keep them stable. And there was a code for educating in asthma. All I gotta do is ask one question. How is your use of inhalers? That's it. And that means in my chart, I said, ask the patient about inhaler. That's it. That's like an extra $15 for 2 seconds of writing. Multiply that as how many asthmatics you see every month. That's a ton of money. So when doctors whine and cry, folks, it's because most doctors are bad businessmen. They don't take the time to do the stuff they ought to do in order to get the reimbursement. The codes are there, but it's not like they're going to come and tell you, hey, doc, you're not charging us enough. No, that's your business. And that's why people are making money now just coding for doctors. See, but you're paying them, whatever, 10, 20,000 to recoup 100,000 for you. So they're making a ton of money now because doctors just are pretty lazy about coding. So folks, there's coding for education. So please, when you get out there, just look it up. That way you make a commitment. That means when it comes to birth control, make a separate office visit where all we're going to do is talk about birth control. Don't kind of mention it as he's going out the door for something else that she came in for. This is something you have to sit her down and let's discuss all the things you need to do. Take it at the same time. Make it around something that you do faithfully every day. Okay. Any questions on that? All right. So now, what if she calls you? So, okay, let me just say, how do I start it? So I say, Miss Smith. All right. I turn to the page in the PDR. You see all kinds of pretty colors, but there's a science that they're going to test you on. And that means you start with the lowest dose of progesterone that suppresses LH. It's like 600 milligrams or microgram. I don't know if it's micro or milli, but 600 is the number. So I just turn to that page and it gives me about 100 pills. Take your pick. They always say, get familiar with one pill in each category so that you know, just keep using the same ones. Okay. So for me, I always remember lowest dose. So the lowest in his name, just reminded me, or a Demulan. Okay. So I said, Miss Smith, take one of these pills every morning. Then every pack, there's 21 pills that are real. Then there's 7 pills that are just, powder. Why? Just so she has something to take every morning. Because if you say, well, then 7 days later, take another, forget it. She's going to forget. So that's why a pill every day till the pack is done. Everybody understand? If everything goes right, she'll take those pills. And I say, well, call me back in a month and tell me what happened. Notice I don't tell her what to report on because you want an honest report. If you say, well, I want to know about weight gain, that's all she's going to report on. Yeah, I gained weight or I didn't gain weight. That's it. You don't get the whole picture. Let's say, come back in a month or call me back in a month and tell me what happened. That way you get a full report. Okay. Now, if you actually blocked her ovulation, then Mancy should drop by 90%. So let's say she says, I bleed for 6 days. That's her baseline. I give her a pill. She takes it every day. Remember, until I tell her she's protected, she's supposed to stay on condoms. Make sure you use condoms with her husband or boyfriend. Till I tell you you're protected by those pills, you're not protected yet. Okay? Because some of them think as soon as they start the pill, they're protected. No, you're not. It may take me 2 or 3 months to get it right. But that's what you're supposed to tell them. Until I tell you, use condoms. Okay. So she calls me back in a month and says, I normally be there 6 days. This time I only spotted for 1 day. I said, oh, good. I cut it down by 90%. That's the right dose. And the articles say now, write prescription for 1 year. Writing prescription for 1 month. Then she got to remember to call you by the end of every month for another month. They said, don't do that. Give her 1 year's worth. Once you get the right dose, 1 year at a time. Okay. It just cuts down on the forgetting. That's if I got it right on the first time. Second scenario. She calls me back in a month. She said, I know it'll be for 6 days. I bled for 5 days and spotted on the 6th day. Did I block it? How's it? No, that's not 90%. Maybe 5%. That's about it. So I said, okay, that's not enough. That means I need to do what? Give her more what? I said, no, we're working with progesterone. Progesterone blocks ovulation, not estrogen. That's why you just turn the next page. There's the next higher dose of progesterone. Take your pick. Just a lot of pretty colors, folks. But it's the science that they will be asking you about on the exam. What is the next step in your management? I mean, you got to understand what this woman just told you and know that she needs more progesterone in her pills. That's it. Just increase progesterone in the pill. They don't even want you to know the names of the pills. Just increase progesterone dose. Okay? Because there's so many of them in the market. Start off with the lowest dose of progesterone, correct? No, 1 month follow-up every time until you get the right dose. Because she's not going to know if it worked right till the end of the month. And then she can tell me, did you see a bleed for 6 days or bleed for 1 day? Then she can tell you. All right. So the first scenario, you got it right on the first try. Give her a year's worth, see you back in a year. All right. But remember, you always tell her, you call me at any time if you have questions. Second scenario, I didn't get it right. She needs more progesterone. Just increase the progesterone dose. Third scenario, she only spotted for 1 day rather than bled for 6 days. Lynn, did I block her ovulation? Yeah, I blocked it. But she says, Doc, I'm uncomfortable with that. Now, who would ever tell you that they're uncomfortable with making the period go away? Older women don't like it. Why? Older women equate normal vaginal blood flow every month with normal femininity. They don't feel right. If they don't see blood every month, they don't feel good as a woman. I'm serious. They will tell you, Doc, I don't like this. What do? You add a little bit of estrogen in it. That means it builds a little bit of layer that sloughs off at the end of the month. Now they're happy. But at least they're spotting a little bit, not because they're ovulating, but because I created a little lining for them. That's it. That's the third scenario. Any questions on that? Okay. Next scenario. She calls me and she says, hey, I forgot a dose yesterday. Man, what should I do now? Double up today. Continue. You're good. It takes 3 days to release the HPO axis. So if she misses 1 day, double up the next day and continue. She misses 2 days. That's a weekend getaway. You know, a sleepover for teenage girls, and they forgot to take their pills with them. You tell them double up for 2 days then. Double up on Monday, double up on Tuesday, continue back. You're good. But once they miss 3 days, that month is released. Anybody who misses 3 days, that pack is no good. You tell them throw away the pack, use condoms. We're going to start over when you start menses again. And we keep going till we got it right. Any questions? Those are scenarios they're going to test you on. What are you going to do? And you got to know how to respond. All right. That's the pills. All right. Obviously, the IUDs are better because you put them in and you don't have to worry about for 5 years. 5 years. Copper, 10 to 12 years before you even have to worry about it. And that's why they're so much better because there's no forgetting anything. All right, Anders. First day you see them. No, now Quick Start says, see, first day they see you, they can start the pill. Yes, it worked just as well as starting on that Sunday after your period begins. We don't do that anymore. Any questions on birth control? Karis? If you're on the long acting, the LARCs, if you're on the LARCs, long acting, are you ovulating? If you're not, then what proliferation is going on? Good question. When we started birth control in women, way back whenever, all right, it was progesterone only. All right. If you have a doctor who argues with you and say, no, it's the estrogen there. You say, okay, not what I do. You know, again, for what I understand, well, I really don't understand. You got to break them down right here. All right. So you say, listen, if one were to think that estrogen is the one that actually stops you from ovulating, how many estrogen only birth control pills can you name? 0. There aren't any. That's how you shut it down. So the doctor who's arguing with it has never even thought about it. How come there's no estrogen only if that's the one that's stopping me from getting pregnant? No, it's a progesterone. There's a ton of progesterone only everywhere. That's because progesterone is the one that actually stops you from getting pregnant because it blocks LH. The surge, without the surge, there's no ovulation. Everybody clear? All right. The problem is if I give you progesterone only, which we do, I'm going to feedback inhibit your LH, but I'm also going to feedback inhibit your GnRH. That means I'm going to shut off your whole cycle. Everybody understand that physio? Feedback inhibition is the rule. Doesn't matter if you never read it before. That's the rule. That means if I shut down your whole cycle, for a woman, that's not good. Why? She needs estrogen for coronary artery disease protection. Remember, vasodilation. Muscle light keeps her blood pressure low. It raises her HDL. Do you really want to take that away from her? No. So that means if I'm not thinking about it and I just start it non-discriminately, guess what? You put her in a medical menopause, and now before you know it, she's dying from a heart attack, and then the parents turn around and sue you for it. Okay? So that's why they said, okay, what are we going to do? Second, a female needs her estrogen to protect her from osteoporosis. You don't want to take that protection away from her. So they say, you know what? Let's add estrogen to birth control pills. Estrogen in OCPs, folks, was an afterthought. It was never in there in the beginning. They said, because she needs it. So then they added 150 micrograms of estrogen to birth control pills. And then they started to do the research around the country and around the world and say, how much estrogen does an ovary put out in the average female? When they finished the studies, it was 30 micrograms. And here they were giving everybody 150 micrograms. Everybody see that? That was those old birth control pills that was associated with breast cancer and endometrial cancer. We were overdosing women back then. Today's pill starts out with 30 micrograms, exactly the dose that we push out every day. And 2 big studies, one in Europe, one here, with almost like 400,000 women. So I mean, the power is just that strong. It showed no increased risk of breast cancer or endometrial cancer if you use today's pills. So now I see these questions where a woman found on the internet that, yes, this caused breast cancer, and she's now asking you, hey, doc, what do I do with my birth control pills? That means if you don't know how to discuss it, guess what? She's going to stop the pills now. So that means you got to know how to put up the argument that that was the old pills where they put in too much estrogen because they weren't sure what the right dose was. Now we're dealing with new pills that have the exact dose that your ovary would have put out every day. So that way you get the protection you normally need, but the birth control pill works. Okay. So that's how they came up with that. Today's pills don't promote breast cancer or endometrial cancer, but here's the caveat. They say, if the woman has a family history of breast cancer, or she has a previous history of breast cancer or endometrial cancer, don't use hormonal. Why? Because you're just inviting a lawsuit. It's not that you're going to lose, but it costs money to fight these lawsuits. Because that means if she comes down with breast cancer again, she's going to blame you now. So that's why they say in those instances, just avoid it. Just avoid it. Because now it's going to create a huge problem. That's a big legal issue. So don't use it. Especially since we got so many other things they can do now. All right, Michael. No. It just says if you have a history of breast cancer in the family, or you have a previous history of breast cancer or endometrial cancer, we're not going to use hormones. Yeah, because we don't want to take the chance. Yeah, it's for the lawyers. I mean, the lawyers will find a way to sue you anyway and say it's still your fault. That's why ACOG said just don't do it. Yeah, it's not even worth it. Yes. Depo-Provera, no, Depo-Provera, is his question, is once every 3 months progesterone injection. I mean, with that one, you can't do a quick start because it's supposed to come back every 3 months. That means I got to give you something today. That means unless I want to just start the pill today, come back in 3 months, and I give you a Depo-Provera. Or I've never seen that one be part of quick start as far as injections. Yeah, so I've never seen quick start for Depo-Provera. So I would use the old recommendations. Huh? Quick start is for the pills, correct. Where I am.
Excuse me, doctor.
Wait a minute, hang on. What's your question? Okay. No, they don't. But what I was leading up to is that if I give you a progesterone only, folks, a lot of that progesterone will get converted to estrogen. Remember, you got aromatase doesn't do that for you. All right, so that's why they tell you every hormonal contraceptive has the same thromboembolic risk. All of them do. However, that risk is 1 to 3%. Didn't I tell you 1 to 3% is acceptable? That's why we don't worry about it. Okay. But it's different. I'm getting to that. They have a different formula. Yes. Yeah. Depo-Provera can be used as chemical castration because all you're doing is inhibiting everything. You're shutting down everything. And so that's the same thing as just taking away all hormones from this person. All right, Leslie, you had a question.
Yes, I have a question regarding, like you said that any person with a family history of ovarian, breast, and endometrial, or
Not
just
ovarian, breast and endometrial.
breast and endometrial. And
Yeah.
the second question is about, like you said, after she missed the third pill, you
Yeah.
have to let that she bleed, right? She bleed.
Yeah,
And
right. That means
when
let the
she
pack go.
when she stopped bleeding, that's when she have to begin the pill again with another packet.
No, you can start with the next time she starts bleeding. That means they used to say the Sunday after she starts bleeding, but now you can just start once, because remember, once you start bleeding, you're in day 1 of the next cycle. Yeah, we don't
Okay,
wait for
so
Sunday anymore.
if the patient is, because I have always confused, if the patient like suddenly stop 3 days of the pill and then she begin 3 days after bleeding, she can begin the pills 3 days after stopping with the new
Right,
packet.
yeah, exactly. Just whenever she starts the next period, you start again.
Okay, so the bleeding is not because the estrogen is increasing, the physiologic estrogen.
No, she's bleeding because her cycle got released. The HPO axis went back to normal. And that means when she starts bleeding again, that means she's starting another cycle.
But it's not like she's menstruating.
No, she is menstruating because she released the whole, you had a hold on it with the hormones. Once you stop the hormones for 3 days, you just released the hold. That means she can go right back to menstruation. And that's why they say,
Okay.
wait till she menstruates again. Once she starts menstruating, start another pack of pills.
Oh, because I got that confused because sometimes like OB/GYN doctors say that you can have bleeding with OCPs.
Sure you can.
So like a side effect, like not like you begin to bleed because you get demonstration back.
Right. Let me just talk about that. That's something different. Can you have bleeding while you're on OCPs? The answer is yes. Or IUDs? The answer is yes. But it's not because you're menstruating. It's simply because the progesterone, if it's progesterone that you're taking, gets aromatized to estrogen, and that stimulates endometrium some. So you get a little bit of bleeding at the end of the month, but not because you ovulated. Okay.
Thanks.
And then the pills, we now put estrogen in. Even at 30 micrograms in there, it's going to build a little bit of wall, and that's going to slough up at the end of the month. But you're just spotting, but not because you're ovulating. It's because of my medication. And that's why we say that's not a problem. Okay. Okay. Next topic, menopause. What is menopause? When your ovary says, I'm done working. I love you, but I can't do this anymore. All right. I can't give you any more estrogen. So menopause is normal ovarian failure. That means if it happens early, we say premature ovarian failure. When would that happen? In a woman who had radiation or chemo or cancer? Well, that's it. The ovary will shut down. Okay. So that's menopause. Second thing, do not call it a disease. Menopause is a normal process. You know, companies love to call everything a disease. That means they got to treat it. You don't have to treat menopause. All right. If the female can handle what's going on, leave her alone. But I just want you guys to know the definition of it. Next thing, how do you know somebody's in menopause? If the ovary stop working, the best test, remember, is a signal to the ovary. That's called FSH. So to ask you what hormone would you check, it's FSH. Okay. And average age of menopause in America is age 50. And FSH of 50 equals menopause. So easy to remember, 50 at 50. What the heck is a hot flash? Because that's the hallmark of menopause, right? What's a hot flash? A hot flash, Maria, is your ovary says, Maria, I miss you so much. You know what? I'm going to give you a big surge of estrogen. You're like, wait, when are you going to give me a surge of estrogen? No, I love you. I'm going to give you some estrogen. You say, no, don't give me no estrogen. I haven't seen estrogen in 18 months. You give me estrogen right now. All my receptors are upregulated. Everybody see the problem? When that estrogen comes out of the ovary, all the receptors are upregulated. You whoosh, sudden surge of estrogen, vasodilation, all the blood flow goes to your skin, which means all the heat goes to your skin, and then you perspire heavily to cool yourself back off. That's what a hot flash is. Just a sudden surge of estrogen, and because all the estrogen receptors are upregulated, you get a super normal response. Okay? And of course, that creates so much anxiety for the female who's going through it. Because if it happens at work, all of a sudden she got to go change her blouse because she's blouse is soaked. Okay, and people around you may not know what's going on. Yes, Solange. Okay. No, she's asking if those moments happen long enough for you to develop traumas. The answer is no. It's such a sudden pulse. Yeah, just a few minutes. All right. That's what a hot flash is. Okay. So that means you teach the parent, or the woman, what a hot flash really is. It's nothing to worry about, even though it's causing her anxiety. So the rule is, this is updated from the female who's the national expert on menopause. Number one, she said, if the female can handle menopausal symptoms, do nothing. Just reassure her that it's okay. Like my mom, she's almost 96 years old. She swears everyone's a wuss. You want medication for menopause? She went through it with no problem. Of course, I say, listen, mom, everybody's not gonna be like you with no big problems. Some women can't handle the symptoms. Anyway, so if you can handle it, they say do nothing. If you got that's mild symptoms. Moderate symptoms, that means an occasional hot flash that actually soaks your blouse, kind of gets embarrassing. All right. I was surprised that this woman admitted to it because I knew about this literature. Acupuncture is better than medication. That's why Asian women don't take pills, they just do acupuncture. Acupuncture has gone head to head with medication. Acupuncture won. All right. I was surprised she put it in there, but she said it. Acupuncture is good if you can tolerate needles on your back, no problem. But Americans don't like needles in their back. So that's why the answer is SSRIs. Because anything that involves anxiety, because you're worried this is going to happen at work, as serotonin, remember, helps you handle anxiety. So for moderate symptoms, SSRI is first line. It doesn't help you to hot flash. It helps you tolerate the anxiety of having a hot flash.
There's a drug out there called, it's basically marketed prostitute.
Right. It's used for hot flashes, yes, but it's the serotonin that takes away the anxiety of a hot flash. So now what you thought was a moderate symptoms is just mild to you now. Oh, you're still gonna have a hot flash, but it's just gonna seem so mild to you, you don't even worry about it anymore. Yeah, that's how SSRIs work. They don't stop estrogen. Serotonin has nothing to do with estrogen. Yes. You mean, so some women having hot, if you're gonna have hot flashes, anytime something messes up your estrogen production, and then you suddenly go back to estrogen production. Yeah, that's something totally different. I don't know, whatever she has going on with her ovary, if it shuts down for a while and then comes back to working, you're gonna get a hot flash. But the physiology is still the same. Any sudden surge of estrogen, when the receptors are upregulated, you're gonna get a supernormal response. Okay. All right, so that's mild and moderate. Any questions so far? What about severe? This is when it's severe that she's actually taking days off from work because it's really affecting her job. You know, she doesn't want to lose her job. That's severe. Okay. For that one, you use estrogen replacement. Now, the studies on estrogen replacement, remember everybody ran away from it because the study showed increased strokes and MIs. But when you look at the breakdown, it was a beta error. That means you thought there was no benefit, but there really was. When you look at the breakdown, the risk does not start till after 10 years. The estrogen replacement therapy has shown decreased mortality. You got 7 studies that showed it. At 10 years before menopause, decreased mortality. Up until 10 years after menopause, decreased mortality too. So that's why it was after 10 years, it was exactly 10.2 years, 10 years, 2 months. All of a sudden, wham, women are dying from hormones. That's why they said don't use it. But it means don't use it after 10 years. So anyway, so when you got severe, they say use hormonal therapy for up to like 7 years. That's just me. I stay 3 years away from the line. Okay, that way it doesn't happen to any of my patients. So I would use as replacement therapy for 7 years. By that time, over 90% are done with menopause anyway. So that's why I like that one. And you got 7 articles to back you up. Nobody's ever going to argue about that because it was well accepted in the medical community. So use estrogen replacement therapy for up to like 7 years. By that time, things are mild anyway. That means she goes back to the mild and maybe she can handle it. You don't need to worry about it anymore. Okay. But that's the current management of menopause in America. And then finally, osteoporosis. What the heck is osteoporosis? Osteoporosis at 9 is excess osteoclastic activity. Because over time, osteoblasts slow down their activity before the osteoclasts. So osteoclasts are still working hard, breaking down your bone, and you can't build it up fast enough. That's what osteoporosis is. It's loss of bone matrix. It is not a calcium vitamin D problem, folks. Even though we give calcium vitamin D supplements, don't pick that answer. I've seen it too many times, and they know some students are gonna be picking, calcium vitamin D is the problem. That's not it. Their calcium is normal, vitamin D levels are normal. That's not the issue. We give the calcium vitamin D supplements as just a part of helping to build more bone, but that's not the issue in osteoporosis. Okay. First line treatment for right now for osteoporosis is the bisphosphonates. How do you diagnose osteoporosis? You do a DEXA scan. A DEXA scan at any spot, because they do different areas, -1 to -2.5 equals osteopenia. That means you're not osteoporotic yet. So you just make sure she's doing normal activity, okay? Isometric and isotonic exercise, vitamin D and calcium supplements, just so she doesn't break down so much bone. So -1 to -2.5, osteopenia. It's just conservative management. Anytime it hits -2.5 at any site, you start bisphosphonates. And currently it's bisphosphonates 5 years on, 5 years off. Hopefully you still remember that from endocrine. We don't use it for, long periods anymore. Why? Because you get more fractures. Remember I told you about the 10-year mark, they saw more fractures. Why was that? Because now your bone has not turned over in 10 years. It cracks like a marble now. It's lost all its flexibility. If you want to use a drug consistently, that would be denosumab, the monoclonal antibody against the osteoclast. That one doesn't have to be stopped. All right, folks, let me make sure I got everything covered. All right, so here's that graph I showed you earlier. The first hump peak of estrogen, remember the graph, all 10 follicles. The next one is a surge from the graft and follicular cell. So estrogen controls the first 10 days. But look at LH, low till about day 8 or 9, boom, peaks. See that at day 14, and then boom, he's responsible for ovulation. And then after day 14, look who takes over. Progesterone takes over the whole second half. Okay. All right. OCPs, we've talked about it. Norlevonorgestrel is now the most common progesterone on the market. Okay. Norethindrone used to be number 1. Now he's number 2. Mestranol is the main estrogen on the market. Depo-Provera is progesterone only. It's an injection that lasts 3 months. Then we got 3 types of estrogen, E1, E2, E3. E1, look at that, 80% from adipose tissue, 20% from ovary. And then estradiol, 20% from adipose, 80% from ovary. This is just to show you why obesity is the biggest problem for precocious puberty for females. Let's see, what's the other? And heavy menstrual bleeding, dysmenorrhea, obesity, number 1 for all of them. All right, because that's unregulated. That's by aromatase and adipose cells. And your normal HPO axis is not controlling that. Estriol, remember I said 100% has to come through the placenta of a living baby. If the baby dies, estriol is the first one to drop off. Understand, Kathleen? Understand, Lauren? Cool. Hormone replacement therapy, I already went through for you. Okay. So these were the 3 benefits I just talked about: decreased symptoms of hot flash, decreased osteoporosis risk, decreased risk of coronary artery disease. All right. The controversy was it works for 10 years before menopause and for 10 years after. After that, it's more harmful than good. PCOS, we already talked about. Other hormonal drugs, I mentioned before, clomiphene is now the second most effective ovulatory drug because letrozole has taken over as number 1. Leuprolide is now number 3 for ovulation. And then RU486, remember, was a progesterone receptor antagonist. Is now an abortifacient, so it was just creating an abortion. Any questions at all? And now introducing to you my main man, Tyrone. That's right, Tyrone, always stalking the female menstrual cycle. Yes, Lauren. Yeah. No, it's just that FSH comes out. He's talking about this, the line for FSH. FSH, notice, comes out to cause the estrogen to come out in the first 10 days. And then after he peaks it right before day 14, he goes away because estrogen is not the one who controls the second half. Okay, that's the way I would file that away in your head. All right. Let's talk about Tyrone, the male physiology. Because males are simple, Tyrone is simple. That's why I do it last. Look at that. We're spending like 3.5 hours talking about women. Men, maybe an hour. We're done. Okay. We're simple human beings, man. Yes. Sabu, you got a question? For the 3 forms of estrogen. Yeah, estradiol is the one that's most dominant throughout your young years. Estrone is the one that's most dominant after menopause because we all pack weight after menopause, and that's coming from adipose. So it makes sense. Spermatogenesis begins at puberty. Austin begins at puberty. What is the first sign of puberty for a male? Look at that, testicular enlargement. Do we remember that? That's where the sperm is going to come from. You got to make room for them. So that makes sense. What's the first sign of puberty in a female? Austin. Breast buds, breast buds. When the testicles reach 4 centimeters, not 4 centimeters, 4 milliliters in size, you've hit menopause if you're a male. Did I say menopause? Damn, okay. I've been talking about menopause for too long. Now I got menopause in my brain. No. It means you hit puberty. Sorry, not menopause. For a male, when the testicle is at least 4 centimeters in size, it means puberty has begun. Yeah, they do it in volume. Just measure the volume within the testicles. Yeah. I think it's 4 centimeters in size, not 4 cc's. 4 cc's is not even a teaspoon. All right, all right, 4 centimeters. But anyway, it's a number I picked up on a few questions. They kept telling me the size of the testicles, and I didn't know there was a certain size that meant you've now entered puberty. I learned by missing it. Okay, so I'm just letting you know it so that next time you get the answer right. All right. So first sign of puberty for a male is controlled by testosterone. LH stimulates testosterone by stimulating the Leydig cells. Remember, Leydig cells produce testosterone, and testosterone does spermatogenesis. A lot of books don't tell you what FSH does in a male. In fact, a lot of students don't even know. That's because FSH stimulates Sertoli cells. Sertoli cells produce several hormones. Sertoli cells produce MIF in utero, Mullerian inhibiting factor. If you remember, MIF controls the internal half, the inner half of the internal male genitals, like I showed you before. The internal male genitals are divided into 2 halves, inner half, outer half. The inner half requires SRY gene from the Y chromosome. Okay. Let me see, testicle determining factor. They found a new one now, new hormone, TDF, from the testes, and then MIF from Sertoli cells. Yes, sir. 4 centimeters? Oh, okay. That's what I said, 4 centimeters. Okay, yeah. Oh, okay. Yeah, it sounds like 4 ml. Centimeters is what I remember, but yeah, that's the right thing. But 4 milli sounds like too small. That's anyway, 4 centimeters is what most of them were right anyway. So anyway, Sertoli cells. That means to be a male, all right, to develop normal male structure. If you remember Sereno now, it's not new. I said for the inner half, I need a Y chromosome first. SRY gene got to be present on that Y chromosome. And then MIF has to be present. Then the inner half will become male. If not, it'll become female. That's how you become a true hermaphrodite. That means now the internal has both male and female structures inside. Okay? Sertoli cells, after you're born, produce inhibin. Because inhibin is supposed to feedback and inhibit FSH. So LH and FSH play a role in the male just like they do in the female, folks. They will ask you. Because I told you a lot of books leave out FSH function in the male, but they expect you should know it. All right? As spermatogenesis, now let's talk about that. Sertoli cells produce inhibin after you're born, produce MIF after, while you're in utero, okay, and maintain the blood-testis barrier. Their job is to make sure that the immune system does not go into the testes. Why? The testes, the sperm that are in there are 1N. 1N. How many N's in a normal cell, Halima? Was that? Remember, 4 is only in a female ovary. That's the only time. It's 2N is the normal cell. So 1N is a stranger. Everybody understand that? That means if you let your lymphatics go in there, it'll destroy everything, and that man will be sterile. That's why we protect the blood testis barrier. Everybody understand? All right. The Sertoli cells also protect and nourish the sperm all the way to maturity. So let's look at some of the things that can go wrong. They can mess this up. And then you'll understand why we manage it the way we do. Number 1, hematoma from trauma. Usually accidental kick, playing soccer, football, baseball, whatever. You got a kick in the groin. Oh, me. If you want to hear a soprano, that's about the time. All right. That's why little boys wear protective cups. Protect the family jewels, right? So if you get an acute hematoma, listen carefully. You get an acute hematoma, I have to worry that that blood testis barrier also got splattered by that trauma. Does everybody understand what I just said? That's why all of them go to surgery. Because otherwise, doing surgery makes no sense to you because you don't know why we're doing surgery. It's because that little boy's gonna be sterile if we don't do something right away. So an acute hematoma, all right? That means he was playing baseball, baseball 89 miles an hour, it hit him there. Oh boy, he's gonna scream, but mom's gotta take him to ER and that kid's going to surgery. Because the urologist wants to know if that blood testis barrier is still intact. Because if it's not, it needs to be sewn up right away. Otherwise, that child will be sterile for the rest of his life. Because antibodies will come in there and destroy everything they see. Because those are strange looking cells with one N. That's not a normal cell. That's acute hematoma. What about if it's a chronic hematoma? Mom tells me, well, he's had this hematoma here for about 3 weeks. Oh, hell, well, he's sterile now. I ain't got nothing to do with it. But you can't blame me for it. Okay. Then we say, oh, put some ice on it. Because if he's sterile, he's sterile. If he's not, then he's okay. So be careful. Acute versus chronic is managed completely differently. Okay. All right. Next one, hydrocele. Hydrocele is a collection of water. Seal is pocket, hydro water. Okay. Coming in from the abdomen through the inguinal canal, right? It usually follows the, what's that, tunica vaginalis? Okay. Same pathway and indirect inguinal hernia goes. And that's what they love to add. What other complications you have to worry about? Indirect inguinal hernia can now develop too. Hydrocele, how do you know you have one? It transilluminates. You put a light behind it and it glows in the dark. What do you do about it? Nothing. Any questions on hydrocele? Next one, epididymitis versus varicocele. Epididymitis is an STI. That means chlamydia and gonorrhea. That means a NAT test will detect it, like we've already talked about. How do you know somebody has epididymitis? Number one, feels like a bag of worms, but it's at the top of the testicle. Varicocele feels like a bag of worms too, but it's at the bottom of the testicles. So location of the worms will tell you which one the diagnosis is. The other way to separate them, if you lift the testes, you take the tension off of the epididymis, it feels better. If you lift his testicles, he'll say, oh man, that feels so much better. That's epididymitis. What's the drug of choice these days on them? For gonorrhea. So ceftriaxone, and they're gonna put a company's name on it, just so you know, they won't put Rocephin. Ceftriaxone, what dose? No, 500 now. They remember it used to be 250. 500 is because of resistance. Okay, so 500 milligrams one time. All right, and for chlamydia, remember they want doxycycline now. Yeah, it's too much azithromycin resistance popping up. So 100 milligrams twice a day for 7 days. NAT test will detect it for you. They want a test of cure 3 weeks afterwards. Now that it's so simple, most people will return and get it done because it takes 1 drop of urine. A test of cure 3 weeks afterwards. Now they say do another one 2 months later. Why? Because they tend to go back to that same old girlfriend or boyfriend and pick it up again. Just when you thought they broke up, no. They thought one more time. And then they spread it right back to each other again. Anyway, but they're right though. So anyway, that's why they say repeat it 2 to 3 months later. So that's epididymitis. Varicocele, varicose veins. We're all going to get it as we age. All right. If it's acute varicocele, that means your sperm is swimming around in venous blood. You understand that, Sloan? You understand that, Montessori? Your sperm is swimming around in venous blood. Remember, varicose veins, that's venous blood. That means sterility is the big complication. So what do? Surgery. We're trying to prevent the male from becoming sterile. Okay, just so you know, why are we so aggressive? Well, for this one, if you don't do something, all the sperm are going to die. Then the blood testis barrier will break down because you're ischemic. That's acute varicocele. What about recurrent? Recurrent varicocele is the one they like to ask about the most. What you got to remember, gonadal vein on the right drains right into the IVC. Okay? They always make an anatomy question. Varicocele on the right, if it's recurrent, that means something's in the abdominal cavity, pressing it, going across it like this. And pancreatic cancer is #1 in older people. So that's why if they give you recurrent, you got to know, gee, what else do I have to rule out? Okay, on the right side, something's compressing the IVC, pancreatic cancer is #1. Well, you scan their abdomen to see what it is. And on the left, remember, left gonadal veins drain into the left renal veins, and then the
the IVC. So it's usually renal cell carcinoma. Either way, folks, it's something real bad. Both of those cancers have very bad prognosis. That's why you want to catch them as soon as you can. So recurrent varicocele on whichever side, folks, is a bad prognosis, but they'll ask you what you think is causing it. So it's different on each side. Any questions on that? Then the worst thing that can happen is torsion. What is torsion? When the testicle starts twisting around its blood supply and nerve, and it cuts it off. So the rule is this: any sudden testicular pain in any male equals torsion until you rule it out. Just remember that. Just like appendicitis, any right lower quadrant pain in a child, appendicitis is ruled out. So here's another one where the urologist will never blame you if you call him in at 2 a.m. Say, I think I got a guy here with torsion. All right, I'll be right in. He knows even if you're wrong, he doesn't get any ding on his record for being wrong, because that's the rule. Okay, sudden, severe, we go straight to the operating room. Just on clinical basis alone, you can take him. But there's 3 physical findings that tells me you have torsion. 3 physical findings. Now on the test, they don't have to give you all 3. That's all they do is give me 1, just 1. All right, number 1, the torus testicle rides higher, because remember, it's spinning and going up like that. So no, they'll just describe one testicle rides higher than the other one. You got torsion. Number 2, the testicle that's torsing will lie transverse, then the regular one lies vertical. You got torsion when I see that. And finally, if you lose your cremasteric reflex, if you stroke the inner thigh of any male, his scrotum always rises. This guy's won't rise. Because why? The pudendal nerve is trapped in there too. So the 3 best clues that somebody has torsion. But remember, you can take it to surgery based on clinical suspicion alone. Yes. For which one now? For torsion will be, yeah, the cremasteric reflex is gone. What is the print sign? What is it? Oh, yeah, just release, raising the testicle. Yeah, right. Because what's the other one you're talking about? Epididymitis doesn't have that. Yeah. Epididymitis actually feels better when you raise his scrotum. Any questions on all these Sertoli cell problems? These are just testicular problems that could cause problems for Sertoli cells. Yes, sir. I don't think it's iliac. I thought it was pudendal. Yeah, it's pudendal nerve. Yeah. Iliac does a little higher up. All right, spermatogenesis for the male. 1 round of mitosis. Remember, the female went from 2N to 4N. When did that happen, Chris? When did the female do that, Miguel? When did the female do that, Saba? It's in utero, 5 months gestation. Look at you guys have forgotten stuff already. I told you all that stuff happens early for a female. That's why she plans everything so early. 5 months gestation, mitosis already occurred. 2N goes to 4N. Primary spermatogonium for the male. We wait till puberty. We say, babe, don't worry about it. We got plenty of time. 14 years. Okay. Primary spermatogonium. Then we enter meiosis 1. 4N goes back to 2N. Secondary spermatocyte. And then meiosis 2. 2N goes to 1N. Tertiary spermatid. See? That's where the men get to have it. Just do it quick. Get it done. Tertiary spermatid. That means because men waited to the last minute, we do it quickly. Boom, 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 boom. Primary, secondary, tertiary, boom, ready to go. Okay. One spermatogonium gives rise to 64 spermatids. That's a lot of cellular divisions. As spermatogonium mature, they go from the basal layer, that's where you find immature sperm, to the top layer, that's where the mature sperm are found. Because I've seen pathology slide questions that say, oh, where would you find mature sperm in this picture? Well, if you say mature, it's got to be at the top. I mean, but it was a slice of the testes, just so you know. Anyway, immature sperm are down in the basal layers. Mature sperm are always at the top. That's because the epididymis, remember, is at the top. Once they mature, they jump into epididymis. Okay, and they will wait there until it's time to ejaculate. Each day, 20 to 40 million sperm mature. See that, Ashley? That's men. We like to overdo it. 20 to 40 million soldiers, man. This is war. It's a war, and we're going to win it. That's right. Uh-oh, wait a minute. 20 to 40 million sperm mature every day. Complete spermatogenesis takes 41 to 72 days. Sperm can live for 5 days in fallopian tube. Man, how long can your eggs live in the fallopian tube? 3 days. See that? Wimps. Wimps. 5 days. Yeah. Hey, but that's called bad planning. Why is it bad planning? It's because you're showing up to a party and they tell you there's gonna be women there. You find out there's no women at all. What are you gonna do now? Because if we show up 2 days later, the egg is dissolved already. There's no party. All of a sudden, hey man, hey Joe, any women over there? No. Hey Paul, any women over there? No, man. They told us women were gonna be here. Hey Tyrone, any women over there? No, man. Oh man, Luther Vandross is my song. It's my song. Hey Tyrone, you want to dance, man? And then they start dancing. You know what that's called? A molar pregnancy. You thought it was just a joke, didn't you? It's not. That's how you get a molar pregnancy. The egg was dead and the two sperm made contact with an empty sac. And so the two heads just fused together and now you have a molar pregnancy. That's exactly how it happens, folks. They say, two sperm, they tried to fuse with the egg was dead. So that's why they touched each other and boom, all of a sudden now they start dividing. But because you don't have mom's genes in there, it's uncontrolled cellular division. You got to have mom and dad genes to have control. You have no control. So how do I know you have a molar pregnancy? We have 3 clues. 3 clues. Mayha's counting them up already. You know one? Yeah. All right. First one, the beta HCG is supposed to double every 2 days. So if it's going higher than that, then that's how you know. That's one. So that means they'll tell you the level you saw. Let's see, 2 days ago. Let's say it was 4. Today it should be 8. I'm just making up a number. But then they tell you it's 10,000. That's a molar pregnancy. You cannot go from 4 to 10,000 in 48 hours. Okay. So anytime the HCG is rising faster than you would predict, molar pregnancy. Number 2, fundal height, the fundus of the uterus is rising faster than usual. There's 2 landmarks, Halima, that they like to use. First one, the symphysis pubis, 12 weeks, 12 centimeters. Umbilicus, 20 weeks, 20 centimeters. So they'll give you a female and say she hasn't had a period in the last 4 weeks. You say, okay, she can only be 4 weeks pregnant. But then they say you can feel the fundus of the uterus at the symphysis pubis. That's a 12-week uterus. She can only be pregnant for 4 weeks. She got molar pregnancy. So they sneak it in there to see if you know what normal is. Folks, I told you, it's all about normal. If you don't know normal, you won't spot abnormal either. Michael. No, they're not that common, but they do occur. I don't know, it's like a couple of percent, maybe 1%. No, it's not even 1 to 3%. It's way less than 1%. Yes.
There's fundamental growth, if there's a discrepancy in there, you have to rule out incorrect dating birth, right?
Yeah, that's when they're just asking you what's the most common cause. The most common cause of let me see. Fundal height and beta HCG is always inaccurate dates, simply because teenagers couldn't tell you when they got pregnant. That's what happened. When teenage pregnancy was going higher, they were telling the doctor the wrong date. That's because they truly couldn't remember. I mean, because teenagers sleep around so much now. I'm amazed. The girls are so sexually active. It's not even the guys. It's the girls are so sexually active. They can't remember who they were sleeping with when they got pregnant. And we're trying to help them figure out who the father is. It's like a damn Maury Povich show. You know, you're the father. Oh, no, you're not. Sorry about that. We don't know. Because she swears it's him, yeah. And then find out, nope, it's not him. Anyway, so inaccurate dates is the main problem now. But anyway, I'm just giving you what's going on here with molar pregnancy. All right, so it's 2 sperm that fuse with a dead egg and accidentally fuse together, and now you have unregulated cellular division. So the 3 ways to recognize it: fundal height is going too fast, HCG is doubling way too fast, or you got preeclampsia in the first trimester. Preeclampsia does not start till a late 2nd and 3rd trimester. That's when the baby outgrows his placenta and causes ischemia, which is what sets off preeclampsia. But if you got a molar pregnancy, the cells are dividing so fast that you get relative ischemia because they're sucking all the blood away from mom. See, still the same mechanism. But at least you know a baby in the first trimester cannot suck that much blood away from mom unless you got molar pregnancy. So those are 3 clues that makes you suspect molar pregnancy. Now, next thing I ask you, the karyotype. Most common karyotype, 46XX. Why? Because X's are stronger than Y's. Yes, women are stronger than men. I think men, we've conceded that already many times. Women are much stronger. So it's by chance alone, X chromosomes last longer than Y chromosomes. Question.
So the oocytes considered to be dead at end of day 3. Is the cytoplasm still viable in that order?
No. So if a oocyte is dead at day 3, the cytoplasm is also no good. That's why the sperm, when the 2 sperm came and fused with it, they actually went right through it and then curled with each other. Boom. And now you got a unregulated fertilization. But there's no living tissue. That egg is dissolving. Right? It's dying by apoptosis. All right. So metagenesis, folks. Molar pregnancy. Now, with molar pregnancy, number 1 complication is uterine invasion. This thing is dividing so fast, it eats right into the wall of the uterus. Number 2, even though it's a distant 2, is choriocarcinoma. That's the one every doctor is afraid of. Why? It's one of the most malignant cancers you'll ever see. Hospice care, they're dead in less than 6 months. They don't even last a couple of months. I mean, they die real fast. This thing divides so fast. All right, its favorite location for metastasis is your lungs. You get what they call cannonball metastasis. That means a bunch of circles, 10, 12 of them throughout the lungs. That means forget it. The person's at stage 4 already before you even know it. Okay. So number 1 complication again, uterine invasion. And number 2, choriocarcinoma. So how do we deal with this? We say, okay, we need to scrape this thing out. So what do? Scrape it out. Then you follow the HCG every week for at least 12 weeks. Because you want to prove the HCG goes back to normal and stays normal. Then you know you got it all. What if somewhere around 6 or 7 weeks, all of a sudden HCG starts rising again? Number 1, you got uterine invasion, or number 2, you got choriocarcinoma, one of the 2. Because it means all the tissue's not gone. Everybody understand me so far? So if the HCG comes down and stays normal, you stop, we're done. But if that HCG starts bouncing back up, you got uterine invasion or you got choriocarcinoma. That means both of those are rapidly dividing cells. What vitamin does all rapidly dividing cells need, Bailey? Folate. So that means we need to give them a drug that can block folate. Is there a chemo drug that can do that, Solange? Right, methotrexate. See, that's how you talk yourself back into the therapy and management. You hit it with methotrexate right away, wipe out the whole lining. That means if there's invasion, it's gone now. There's choriocarcinoma, you kill everything now. See that? And then you take HCG again for a few more weeks. Always talk it out, folks. That's how I remember these things. I'm always talking it out. Don't try to memorize it. And then that means you want the information to stand still. That's hard. Whereas if you start talking about it, what's the process going on? Your brain would then remember the connection back to the management and drug of choice or whatever it is they've been asking. Any questions on metagenesis? All right. Virility. Virility. There's a measure of virility. All right. 20 to 40 million sperm per cc of semen. 20 to 40 million sperm per cc of semen. You hear that, Ashley? 20 to 40 million. Wait a minute, we're not done yet. 4 to 5 cc's of semen per ejaculate. Wait a minute, do the math, bring out a calculator. 4 to 5. Oh, baby, 200 million. 200 million. Yes, Ben. It's a war. We come equipped with soldiers. We plan to win this war. But wait a minute. It's called bad planning again. Why? You're going to have to send in 200 million soldiers so that one guy gets a damn job. We got to sacrifice a whole lot of soldiers, man. So that one guy finally fuses with this egg. But it's a storm of troopers. Vroom, 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 vroom. They're coming. All right. No more than, 4 to 5 cc's per semen. No more than 40% abnormal forms. That means you only allow one predator willing in here. Why? Because he's eating all the damn food. How we gonna make that trip when one guy's eating up all the crackers? Hey, Predator, you in there? Come out, crackers falling out of his lips. Eh? Eat all the chips. Come on, man. And then Angelman's, oh man, that girl's cracking up at everything. Hey, girl, this is a serious business. Stop all that laugh. I think she's smoking weed myself. Nobody's gonna believe me though. All right, so no more than 40% abnormal forms. And then look at this, 36% of the sperm must still be motile after 5 minutes on glass line. This is when they, if you go to fertility clinics, they put you in a cold room. Why? Because sperm don't like cold. All right, they need a certain temperature to live in. All right, but they, for the men, we always do sperm analysis first. Why? Because male factor, #1 cause of sterility. Now, the trick to the question is the woman who comes in complaining. Doc, we haven't been able to get a baby in 3 years now. We've been married for 3 years, no baby. Even though she's the one complaining, the problem is still male first. That's why we do the sperm analysis first. So anyway, they have you ejaculate on a slide, and then they put it underneath the microscope in that cold temperature to see if the sperm is still alive and well. So when she looks in there, see that shit, then she counts. No more than 40% are abnormal, good. 36, 30, 60 are still motile. That means they're strong, strong. You see them, nice by a little garbage can fire, you know, like that. Put some more paper in there, you know. They got the hats on, they got the starter jacket on. Ooh, they got Wolverine boots. Yeah, they give you the thumbs up. Doc, ready for this? Yeah, ready to go off to war. But then they ask you, well, when are we going to war? Well, let's see. Look at this. The pH must be basic. Why is the pH got to be basic? Because we got to neutralize the enemy, so to speak. So remember, the female vagina is very acidic. When does she get her lactobacilli, Gloria? It's puberty. Remember, the vagina is very alkalotic till puberty. All of a sudden, these bacteria called lactobacilli show up. All right. And now colonize the entire vagina, producing lactic acid every day. And that's when the pH of the vagina then becomes 4.5 to 5.5. Okay. So for the male, you better be basic. Why? Because when you ejaculate inside and it's acidic, the sperm die on contact, unless you protect them. Basic. Any questions on that? All right.
Yeah, excuse me, sir.
Yes, maybe go ahead.
Please, the bacteria that lives in female private organ, is it normal flora?
Yes, normal flora.
Okay, so it doesn't kill, like it's not harmful, right?
No, it's not harmful. What's this
All right.
private organ called again?
I don't know.
Oh, Lord, I don't know. Good Lord, we still back in kindergarten? What are we gonna call it? Private organ? Call it vagina.
Okay, sir.
Okay.
I'm just asking to know because of some of
Okay.
the
Yeah,
folks
next
that
time, call it a vagina. I remember, you guys are trying to be physicians. Don't play with these sounds. What was it? We do it. What the hell is it? Don't talk like that in medicine. Don't say it. No. Name the parts the way it should be named. I
Okay,
told you. For some reason, physicians are queasy about sexuality. I don't know why, but they are. Anyway, call it the right term. So
Okay.
pH is basic to neutralize all this lactic acid. Now, why does the female need an acidic vagina? #1, to kill bacteria. Remember, the female urethra is short, so there's always bacteria colonizing her vagina. You better have lactic acid to kill all of them, and that happens. #2, to keep fungus in check. The female vagina, all mucosa, has fungus lining it. Well, as long as you're acidic, 4.5 to 5.5, fungus does not grow. Candida just lives there happily ever after. Doesn't bother you at all. Well, wait a minute. What if I give you broad spectrum antibiotics and kill them off? Why do you think they start getting UTIs? No, that makes sense. Why do they start getting Candida vaginitis? Oh, look at that. It makes sense all of a sudden. Just so how to remember those benefits. All right. Infertility. What is infertility? Infertility is inability to achieve pregnancy after minimum 12 months of unprotected intercourse. The key word, 12 months. So duration of time is very important, and it has to be unprotected intercourse. That means if you're using condoms, okay, well, let's understand why you're not pregnant. Okay, if she's on birth control pills, okay, well, then we understand why you're not pregnant. So it's got to be unprotected intercourse. So if they've only been trying for 3 months, 4 months, the answer is see you back. Yeah, we're not going to start some mega workup for 4 months. Because I mean, some women become really anxious about it because they want to have a baby, you know, because that time clock that women have in their head. All right, maybe society, I mean, unjustly does that to women. All right, so you got to try to understand. Now they're trying to bring it down to 6 months. I haven't seen it take over yet in the literature, so don't pick 6 months. I'm just letting you know why they're trying to bring it down to 6 months. Because today's women, you know, women like to go chase their career before having babies. That means they're older when they try to have babies. And so we got so much infertility now. And that's why they thought, okay, we probably need to bring this down to 6 months. Anyway, infertility, 50% of male fact, that means it's the man's fault. You know, countries like my own, Nigeria, Asia, Middle East, it's always a woman's fault when they haven't had a baby. So my mom is like the oldest living elder in the village. She's like the godfather. Nothing happens in that village without Madame's permission. I just love watching her. And she just sits in her little lazy boy. A line of women just line up, waiting to see Madame. Oh, Madame, Madame. Then they tell her their woes. If there's any kind of argument going on in the village, they bring the argument to her. She settles it. That's what the godfather does. And whatever she says, that's it. There's no more argument. It's law. Okay? And it's so funny, but I see a lot of women coming in, oh, Madame, he's going to be so mad at me. I haven't given him a child yet. You know, because the men want children before they drop dead. You know, men die young there. So they want a child as soon as possible. In fact, a man is allowed to marry another woman to have a child if the first one has not given them a child in, 2-3 years. Now, this is America, that's Nigeria. That's totally different now. Don't start looking at me all strange, okay? That's because the death rate is so high there. Just so you know, the man wants a son to carry his name on because he knows he's going to be dying soon, and he wants somebody who's going to carry that on. That's why they want a child and they want a son. Well, the rule is you can marry as many women as you want, all right, to have as many boys as you want before you die. Now, my father was one of the first men to break from that tradition. He said one woman was enough. Smart man, smart man. I'm telling you, I don't know how guys can deal with two. One is enough. Trying to figure one out is hard. Trying to figure two out, you're gonna get an aneurysm, man. So anyway, infertility is a male factor. Always do sperm analysis first, just so you know why that's the answer, even though she's the one complaining. Sperm analysis first. And they want 2 of them, at least 1 week apart, because men don't make the same amount of sperm every day. So I check it on this Tuesday, I check it next Tuesday. And this one may say 500 million, this one says 175 million. You average the 2, and that's the average that he puts out every day. Okay, then that means he's good. Okay. All right, so always do sperm analysis first. 30% female factor, and the most common female factor is PID. And so what I see in so many books, most common cause of infertility is PID. Folks, that sentence has been wrong since it was written. And because test writers know students have read this in so many places, this is the first aid, that's the wrong answer, okay? They keep playing the same trick, and so many students keep falling for it. That's how they know where you got programmed, okay? What they really meant to say was the most common cause of infertility in women is PID. But I told you the book doesn't say that. They just said the most common cause of infertility is PID. No, male is number 1. Okay. All right. 20% is miscellaneous. And of the miscellaneous group, fallopian tube problems, number 1. This is why we do a histosalpingogram first. See, that's how I remember the management. I do my sperm analysis. If everything's good, histosalpingogram is next. I need to look at the fallopian tubes, look at the shape of the uterus and all that. That way you can see if there's fibroids, was it bicornuate uterus? See if there's anything anatomical going on. You'll see scar tissue from PID, okay? Any narrowing, so miscellaneous. Fallopian tube is number 1. So now if everything goes well, look what happens. When the male ejaculates, the sperm go through the epididymis, head straight for the ejaculatory duct. Ejaculatory duct then joins the urethra about midway, and then the head of the penis over here to the right. So the sperm goes shooting out here to the right. It comes right here in the middle. Now, if you look over here on the left, you have a bladder. Bladder has urine, pH 5 to 6. Remember, I just told you semen, it's got to have, you're talking about, we want the vagina to be 4.5 to 5.5. Even that's too acidic. That's the reason why if you let urine meet up with sperm, that's it. All the sperm are dead on contact. For that reason, folks, there is a valve here. Nobody's got their name on it, but there's a valve between ejaculatory duct and urethra. It has the longest absolute refractory period of all valves in your body. Why do you want that? That means when that valve comes down, all right, that means sperm can come out and come out and come out several times before you ever open up down here. And then after you ejaculate, then the valve goes up so slowly, which is why it takes time before you can urinate after you ejaculate. That valve does not go up quickly. And so the male, when he tries to go to the bathroom, has to sit there for a while because that valve is not going to open anytime soon, but you have to wait. That's because the physiology has it so that urine never meets sperm, ever, okay? Who controls this valve? Autonomic nervous system. What neurotransmitter controls autonomic nervous system, Melissa? Huh? Norepinephrine. So anytime you have autonomic dysfunction, this ain't working. What's the most common cause of that, Anna? Not ischemia, autonomic dysfunction. In an adult, Karis, diabetes is number 1. So if you didn't know this, it would scare you when you saw the question. And they tell you did a urinalysis and you can see sperm floating dead in the urine. See what they're trying to tell you? You would swear it's a misprint. That's for real. If you have autonomic dysfunction, you will see sperm dead in the urine of a diabetic. Parkinson's, usually 7 to 8 is dead. We're not worried about that, but Shy Drager has the same problem because that valve is no longer coordinated anymore. And so you can actually see sperm and urine meet up. And you see sperms floating dead because that pH is going to kill them. But the fact that you saw it in the urine, that's what scares the physician unless you know what it means. Yes, sir. Retrograde ejaculation, we're coming to that, I'll show you. All right, so this is normal ejaculation, so straightforward. All right, well, before sperm can leave, it's got to make 3 stops, Lauren. Number 1, stop at the seminal vesicles to get semen and fructose. What's the semen for? Camouflage. Semen is camouflage. The sperm hide underneath the semen. Why? They wait till all that acidity of the vagina has been neutralized. Can't come out too early. Come out too early, you die. There's always that one sperm who wants to get a head start. I think I'm gonna get a head start. Tyrone says, man, don't go out there, man. Don't go out there. I'm telling you, don't go out there. No, dude, man. Come on, man. There's 1 egg. I'm gonna get that egg first. Tyrone said, hey, man, I told you, man. I'm telling you, don't go out there. Bad things happen. You go out too soon. We'll wait till the bicarb neutralizes like that. No, man. I'll see you in the morning. And he goes out. Oh yeah. Well, guy, he wasn't quite dead yet. You got to fry him up some more. Anyway, any sperm that leaves too early will die on contact. You got to wait for the bicarb. See, that's number 2. Bicarb from the bubble urethral glands. Why fructose? Why we fructose? Why not glucose or galactose? Melissa knows why. Why would sperm pick fructose? Something you've learned will answer that question. No, not glue transporter. Let me ask, nobody on this side has a hand up. Come on now, Bailey. It has no regulation. It burns fast. Sperm is moving real fast. So that means they need something that can burn real fast. That means burn faster than glucose and galactose. That's why sperm chose this. There's always got to be a reason, folks. You just got to think about it, okay? Bubble urethral glands, also known as Cowper's gland, produce bicarb to neutralize all the lactic acid in the vagina. Prostate, what do you pick up there? Zinc. Zinc is used in what they call capacitation reaction. Capacitation reaction. Capacitation is the act of removing semen off the top of sperm so that they can take off. Capacitation. Then you need acid phosphatase to eat through the cervical mucus. Remember, it's thick right now. And then you need hyaluronidase to eat through the cornea radiata, which is really the granulosa cells around that egg. Hyaluronidase. Any questions? So the sperm must go through these three places before it finally goes out. All right, but if everything goes well, go right through your ejaculator duct and the head of penis. Let's shout over here on the right. Mabel, you have a question?
Yes, sir. Please, what did you say about acid phosphatase and the hyaluronidase?
I still think there's something wrong with that sound, boy. All right, so I just said acid phosphatase eats through the mucus, and hyaluronidase eats through the corona radiata, which is really the granulosa cells around the ovum. Remember, hyaluronic acid is connective tissue. Mabel, did you hear that?
Yes, I heard it. I heard it.
Okay, all right, I want to make sure you heard me. All right, so now if everything goes well, boom. Stage of sexual response. Let me give you the story behind this. This started back in late 60s, early 70s. I came to America in 69, and this was just starting. It was called a sexual revolution. How did this revolution start? Well, they've done surveys of women, and I remember 29%, the article I reviewed anyway, said 29% said they've never had an orgasm in their lives. When you look at the breakdown, it was older women who were raised in this time, late 60s, early 70s. Women's consciousness started to awaken. They said, wait a minute. Men are the only ones who are supposed to be gratified by sex. This is for real, folks. If it helps you remember, this is why men said, I'm going to go get me some. Does that sound like you're sharing anything with anybody? No, because men were told sex was for you. Women were told by their mothers, sex is for him, not you. Your job is lay there, let him do what he's got to do. When he's done, go wash up. I'm serious. That's what these women were told. So they were never told how to enjoy sex at all. But then in the late 60s, women said, wait a minute, we want to enjoy sex too. This is not fair that we're just being used for sex. Well, then the question came, how do you enjoy sex? Well, women didn't know how to enjoy sex. So we had to teach them. So in order to teach them, you got to first learn what it is. A husband and wife psychology team, Masters and Johnson, did all the research on sexuality. They're the ones who came up with this. Masters and Johnson, husband and wife team. You know, big thing back then, sex, drugs, rock and roll, woo-woo, all right? Okay, so what they do, I don't know if they rented or bought a house somewhere in the hills up in California, and they said, we'll let you use our house for the weekend. You can have sex all you want if you let us study you. Study you means we have cameras from every angle. We got sensors on your nipples. We got sensors on your testicles. We got sensors on your penis. We got wires hooked up to your scrotum. We got wires hooked up to labia majora, intravaginal wall, cervix. With that many wires, I don't know how the hell you can even have sex, but they had it. Somebody worked it out. Today, that's called porno, but hey, now, back then it was called research. Think about it. Cameras from every angle. Sounds like porn to me. But anyway, I give them credit because they did a lot of good research. All right, this is what helped women actually enjoy sex. Now, young women like you guys think, oh, it's a foregone conclusion. No, it was not back then. Women actually did not know what enjoying sex actually meant. They were always taught that it was for the men, so they didn't know how to enjoy sex at all. Yes, sir. Masters of Sex TV show? So it's doing research about sexuality? Yeah, that was a big issue back then because women didn't know. So anyway, they're the ones who came up with all these phases. So let's go through them. First one, excitement phase. Excitement phase is exactly what it says. This is when you're getting sexually excited. For men, testosterone. For women, estrogen. But excitement is not the same thing as libido. Notice libido is not on here. Libido is the desire to have sex. For men, still testosterone. For women, progesterone. Wait a minute. This is why early on for a female, she can enjoy the excitement of sex, but she doesn't have as much of libido as a man. Men are always complaining that my girlfriend doesn't have as much sex drive as I do. My wife doesn't have as much sex drive. That's because it's physiological, folks. She doesn't have the same drive. She enjoys it though. You just have to coax her into it. Okay, so Master Johnson addressed that too. So anyway, that's excitement phase. And they have a plateau phase. You're at the top of the mountain. And oh, what a beautiful sight it is. And there's trees, and there's meadows, and there's water. Woohoo! And then right before orgasmic phase, there's a sudden excitement phase. And then you slide down on the other side called orgasmal resolution phase and go wee. Okay. Everybody has the same phases, folks. It's just some are longer and one than others. And that's what we're gonna look at. What's the difference between men and women? It's different in each phase. Well, now, we said men, libido and excitement, testosterone. For women, excitement is estrogen, libido is progesterone. And that's because progesterone has a sequence of testosterone in it. So it's really testosterone for women too, okay? Well, estrogen controls the first or second half of the menstrual cycle, Karina. Estrogen controls, controls the first or second half of your menstrual cycle. First half. Who controls the second half, Lillian? Progesterone. So that means a female has more libido before menses. Everybody understand what I just said? Okay. She can have excitement in the first half, but she doesn't have the libido. Okay. And so for a male, men have libido all the doggone time. So what happens? As we get older, the woman has less estrogen. That means now more progesterone, more androgen. That means she has more libido. But at the same time, her husband or partner has less testosterone. Oh my goodness. So for the man, has less libido and less excitement. At the same time, the woman is just finding libido with her excitement. Folks, this is a physiology of cougarism. That's how it happened. This is why I just like physio, sort of physio of cougarism. This is why older women started chasing younger men, because they knew at the time when they had the high sex drive that their husband had been wanting for so long, he can't keep up. So what do? Get yourself a younger man. And that's how it all started. They got their own website and everything. That's what I heard.
Really?
Research. Got to give a lecture. Got to research these things, man. So, oh my God, I tell you. Anyway, yeah, exactly. They even got their own reality show now. I saw that the other day. I said, oh my God. Okay. Yeah, cougarism everywhere now. But anyway, just so you know, there's physiology to cougarism. It wasn't just something somebody made up.
Sir, I want to ask something, sir.
Mabel, go ahead.
So maybe this may be the reason why some older men, because down there in Nigeria, you hear that older men with maybe for some maybe once in a time, or maybe I can say monthly, or you find out that some of those older men, they die on top of the younger girls, maybe trying to satisfy them or something. So does it have anything to do with a heart problem? Because they're trying to satisfy the younger ladies and they'll die on top of them.
Exactly. No, she's saying this happens in Nigeria. If a man tries marrying a young woman because he wants to have babies, but sometimes he ends up dying on top of his woman because he can't keep it with her desire. Because he doesn't have as much testosterone as he thought he had, and then he drops dead right in the middle of intercourse. Yeah. It's not just Nigeria. This happens in a lot of countries. All right. But yeah, it's the same physiology, folks. All right. So these are the phases of sexual performance. Okay. So Masters and Johnson, they found out a lot of things. So after they got everything set up, let me just give you some summary of some of the things they found. Number one, women at that time, they polled women. They said, what do you think excites a man the most? And the most common answer was a naked woman. So women thought, if you just come on naked, that's what excites a man. It's okay, well, let's test it. So they had three groups of women. One, fully clothed women. Second, fully naked women. Third, the group was women just wearing their underwear. So, okay, let's try it out. All right. So they had probes, EEG, all kinds of probes around the skull, right? Fully clothed women came out. And they took a look at the men, and the probe was going on 30 or 40 seconds and then stopped. Okay, they said, all right, bring out the naked women. And the naked women came out. What do you hear? About 30 or 40 seconds. That was it. Died out. And they brought in the half naked women just in their underwear. Probably still going on right now. If you go to California, you'll see it. That's when they realize men like the fantasy of sex. It's not a naked body that excites a man the most. It's the fantasy of sex that excites a man the most. So you know what they did? They try to keep it a secret. And then too bad, somebody put it on the damn internet, man. And some lady named Victoria found it first. Now it's Victoria's secret, boy, I'm telling you. But Victoria's a man. Just so nobody argues with me about that. That's just for the joke purpose. It's a man who figured this out. He said, wait a minute. That means I can start a lingerie industry in America. There was no lingerie industry in America until after this research came out, because he saw the opportunity. If men are more turned on by a half-dressed woman, I can make a fortune by just half-dressing women. And so they came out with lingerie, which is a huge industry now in America. That was to satisfy the male. This is why in couples, if their love life is going stale, they always recommend like role playing. It's the fantasy of sex that excites a man the most. That's how you get him excited again. Okay. And dressing up in certain costumes and stuff. That's what excites a man the most. Not a naked body, like women thought. It's the fantasy of sex that excites a man the most. So they said, okay, let's look at sexual dysfunction. So now women knew how to excite men. What about sexual dysfunction? Okay. And then I'll do how to excite each side. Sexual dysfunction in young men, look at that, premature ejaculation. They call this performance anxiety. That's because if a young man is concentrating too much on what he's doing, he's going to feel anxiety. What's the first discharge from your brain if you're anxious, if you feel any anxiety? Oshni. Sympathetic or parasympathetic? She says parasympathetic. Parasympathetic, an erection. Remember point and shoot? He has a rigid erection. He's ready to have sex. He thinks I'm going to have sex all night, and then feels stressed. Shoot. Sympathetic. He ejaculates. It's over with. Performance anxiety. They got that one perfectly. Okay. I remember when my son was a teenager, listening to some of his friends talk one day, and I heard one of them talking about, yeah, man, if she's not saying, ooh, give me more after 5 minutes, that means you're not doing it right. I'm like, damn, man, you guys concentrate too hard on this. But that's what they thought. I said, that's exactly what Master John said. You guys are thinking too hard about it. The key is to relax and enjoy it. If you start thinking too much about the whole thing as a performance, then that's why you will feel anxiety. And that's why they ejaculate too fast. Okay. And then we call it premature ejaculation if you cannot hold an erection for at least a minute. Okay. Inside the vagina. So premature ejaculation was the main problem in young men. What about older men? So middle-aged men, stress-induced impotence. It was called climbing a corporate ladder. Well, if a man is stressed out about his job because his boss has got him doing three projects at the same time, he's stressed out. When he comes home, stresses out his wife. So it starts out with parasympathetic and the sex is still okay. All of a sudden you go into sympathetic and both of you are now impotent. She has no desire to have sex and he has no desire. He's impotent too. That's the stress. That's why they call it stress-induced impotence. The stress of climbing the corporate ladder. Okay. What about elderly? It's called vascular impotence. Makes sense. Atherosclerosis. Ischemia. Remember, an erection is engorgement with blood. Well, if you have plaques along the way, it cannot get engorged so fast anymore. That's why you get impotence. But look at this, folks. Atherosclerosis, decreased blood flow, makes sense to me. Takes longer to establish erection, makes sense as well. Harder to maintain erection, yep. Need for more direct stimulation, yep. And then long refractory phase. Now you see that part, need for more direct stimulation? Did you know that elderly people engage in more oral sex than young people? Now it's hard enough for people to envision their mom and dad having sex. For some reason that turns everybody off. Envisioning your mom and dad having sex, but they had to do something to get you, didn't they? All right, so I don't know why, but it turns a lot of people off to have that vision. Imagine grandma and grandpa getting in, oh, yeah, after midnight. That freaks come out at night. Freaks come out at night. That's grandma. Oh, you can't, you don't want that picture in your head. But grandma and grandpa be doing some freaky things, man. I had a 77-year-old man come into my office one time, and he had a indirectly inguinal hernia, as big as a baseball. And I thought, oh my God, I probably have to fix this. And I started thumbing through his chart. He's had it for more than 20 years. I said, okay, I guess no rush. He's had it for more than 20 years. Ain't bothering him at all. So I just happened to ask him the question. I said, does that bother sexual performance for you? He said, "Psh, no. I said, why you say it like that? He said, Dr. Vance, come here. He said, at the nursing home, I got 2 girlfriends. He said, I get it at least 4 or 5 times a week, man. This don't pose no problem. Like, what? I was like, oh my God, man, come on. 4 or 5 times at age 77. More than most guys get, even in marriage or single. Man was so sexually active, and that didn't bother him at all. So my point is, folks, nowhere on here do you see libido goes away. It does not. Performance goes away, but libido stays there. Okay, they still have the desire to have sex, but performance just goes away, so then they just don't have sex. But don't pick an answer that says libido disappears with age. It doesn't. Okay? Yeah, they do. They have sex other ways. A lot of people, especially young people like yourselves, you guys think sex is only vaginal penetration. There's a lot more to sex than that. All right? The elderly people realize vaginal penetration when her vagina is dry. They say, no, we're not going to do that. Let's just engage in oral sex. All right? Mutual masturbation. They do that all the time. And they enjoy a very active sex life. That's my point. That means it's only if you ask, then they'll tell you. They had one study, and you know the elderly people said, I don't know why my doctors never asked me about my sex life. They were pissed because they said, why does doctor think I'm dead? He never asked me about sex at all. Like I don't have sex anymore. This is somebody who was 80 years old, still sexually active. Okay, but the doctor had never asked him. The doctor just assumed she wasn't having sex. That's when they realized the hang up is on the physician's side, it's not the patient's. It's the physician, like I keep telling you guys. Doctors have a hang up about sexuality. I don't know why. I always say, feel comfortable with your own sexuality so you can talk about somebody else's. Our job is not to judge people for their sexuality. Just listen, okay, and educate. That I see as a prime role of physician. We educate. I don't care what anybody's doing. My job is to educate them how to stay healthy and do what they like. Okay. All right. So elderly, remember that. And then let's see the difference. Yes. No, I said libido is not the problem. Libido doesn't decrease that much as you age. You still have the desires, performance that decreases the most. Okay. Mabel, you have another question?
Yes, sir. I want to know if there's any medication for premature ejaculation.
Sure there is. You learned it already. What was it?
I didn't.
You learned it already. Mitchell, tell her. Yeah, BSSRIs, which cause anorgasmia, the opposite.
BSSRI or
SSRIs cause anorgasmia, the opposite of premature ejaculation.
okay.
That's why SSRIs are used for.
I didn't know that could have saved someone though. Okay.
Yeah. So you can advise somebody to get treated if that's the problem for him.
Okay. I could have treated my okay.
Okay.
My ex-boyfriend though.
Is that boyfriend now? Yeah. All right, folks. Now remember, try not to blurt out your business. I'll do the lecturing, so I'll do all the talking. Please don't let your business be known. All right, Pablo.
I'm joking.
Does propranolol work also for premature ejaculation since it's for performance anxiety?
No, the beta blockers actually just cause a lot more impotence. Yeah, so we don't use beta blockers. Yeah, but that's a good question. It doesn't work though. All right, so what's the difference between men and women? Here it is, folks. Men have a long refractory phase. That means it takes a lot longer for a man to get ready to have sex again, whereas women are ready to have sex at any time. Look at this. That's why women have a longer excitement phase. That's why, sorry, I think I said it the opposite. Men have a long refractory phase, but a short excitement phase. So because we have a short excitement phase, men are ready to have sex all the time. But women are not set up that way. Women have a longer excitement phase. That means they need more time to get excited. Then they can enjoy the sex, right? But they have a short refractory phase. This is why women can have multiple orgasms and literally just leave you out of the picture. Doesn't need you anymore. But that can happen. Women can have multiple orgasms, whereas a man cannot. So Master Johnson approached this as well. They said, what you need to do is understand what foreplay is. Do you know they're the ones who came up with foreplay? Foreplay was developed for the benefit of the females. Men don't need foreplay because men are ready to go all the time. But women need foreplay, what? Longer excitement phase to get them up that mountain. That's what it was about. So that's why men are then taught, you have to learn foreplay. It's not about you, it's about her. Because if you're always ready to go and you want her ready to go, but she's not, then there's gonna be a battle. All right, because some men are just so impatient. They ready to have sex with no foreplay, no sensuality, no nothing. And the woman says, no, I don't want that. I want foreplay, I want sensuality. Men are much more sexual, women are much more sensual. Right? That's why they say women are much more romantic than men. Because men start thinking, well, I don't need that. Yeah, you don't need it, but she does. So that means you have to learn how to play along. Okay? Because that way both sides get something out of this. Because if you're the only one, you climb that mountain. You get to the mountain, you go down the other side, you talk about we. She's gonna look at you and say, we what? What do you mean we? We, you. You're the other one who got something out of this. Now she's pissed off because she didn't get nothing out of it. You ejaculated way too fast. Okay? So you can say we, but she's not gonna agree with that. So the sex differences. So, but if everything goes well, you're going through the ejaculatory duct through your shoot out through the right. Well, to address premature ejaculation, this is also on your exam. Squeeze technique. This is retrograde ejaculation that you were asking about. Master Johnson came up with this technique. You can teach it to anybody in less than 5 minutes. Okay? All you do is gently squeeze the head of the penis. Once you squeeze the head of the penis, it starts gentle peristalsis that goes backwards. That means the sperm will go right back to the ejaculatory duct all the way back to the epididymis. That means for that man now, he is charged and ready to penetrate again. That means he can hold on to that ejaculation until she's ready. Remember, a man climbs the mountain too fast. A woman needs time. Like the train that could. I think I can. Yeah, she's got to climb slowly. So that means for the man, you got to be patient. Men have to be taught patience. All right. So that's why you got places like there's a place in Chicago called Sybaris. If you don't want to, or you don't know what romance is, they'll do all the romance for you. You just pay a bunch of money. They give you your own room. In the middle of the floor, there's a jacuzzi. They put rose petals from the door all the way to the bed for you. That way, romantic. They got music going on, the way, and they got two masseuses that come in. You get a massage, she gets a massage. See, that way for the man, he needs to relax. Because remember, relaxation is what? Parasympathetic. That's called a point. That means a good erection. All right. She's relaxed. You're relaxed. Guess what? Good sex. You never have to leave the cottage. They take care of everything. You have a butler for the whole weekend. Now, this is what I heard happens in Chicago. See? It's worth the damn money, man. Come on, fellas. All right. So that means if you don't have any ideas of what romance is, let them do it for you. All right. The woman will be happy with you. Okay. Because it's a whole weekend of romance planned for you already. You don't have to think about anything. They do the whole thing for you. Okay. But this way, they make their money off of couples that have been married for a while. This is how to kind of re-energize your sex life. Okay. So that's why I fit in that protocol. So I said, cool, let's try it. All right. But that's why they take care of everything for you. And it jumpstarts your sex life again. Because after a while, you've had children, both of you are working. All of a sudden you guys are thinking about work all the time or thinking about your children all the time. And the sex disappears. And then people start getting real angry at each other. And that's why they tell you that's the time you slow down and do something like that. Anyway, squeeze technique. You can teach in less than 5 minutes. Squeeze the head of the penis, retrograde peristalsis. Sends the sperm right back, which means that guy can reinsert and keep going until she is ready. Once she's ready and she lets go, then you can let go. Okay? So squeeze technique, easy to teach. Now, the book says, so I got to tell you that, she should squeeze the head of the penis. Let me show you why Master Johnson said that she should squeeze the head of the penis. Their whole theory was the cervix hangs down on an angle like this inside of her. When the head of the penis, when the man is ready to ejaculate, the head of his penis starts throbbing. That means the cervix will feel the head of his penis hitting it. And that's how she knows he's about to ejaculate. So she tells him, pull out. She squeezes the head of the penis, the sperm go back in, he can reinsert. That means he can hold on for an hour, 2 hours, whatever the hell she needs. That's what he's going to do. But again, You gotta have a man who's patient because a lot of guys are not that patient. So here's what I do. For couples that have been married for less than 5 years, I already know he has no control. She should squeeze the head of penis. After about 5 years, this is again my own experience, just working with couples. After about 5 years, the man becomes more in tune with his wife. He wants to make sure she enjoys sex now. In the beginning, he just wants to make sure he's getting sex. But after a while, he says he wants to make sure his wife is enjoying it too. So what's he do? A man can tell he's ready to ejaculate way before a female is ever going to feel anything. And that's because the muscles back here, way back here in the bladder, pelvic floor muscles, start contracting. They start throbbing before his penis starts throbbing against their cervix. So the man could actually stop this earlier. Well, when I went back to Master Johnson thinking, why didn't they ask the man to do this? They did ask the men to do it. The problem was the men enjoyed ejaculation so much, they never did it on time. So according to literature, they gave it to the more responsible gender, women. So anyway, just so you know, on your test, you're gonna say, yeah, the woman should squeeze her head of penis. But in real life, just modify it. Under 5 years, let her squeeze, but after 5 years, make him do it. Okay? That way it's his responsibility, and they will do it. Okay? And usually couples are so happy when you teach them something like this. Let me just tell you my own experience with couples. They love it when you are a doctor who feels comfortable to discuss sexuality, because lack of sexual satisfaction, number 2 cause of divorce in America. This is not a small topic, folks. Just so you know why I separated it. All right. Otherwise, I could have just done it with endocrine and just skipped a whole lot of things. I said, no, there's too many questions on this stuff. I want you guys to hear the whole story from beginning to end. All right. So that's why we as doctors, the literature says doctors should get more involved, which means when you see somebody for their annual checkup or a couple for the annual checkup, you should bring that topic up. Okay. And you take the weight off of whoever has the problem, they take it off their shoulders. They're happy you brought it up. But all of a sudden, both of them will discuss with you. And let's say if the wife is the one dissatisfied because he has premature ejaculation or he's impotent. So now you bring it up the situation for young couples, it's premature ejaculation. So I say, most couples, about 95% of men your age. Now you guys been married how long? 3 years? Yeah. Most men, 95% have a problem with premature ejaculation. Nothing to be ashamed of, but it's a very common problem. You should see initially he starts out uncomfortable till he hears me say 95% of men have the same problem you got. All of a sudden you say, what? All of a sudden he realizes all his friends are lying. That's what it does. It lets him off the hook because he thinks he's the only one with the problem. And most young men have the same problem. When you put a survey underneath the door and they start telling the truth, that, yeah, they've had the problem, but they would never tell their friends that they had that problem. Okay. But once you bring it up, he feels okay because you said 95% of men. And guess what? The wife, you should see how relieved she feels that you brought up the topic because she's been dissatisfied, but she doesn't want to stress him out. Now, women are much more in tune with their husbands than vice versa. I'll give them credit for that. Okay. So the problem is she knows if she stresses him out, the problem gets worse. Everybody understand? Stress is the problem, right? So if you stress him out, guess what? It'll get worse. So that's why she just decides not to say anything. But at the whole time, both of them are dissatisfied with sex. They're not having enough of it, so the wife is dissatisfied. And the man is dissatisfied because he's stressed out because it's going to happen again if he tries to have sex with his wife. Okay? So something for us to help out. All right. Premature. Yes. Oh, just a gentle squeeze for like 3 to 5 seconds. Yeah. All you got to do is squeeze the head of Mabel.
Sir.
Another ex-boyfriend problem here. She started cracking up now. Okay, what's your question?
Sir, please, I wanted to demonstrate how to squeeze the head of the penis.
Oh, God. Mabel.
Yeah, we can save a soul or even save ourselves. You can never know.
I need a drink, man. She gonna drive me to drinking for sure. She gonna drive me to drinking, man. I'm trying to stick to Mountain Dew. You gonna have me drinking alcohol, Mabel? So I demonstrate the squeeze technique. Good Lord. I ain't got that much dedication to education. There are limits there. What Dr. Francis will do. So anyway, squeeze technique. That's all you need to learn. Moving on. Once the sperm is deposited in the vagina, sperm hide underneath the semen. Remember, protect themselves from the acidosis. Okay? Bile covers then released to neutralize lactic acid. Zinc is then used for the capacitation reaction. Fructose is then clicked in for energy. All this is happening within seconds. And the sperm take off. Okay? 70% of sperm though are dead before they reach the cervix. 70%. So let's say there's 200 million. Oh my goodness. That means 140 million are dead before they ever reach the cervix. You know what the remaining do, Josh? You stop for a moment, pick up a 40 ounce. For the homies, you're gonna make the rest of this trip. Then you hear that song start playing. How do I say goodbye? But the light is up, but the light. But the homies ain't gonna make this trip. So all the sperm, they're dead, sorry. And the rest are gonna go on without them. All right, so acid phosphatase, they used to eat through the cervical mucus. Remember, the cervical mucus is thick right now. You gotta eat right through there. So here's, oh, wait a minute, I think, yeah, let me go through the rest of it first. Sperm then enter the uterus. Once they enter the uterus, they run into another problem. There's a fallopian tube on the left, fallopian tube on the right. And they're like, wait a minute, they didn't tell us there's 2 ways to go. And there's another half who will never see that egg because the egg is on one side. So they split up into 2 halves. Whoever picked the wrong side, you ain't gonna make it because you're gonna run out of fructose and there's no egg on that side. This half will see the egg. By the time they get to the egg, folks, there's only a few thousand left. Did you hear what I just said? From 200 million, only a few thousand ever reach that egg. That's just amazing. That's why they say, if you don't have at least 200 million sperm per ejaculate, the chance you're going to fertilize the egg is less than 1%. It's not impossible, but it's not very possible either. Okay, less than 1% chance. 200 million. So that by the time they die out, okay, if 3,000 reach that egg. But if you don't have at least 200 million, 3,000 is not going to get near that egg. All right, they swim through the fallopian tubes. By the time the sperm reaches the egg, only a few thousand are remaining. Sperm then surround the egg. So here's the ovum. Here's the corona radiata, remember, radiant like the sun. This clear area in the middle is called zona pellucida, which really just means clear area. That's where the sperm heads are trying to get to. So here comes the sperm, they surround this egg. I'm just going to draw a few of them like that. And what they do, they dart in and dart out. When they dart in, Miguel, they open up their sperm heads and release a bunch of enzymes to start eating away at this tissue. That's called acrosomal reaction. Sperm heads dart in, open up their heads, release a bunch of enzymes. Remember the acid phosphatase and hyaluronidase to eat through this tissue. And then they dart back out. They wait till there's actually an opening to get in there. Once an opening occurs, the sperm then come in here. So let's say here's the first sperm head to get in. As soon as he gets in here, a wall will form around him and that ovum. See that? Once that happens, that ovum then finishes meiosis 2. Remember, still stuck in metaphase of meiosis 2. She will finish meiosis 2, release the second polar body, and now fuse with that sperm. Now you have 46 XX or XY. Yep. And that's exactly where you want to be. All right, so the fact that a wall forms around the sperm heads and the ovum is called a crystallization reaction. All right, so you got capacitation reaction, peeling the semen off the sperm. That's before they even start moving. You got the acrosomal reaction, sperm heads release digestive enzymes to eat through the corona radiata. And then you got crystallization reaction, forming a wall around one sperm, one egg. Well, it's conceivable, Saba. It is conceivable that 2 sperm are running at the same speed. Just running at the same speed. That means slide in there at exactly the same moment. If they slide in at the same moment, guess what? A wall will form behind the 2 of them. Now you got 2 sperm fusing with 1 living egg. That's how you get an incomplete mole. Remember, complete mole was 2 sperm that fused with an egg that was dead. So there's no maternal genes to incorporate. An incomplete mole is 2 sperm that fused with a living egg at exactly the same moment. Again, rare, okay? But this one, what? Oh yeah, this one has maternal and paternal genes, which means that you can make a baby out of it. All right, 69XXY. Notice 3 sets. 69XXY is the most common. And notice again, 2 X's, 1 Y, because X's are stronger than Y's. Remember, 46XX was most common for complete mode. Now, if I got 3 sets of genes here, it doesn't mean everybody's going to be Klinefelters. That's what it sounds like, XXY. What'll happen is 1 X and a Y will slide over like that. Then you got a ball of molar tissue next to it. Or the 2 X's will slide over together. Now you got a girl, you got a ball of molar tissue next to her. But that only happens 1 to 3% of the time. Because anytime you mess up chromosomal count, remember, most times it dies. So you're not going to get normal babies. So what happens? That's only 3% of the time. The other 97% of the time, you get fetal parts, which is what Solange was saying. You get an arm, that's it. Look in there, there's a toe, and that's it. You look in there, there's an ear, and that's it. So anytime it's just fetal parts, you got to scrape it all out as quickly as you can. Remember, if just fetal parts, there's no wall. Mom is going to recognize there's these are in there, and she's going to attack the whole thing. If mom attacks the whole thing, what happens afterwards? She now has antibodies against herself because she killed the whole thing. This actually happens in a lot of women. How did we find out? With PCR, somebody spun. They took mom's blood and spun it, I don't know, 2 million, 3 million times. It's called cell-free DNA analysis. So it's PCR. By spinning it, they found 1 fetal cell at the bottom. And they said, oh my gosh, fetal cells do circulate through mom. We didn't know that. Very few, but they do. And that's why mom will attack it and make antibodies against herself. Everybody understand that? Years ago, I used to ask myself when they said every autoimmune disease is 8 to 10 times more common in women than men. And I said, why would it be that prevalent in women, not men? I said, it's got to be that mom is attacking who's over there. That's mom, that's dad, and then she actually has to attack herself. But I could never prove it because no evidence ever showed fetal blood actually makes it over to mom, or fetal cells make it to mom till PCR came out. I said, I knew it. So I was so happy when I saw that. So now this is the earliest way to diagnose genetic disease in utero now. Remember, amniocentesis, 16 to 20 weeks. 5 months of worry? Nah, nobody uses that anymore. But CVS, chorionic villus sampling, you have to wait till 12 weeks. With cell-free DNA analysis, you can do as early as 10 weeks. And with that 1 cell, you can do all genetic testing that you want. Figure out every disease that baby has. So that's now the standard of care. Because no harm to the fetus, no potential harm to the baby at all. Just take mom's blood. Okay? All right. So a zygote is formed when 1 egg, 1 end, and the sperm, 1 end fused together. Now you have 2 ends, the beginning of a normal baby. The stages they want you to know. Zygote is a 2-cell stage. That's the first stage I just described for you. 90% of fertilization occur in the ampulla. That's a wide part of the fallopian tube. It must now migrate through the fallopian tubes all the way to uterus. So you can imagine, therefore, if there's any scar anywhere at all. See that? Ectopic. That's why 90% ectopics occur in the fallopian tube. Now you know why. So sudden adnexal pain in any female of childbearing age is ectopic until ruled otherwise. You got to move fast because that baby's going to burst that fallopian tube and bleed everywhere, and that might kill mom too. Morula is a 16-cell stage. It's the stage that enters the uterus. Blastula is the cell stage that implants. So that's why they want you to know these 3 stages. 256 to 512 cell stage is the stage that implants. So they'll ask you what to call it when they implant. So zygote when you fertilize, and morula when it enters the uterus, and then blastula when it implants. Now, from the time you fertilize the egg till the time it implants, takes 7 to 8 days. Just a week. Well, that means, Maria, if you ovulate on day 16, let's say we're picking a number, and that egg can live 16, 17, day 18, right? 3 days. That means it gets fertilized, and then 7 or 8 days later, what are we up to? Day 24. That means in 4 more days, the lining will slough off, day 28. That means if they ask you, what is the first role or most important role of HCG? That's how you remember that. Keep that corpus luteum producing progesterone. Because if you don't, the lining will slough off and the baby will abort. That's what a spontaneous abortion is. So the number one role of HCG is to maintain the corpus luteum production of progesterone, to maintain that lining so that baby has blood supply, remember the coronary arteries, and food, lipid and glycogen deposition until he establishes his own placenta. 1 week after fertilization, Amy, HCG shows up in the blood. It takes an additional week to show up in the urine. So all the home pregnancy tests are based on 2 weeks ago is when you got pregnant. All of them. They all have the same sensitivity. In fact, they all use the same reagent. I remember an article years ago that said, hey, doctors, tell your patients to get pregnancy tests from the dollar store. You know, the dollar store had the same reagent as EPT or first response, all these over-the-counter one that's, you know, $30, $40. They said, no, buy from the dollar store for $1. Same reagent, same accuracy. Okay. Any questions on the 3 stages? All right. Let's implant. Formation of the placenta. Here's what happens. When the baby's coming down, we call him the trophoblast. Mom's endometrial wall, it's called a cytotrophoblast. When they come together, now you call it syncytiotrophoblast. Remember, syncytia means together. That means the 2 layers just come together. Syncytiotrophoblast is the beginnings of your placenta. Any questions so far? Implantation usually occurs in the posterior wall of the uterus in the majority of cases. That way it gives the baby plenty of room to enlarge coming to the front. Implantation occurs posterior wall majority of times. Gives the baby plenty of room to expand. What if he doesn't implant the right way? There's always something that can go wrong. First problem, if the baby does not implant the right way, it may implant right over the cervical os. That means it fell, and rather than going to the back, it just came straight down. Here's the cervix. Yeah, like that. So we call that placenta previa. So things that can go wrong. Placenta previa means implantation over the cervical os, which means, Jess, when it close to labor, as soon as that cervix starts opening up a little bit, you're actually ripping the arteries of the placenta. So this is the most common cause, the most common cause of painless 3rd trimester bleeding. So any woman pregnant, 3rd trimester, bleeding, no pain, this is your answer. And of course, you just verify with an ultrasound. But just so you know, they're just asking what's the most common cause, placenta previa. The ultrasound shows it's over the cervical os. If it covers more than half the cervical os, you have to plan to do a C-section. That means whenever she actually does go into labor, you do a C-section. That baby can't come through there. There's not enough room. Placenta previa. Any questions on how to manage it? Well, then there's one called vasoprevia. That means a blood vessel from the cervix, all right, from the placenta. So here's the cervix again. Oh, let me zoom in a little bit here. All right, so here's the cervix of the female, okay? That means it's like this. And now you got the artery, placenta artery hanging through like this. That means if that placenta artery is just hanging there, guess what? It can wrap around the neck of the baby if he tries to come through there. So placenta previa. Vasoprevia. You have to worry about strangulation of the baby. Again, plan on doing a C-section when she goes into labor. The other problem is, if the OB didn't know this, you know how they try to break the water with that instrument? A real sharp instrument. What if they just reach in there and slice? They'll slice that artery wide open. The baby would bleed to death. That's a bad outcome. All right, so that's why we like to diagnose these way ahead of time. That way you know, you got to do a C-section. You can't let this baby come through there, and definitely you're not going to try to break her water for her. That's vasoprevia. and the other one is called abruptio placenta. An abruption is a torn placenta. So this hand is the baby, yeah. And then this hand is the endometrial wall. The baby normally does that. He's the one that moves. The wall doesn't move. Okay, they come together. If all of a sudden that placenta tears, there's a blood clot. Now there's a blood clot between the baby and the wall. Everybody see that? That baby is now separated from his blood supply. So what do we do with abruptio? First, how do you recognize it? Is the main painful third trimester bleeding. So if the woman has a lot of pain with her bleeding in the third trimester, it's abruption. So first you got to make the diagnosis. And then of course you verify with ultrasound. And here's the management. If they're already in labor, the baby's already on his way down, let the baby come on out. Because we need to get him out of there. Don't stop labor. That'll just take more time. They said, no, let him come on out. All right. As long as the monitor says he's doing okay, let him keep coming. Okay. But what if the baby's not fine? So that means if mom is not in labor and you got abruption, then you need to get that baby out of there as soon as you can. That means we hook up the monitor and you see fetal distress, C-section immediately. Because remember, he's separated from his blood supply. There's no reason for you to wait. Okay. You only let the labor go if she's already in labor and the baby's on his way down. But if she's not in labor, you got to do a C-section, get the baby out of there. Because he's separated from his blood supply. So anytime there's significant abdominal trauma, like mom was in a car accident, that's a concern. And anytime we have abruption, if mom is Rh negative, you got to give RhoGAM right away. Because there's a chance fetal blood went across. She's primed now. She's sensitized. And if you don't do something, she will kill the baby. Because you give her time, she'll form antibodies and attack the baby. So abruptio placenta. Any questions on that? All right. When the mom is in labor, we will always want to make sure that she's able to stop herself from bleeding. So postpartum hemorrhage is a big problem. This is why we say, moms, do not take aspirin and NSAIDs throughout your pregnancy, but especially after 9 months, don't do that. Because we don't want her to be anticoagulated in any way in that 9th month. That's after 9 months. So what about the situation where mom has a history of preeclampsia that was severe? Because you got to put on aspirin, right, Jess? That's why you're shaking your head. I can tell you're thinking about that. You have to put on aspirin. The rule is put on aspirin, but wait till after 12 weeks. Why? So the brain is fully formed. Because if you bleed into the brain, that's it. The baby's dead. Okay, so we wait after 12 weeks, start on aspirin. As soon as you hit 9 months, they say stop the aspirin and put her on unfractionated heparin, because if she starts bleeding, we can reverse it right away with FFP, and therefore she doesn't bleed. Because we don't want anything else. You know, none of the NOACs, DOACs, any of those. The bigger, I mean, direct thrombin inhibitors, factor 10, no, they said no. All of them got to be, no, not during pregnancy. Okay, heparin, unfractionated heparin is the only one you can safely use because you can reverse it within seconds. Okay, if she starts bleeding. So postpartum hemorrhage. Why are we so afraid of postpartum hemorrhage? Because if you open her up from the bottom, all the blood from the brain drains straight down, right? Throughout the whole pregnancy, there's a lot of blood flow going to her pituitary because all the hormones are being synchronized. Going to her hypothalamus, going to her brain in general. All that blood would drain straight down to her vagina if she starts bleeding, and then she will lose what? Her pituitary. That's how she-hands first occurred. So let me just call it panhypopituitarism. Panhypopituitarism. She-hands, or this was she-hands, is the same thing. She-hands is only when it happens in postpartum women. All right, otherwise, the most common cause of panhypopituitarism is a car accident, trauma. When somebody doesn't have a seatbelt on and they get thrown forward, their face goes right to the windshield, the glass cuts right above the nasal bridge. There it is, you just lost your pituitary. That's the #1 cause. Yes, sir. Apoplexia, yeah. You lose your pituitary instantly because you just cut off all the blood supply. If you remember, the blood supply for the pituitary came down from the hypothalamus. So if you just sever those arteries, that's it, it's gone. So somebody did a study on panhypopituitarism to see what order do these hormones actually disappear. The first one to disappear was prolactin, which makes sense. That's why she hands. It presents with, hey, I don't have any breast milk coming out. Any postpartum woman that says I got no breast milk, you got to work them up for she hands. Because breast milk is usually dripping out by the time the baby comes out. So there's no need to wait for anything. Prolactin, the first hormone. So for she hands, lack of lactation is how they will present. But if you're an adult who's not pregnant, you don't even know you lost your pituitary. The second hormones to be lost, FSH and LH. So outside of she hands, the most common presentation, secondary amenorrhea for the female because FSH disappeared. Impotence and decreased libido for the male because his LH disappeared. So that's how they'll present in the male or female. After that, ACTH will disappear. No, TSH, sorry. TSH is the third one to disappear. Notice the permissive hormone under normal conditions, and then ACTH is the last one to disappear. The stress hormone the permissive hormone under stress. Notice how your body holds on to the two permissive hormones to the end. You understand, Rachel? Notice, therefore, why those are the two hormones you have to replace before she even leaves the hospital. Again, it's got to make sense for you to remember it. You cannot live without these two hormones. That's the only two you have to replace before she leaves the hospital. Start on thyroid, start on cortisol. And what steroid do we use to take the place of cortisol, Mabel?
What do you say, sir?
Oh boy. I said, what steroid takes the place of cortisol? You learned it.
Yeah, I did. What's steroid? I can't remember.
All right, Leslie.
Hydrocortisone.
Hydrocortisone is correct. Remember, fludrocortisone takes the place of aldosterone. Hydrocortisone takes the place of cortisol. So you have to put mom on thyroid hormone and some cortisone, hydrocortisone. Any questions on that? All right. One more problem.
So I have a question, please.
Hang on, maybe let me just do these three things because that's the last things. All right. So what if this placenta implants the wrong way? No, placenta should implant on the surface of endometrium. It's called AIP. Let's say AIP implantations. If the placenta implants all the way through the endometrium, that's accreta. They go in alphabetical order. That's why I call it AIP. That way I don't forget what order they go in. So the implants all the way through the endometrium, that's accreta. If it implants all the way into the myometrium, that's increta. And if it implants all the way out to the periphery, which is serosa, that's how I remember percreta for periphery. So percreta. Now, how do you know you have one of these? Because otherwise we make the diagnosis on autopsy. Well, that's not autopsy, on pathology. Because you have to cut the uterus out. Autopsy means the person died. They don't have to die, okay? But it's just pathology. You have to take the whole uterus out. So accreta. Once the baby's delivered, the placenta should deliver within how many minutes, Anna, do you remember? 30 minutes. That's in every pregnancy. It doesn't take long. Which prostaglandin causes the ischemic effect, Michael? Not E2. Rachel. And Cynthia. F. F is the vasoconstrictor. So F cuts off the blood flow to the uterus and lining, and then it slides right off. Within half an hour, it's out already. So anytime it takes more than half an hour, that's how you know it's one of these. What do? Stick a couple of fingers in there, and you try to milk it out. Don't ever pick the one that says pull it out or yank. We don't pull and yank. You just try to milk it with your fingers, just sliding like this. Because if it's accreta, maybe half of them will slide out if you just run your fingers underneath it, okay? But if it does not slide out with your milking it, hysterectomy. Yeah, hysterectomy. You gotta cut the uterus out. Hysterectomy. Cut. Fundal massage does not work for these. These are attached. Massaging the uterus does not make this come off. That's after you get this out. I mean, that's why they say, get the whole thing out of there. So let me give you again, here's the recommendation, so everybody understands it. You try to milk it out, because if it's a Creta, half of them will slide out just by touching it, okay? But if it does not come out easily, they say, don't ever pull or yank, because you're gonna cause heavy bleeding. You might kill the mom if you did that. That's why they said, do a hysterectomy. That is the answer, hysterectomy immediately, because you wanna cut out the whole uterus with that placenta attached to it. Because Mary's got so much blood around it. You pull, she's gonna bleed. Yes. Other half of what? That's what I'm saying. If you're able to milk it out, you can, the uterus can stay. But the other half where you cannot milk it out, and definitely Creta per Creta is not coming out. You got to do a hysterectomy to follow. Automatically, you must do a hysterectomy. Remember, is doing that to save her life. We know what happens if you pull on that placenta. Most of them will bleed to death. So we don't gamble with her life. You just don't. Okay, Mabel, your question now.
Yes, sir. It's not a serious question like that. Please, sir, you said that that steroid, the hydrocortisone take the place of cortisol. You now
Correct.
said that another one take the place of fludrocortisol, right?
No, fludrocortisone takes the place of aldosterone.
Okay.
Yeah.
Thank you.
Yeah, this is all in your endocrine notes already. Shri.
Yes. So when you milk or like massage the placenta and you said half comes out, what about the other half? Like,
No, that's what somebody was just asking. I'm not saying that only half the placenta came out. I meant half the time the placenta will slide out after you start milking it.
oh,
Not
okay.
that half the placenta comes out. No, half the time the placenta will slide out easy. Then no problem. She gets to keep her uterus. But the other half where the placenta does not slide out easily, and definitely with increta and percreta, you're not going to be able to slide it out. We go straight to hysterectomy. Cut out the whole uterus to save mom's life, just so you understand, which means in the past, we used to try pulling it out and they would die. I mean, they would die because there's so much blood in the uterus. And last point, and then we'll finish for the day, postpartum hemorrhage. Now, remember I said she hands because of postpartum hemorrhage. How do you even deal with it? What do? The first thing we do is bimanual massage of the uterus. You're trying to get that uterus to snap back into shape because uterine atony is the #1 cause of postpartum hemorrhage. Uterine atony is the most common cause of postpartum hemorrhage. So you want to get the tone back. So you do bimanual massage. That doesn't work. Then use oxytocin to try to get this thing to get some tone, and then boom, prostate F will cut off the blood flow again. Okay. But that's why we don't want any anticoagulants or any bleeding disorders and not be treated. Remember, heparin is the only one we use in a pregnant woman. If you're going to use aspirin, stop it at 9 months. All right. So in the morning, then I'll go through all the hormones of pregnancy and move right into immuno, folks. We're getting there, almost done. All right. See you tomorrow.
Please, sir.
Mabel, do you have a question?
Yes, sir. Please, what did you say about accreta and increta, please?
What did you hear?
I didn't hear anything. I just heard about
God.
increta.
I tell you, we got to fix that mic of yours. So I said increta and percreta are automatic hysterectomies to follow because you can't pull them out. They're so firmly attached. The woman would bleed to death if you did that. Did you understand that?
Yeah. You said that the hysterectomy is done, right? For
Yeah,
both
you
of
got to
them.
do hysterectomy on that woman.
But how do
Right.
how do I identify how do I identify each of them?
Only by pathologies. After you do the hysterectomy, then the pathologist will tell you which one it was.
Okay.
That's why I said the first thing you try to do is milk it out. Only the cretas, half of them will milk out easily. That's why if you just put a finger in there and you try to slide it out and it slides out easily, then it definitely was a creta. But the other half that won't pull out, you don't yank or pull. And definitely all the incretas and percretas, you cannot pull. We go straight to hysterectomy.
Okay, thank you.
All right. You understand so far, Karan?
Yes, I
Karan Miller?
understand.
All right, good. All right. You have a question? Are you doing good?
No, I don't have a question. I'm doing good.
Okay, excellent.
Thank
All right,
you.
excellent. All right, Jolita, do you have a question?
Yes, I have a question. Is the woman mutilation a common problem in Nigeria?
No, we don't do female circumcision like they do in, I think it's Middle East, where they do that. We don't do that in Nigeria.
Okay, thank you.
No, the bad thing that women object to is that whole, they blame the woman anytime you haven't had a baby in 2 or 3 years. And why, and when the man goes to marry somebody else just to have a baby, of course, the first wife gets pissed off, but he can. All right, so we'll see you guys in the morning.